to order. The clerk will call the roll.
Click.
Present.
Campos.
Present.
Jaton.
Here.
Johnson.
Here.
Jones of Harris.
Present.
Jones of Dallas.
Present.
Oliverson.
Here.
Price.
Here.
Smith.
Here.
Tinderholt.
Present.
A quorum is present. Good morning, everyone. I anticipate a great number of people wanting to testify today. As per the committee posting, I will limit the testimony time and number of witnesses to ensure consideration of posted and pending business, especially if testimony would cause the hearing to extend into the next calendar day. I'd like to inform everyone that the public comment portal opened when the hearing was posted on Wednesday afternoon. I will direct the clerk to keep it open until Friday at 5 p.m. for any bills that have witnesses we are not able to hear today. Any Texas resident is welcome to offer their comments on the portal. Each member of the committee is able to view the comments as they are posted. The comments will be posted and available on each bill's webpage after the portal is closed. I'm committed to open, transparent, and participatory government. It is my responsibility to balance that with the health of my committee members. I've reached out to both sides of the most contentious bill, which we will take up this afternoon, to ensure committee members receive the information that each side determines is most important first. It's not healthy to go without proper rest. With the stresses of sessions, it's vitally important to maintain the healthiest lifestyle as possible, including getting adequate sleep. It's my intention to adjourn the hearing by midnight. As a reminder, if there's anyone who wishes to testify on any of the bills that we're going to be hearing today, you must register on the electronic witness affirmation kiosks located outside the hearing room before you testify, and indicate each bill that you would like to testify on. There will be an overflow room set up in room E2030 as needed. Now we're going to move to some bills that we're going to vote out. The chair calls up HB 299 as pending business. The chair offers a complete committee substitute. Members, this is Representative Murr's bill related to voluntary accreditation for recovery housing. The substitute removes referral limitation and makes it applicable to NARR affiliate accredited recovery homes only. Is there objection to the adoption of the committee substitute? The chair hears none. The substitute is adopted. Representative Johnson moves that HB 299 as substituted be reported favorably to the full House with the recommendation that it do pass and be printed. The clerk will call the roll.
Click.
Aye.
Campos.
Aye.
Jaton.
Aye.
Johnson.
Yes.
Jones of Harris.
Aye.
Jones of Dallas. Oliverson.
Aye.
Price.
Aye.
Smith. Tinderholt.
Nay.
There being 9 ayes and 1 nay, the motion prevails. The chair lays out House Bill 576 as pending business. Members, this is Representative Raymond's bill relating to the confidentiality of certain autopsy records. Are there any questions? Representative Jaton moves that HB 576 without amendment be reported favorably to the full House with the recommendation that it do pass and be printed. The clerk will call the roll.
Click.
Aye.
Campos.
Aye.
Jaton.
Aye.
Johnson.
Yes.
Jones of Harris.
Aye.
Jones of Dallas. Oliverson.
Aye.
Price.
Aye.
Smith. Tinderholt.
Aye.
10.
There being 10 ayes and 0 nays, the motion prevails. The chair calls up House Bill 1106 as pending business. The chair offers up a complete committee substitute. Members, this is Representative Goodwin's ACU detox bill. The substitute removes the requirement that the Texas Medical Board develop continuing education. Is there objection to the adoption of the committee substitute? The chair hears none. The substitute is adopted. Representative Tinderholt moves that HB 1106 as substituted be reported favorably to the full House with a recommendation that it do pass and be printed. The clerk will call the roll.
Oh, okay.
Click,
Aye.
Campos, Jeton,
Aye.
Johnson,
Yes.
Jones of Harris,
Yes.
Jones of Dallas, Oliverson,
Aye.
Price,
Aye.
Smith, Tinderholt,
Aye.
10.
There being 10 ayes and 0 nays, the motion prevails. The chair calls up House Bill 1488 is pending business. The chair offers up a complete committee substitute. Members, this is Representative Rose's sickle cell healthcare improvement bill. The substitute clarifies the National Clinical Practice Guidelines, follows the task force recommendations, and extends the task force 10 years. Is there objection to the adoption of the committee substitute? The chair hears none, and the substitute is adopted. Representative Alverson moves that HB 1488, as substituted, be reported favorably to the full House with a recommendation that it do pass and be printed. The clerk will call the roll.
Click,
Aye.
Campos,
I'm sorry, number?
1488.
Aye.
Jeton,
Aye.
Johnson,
Yes.
Jones of Harris,
Aye.
Jones of Dallas, Oliverson,
Aye.
Price,
Aye.
Smith, Tinderholt,
Aye.
There being 10 ayes and 0 nays, the motion prevails. The chair calls up House Bill 1890 as pending business. The chair offers a complete committee substitute. Members, this is Mr. Jeton's Hospital at Home bill. The substitute is a ledge council draft and changes the effective clause. Is there any objection to the adoption of the committee substitute? The chair hears none, and the substitute is adopted. Representative Campos moves that HB 1890, as substituted, be reported favorably to the full House with a recommendation that it do pass and be printed. The clerk will call the roll.
Click,
Aye.
Campos,
Aye.
Jeton,
Aye.
Johnson,
Yes.
Jones of Harris, Jones of Dallas, Oliverson,
Aye.
Price,
Yes.
Smith, Tinderholt,
Nay.
9-1.
There being 9 ayes and 1 nay, the motion prevails. The chair calls up House Bill 2767 as pending business. Members, this is my pharmacy bill. Are there any questions? Representative Campos moves that HB 2767 without amendment be reported favorably to the full House with a recommendation that it do pass and be printed. The clerk will call the roll.
Click,
Aye.
Campos,
Aye.
Jeton,
Aye.
Johnson,
Yes.
Jones of Harris,
Yes.
Jones of Dallas, Oliverson,
Aye.
Price,
Aye.
Smith, Tinderholt,
Aye.
9-1.
There being 9 ayes and 1 nays, the motion prevails. Thank you, members. We can now start our new business. Out of respect for each of you and in an effort to hear from as many people as possible, move efficiently through the agenda. There will be a 3-minute time limit on witnesses after the author lays out the bill and provides an expert witness. If you are here to testify, please be succinct as possible and try not to repeat what witnesses before you may have said. I and all committee members appreciate the sacrifices many of you have made to be here today to be heard. On behalf of the committee, I'd like to personally thank you for taking the time out of your busy schedules to be here. We realize it's a personal sacrifice that may include, among other things, travel and time off from work, along with sharing personal experiences. We do appreciate your involvement. As a reminder, if you intend to testify, please register on the electronic kiosk outside the door. There will be an overflow room set up in E2030 as needed, where you can watch the proceedings. In an effort to move as smoothly as possible once the author and expert witnesses give their testimony. I will call witnesses up 3 at a time. There is an audio delay in the overflow room. When you hear your name called, regardless of whether you were in the room or in the overflow room, please make your way to the front row of room E2036 so that you will be on deck and available to testify with the least amount of transition time. Again, we appreciate you being here. The chair lays out House Bill 1771 and recognizes Representative Price to explain the bill.
Thank you, Chair Click and members of the committee. I appreciate the opportunity to bring up House Bill 1771. This is a bill requiring standardization of rules relating to telemedicine, telehealth, and teledentistry records. Although remote telehealth care or healthcare services were not new to Texas, the COVID-19 pandemic escalated their utilization. Telemedicine, teledentistry, telehealth continue to allow health professionals to see, diagnose, and aid patients across the state. Today, families and individuals in varied communities and of all ages take advantage of remote healthcare services to visit their healthcare providers to receive a variety of services. Right now, record keeping is all over the place. There are no uniform standards. House Bill 1771 addresses the need for state agencies with regulatory authority over health professional boards to adopt standardized rules to ensure providers properly collect and retain documentation of patients' consent for remote services. There is to be a committee substitute, which was not ready for the hearing today, which will add language to the bill to ensure that the adopted rules address specific consent documentation for remote services and to include provisions based on the appropriate standard of care for consent documentation in an audio-only format. It's a very straightforward bill, as you can see. I appreciate the opportunity again to lay it out, and I would answer any questions now and request the ability to close.
Questions, members? Looks like there's no questions. Okay, we're going to begin our public testimony. The chair calls Nora Belcher.
Good morning.
State your name, who you represent, and your position on the measure.
Certainly. Good morning, members. Chair Click, Representative Price. I'm Nora Belcher, CEO of the Texas eHealth Alliance. I want to thank you for giving me just a minute today to talk about why House Bill 1771 got on our radar and why it's important. I know we all want to forget what the early days of COVID were like, but I'm probably never going to forget. We certainly did not expect to have to pivot that quickly to that much virtual care. Over the years, this committee's done a great job moving telemedicine forward on the clinical policy side, but we have not kept up on the documentation and practice policy side the way that we need to. So all we're asking in House Bill 1771 is to have a set of policies and procedures for documenting things like consent to treat, consent to share data that support the virtual care modalities, and that does include audio only. Those decisions should be left up to the boards. But the legislature taking a position on this will go a long way to making sure that both the providers and the patients are protected. And with that, I'm happy to answer any questions.
Members, any questions for the witness? All righty. Thank you for being here.
Thank you all very much.
Is there anyone else wishing to testify on for or against House Bill 1771? Chair recognizes Representative Price to close.
Thank you, Chair Click. I ask for the committee's favorable consideration, and I close.
If there's no objection, House Bill 1771 will be left pending. The chair hears no objection. House Bill 1771 is left pending without objection. The chair lays out House Bill 2059 and recognizes Representative Price to explain the bill.
Thank you, Madam Chair. Thank you for allowing me the opportunity to bring up House Bill 2059 that maximizes the use of funds already allocated for the mental health first aid program, prevents funds from lapsing, and expands the list of persons permitted to participate in the program. The mental health first aid programs offered throughout the state by local mental health and local behavioral health authorities in an effort to help people identify, understand, and respond to signs of mental health concerns and substance use disorders. The authorities provide the training. Originally, legislation permitted the mental health first aid training course to be provided only to public school educators. Over the past few sessions, the legislature has broadened participation to allow the inclusion of additional school district employees and university employees. Monies are already appropriated for this initiative, but statutory reimbursement limitations don't allow for the maximization of the use of this funding. House Bill 2059 will maximize the use of the allocated funds. The bill will also allow for more individuals to participate in the training, but not at any additional expense to the state. Additional program eligible participants by and through House Bill 2059 include youth, first responders, child care facility employees, private and charter school employees, and judges and attorneys. Increased participation will enhance the awareness of signs of mental health concerns and substance use in our communities. There will be a committee substitute, again, which was not ready for presentation today to be brought up at the hearing. It will make non-substantive changes for clarity about participants in the mental health first aid course program. I'm happy to answer any questions. With that, would like the ability to close.
Members, any questions for Representative Price? Okay, and we show no witnesses signed up to testify. Is there anyone else wishing to testify on, for, or against House Bill 2059? Chair recognizes Representative Price to close.
Thank you, Madam Chair. This has been a very successful program. This will modernize the program more and allow more people to participate, and I respectfully ask the committee's favorable consideration, and I close.
If there's no objection, House Bill 2059 will be left pending. The chair hears no objection. House Bill 2059 is left pending without objection. The chair lays out HB 2727 and recognizes Representative Price to explain the bill.
Thank you, Madam Chair. House Bill 2727 addresses telemonitoring, which is also known as remote patient monitoring in Texas Medicaid. A quite limited remote patient monitoring benefit was established in the Texas Medicaid program in the year 2011. The program has effectively served thousands of patients, allowing them to remain at home rather than having their conditions worsen, which can result in a transfer to a higher level of care or an emergency room visit. Currently, only a home and community support services agency and a hospital can utilize telemonitoring for patients. Over the course of the COVID-19 pandemic, telemedicine, telehealth, and remote patient monitoring were all deployed to keep patients safe at home while providing them access to appropriate medical care. The Centers for Medicaid and Medicare Services were supportive of this expansion and have added a number of these services to the Medicare program permanently. Texas did the same thing in 2021 with the passage of House Bill 4, which made the vast majority of the telemedicine and telehealth flexibilities, which were permitted during COVID, permanent parts of the state's Medicaid and CHIP programs. When the Public Health Committee reviewed the progress being made on House Bill 4 implementation during the interim, remote patient monitoring was referenced as an area for updating in the same way that House Bill 4 updated telehealth and telemedicine. House Bill 2727 can save the state money while providing health care services to the Medicaid population in the long term. Telemonitoring would enable a health care provider to potentially recognize an indication of a problem and remedy it before a high-cost emergency room visit, which could also entail ambulance services or hospitalization if needed. House Bill 2727 adds federally qualified health centers, or FQHCs, and rural health clinics, or RHCs, to provide home telemonitoring services. These two types of facilities are where many of the Medicaid population go for their health care. By adding utilization of telemonitoring for these facilities, we're not adding any new facility options for providing services. We're just adding an additional method of provision of services through a technological means for them. Additionally, House Bill 2727 adds a maternal monitoring benefit to give Texas mothers another tool in respect to high-risk pregnancies to improve the health and outcomes for moms and babies in the Medicaid program. These programs are recommended by CMS and by other specialty groups like the American College of Obstetricians and Gynecologists. The legislature continues to address this issue session after session. House Bill 2727 simplifies the eligibility criteria for remote patient monitoring services to reach a broader group of Medicaid patients. It gives the Health and Human Services Commission updated authority to add services that are clinically effective and cost-effective. Statute already has HHSC setting the rules for the specific programs, and with the caveat, if clinically effective. Regarding the fiscal note, I am surprised, due in part to, as explained to me in the past, monies are in the base budget to provide these services to persons on Medicaid. Thus, monies are already allocated. My reasoning that House Bill 2727 can save the state money in the long term is consideration of cost savings over time. While some costs may exist on the front end, the Commission's apparent reason for the fiscal note, which you'll see on page 2, realized cost savings are long term. Essentially, the savings are dynamic. Avoided ER visits, less chronic progression of illnesses, et cetera, are long-term and not estimated in the fiscal note. How much money is being saved in the long run? The Commission has been asked in legislation to review programs for cost savings, and their 2022 report on teleservices states, for home telemonitoring, the number of Medicaid clients increased by 9% between fiscal years 20 and 21. However, during that same time, telemonitoring expenditures decreased by 10%. However, while saving the state money, and thus the taxpayer, is a goal of 2727, let us also think of the people receiving the services in the Medicaid program. House Bill 2727, by broadening utilization of telemonitoring, can make a significant difference in people's lives. As I mentioned, there will be a substitute, and the language changes are small but very significant. It'll further ensure that the Commission can add conditions without legislative direction if found to be clinically effective, and it will show to add kidney failure and end-stage renal disease onto the list of specific conditions for the Commission to include for remote care, and as always, with the caveat, if found to be clinically effective. I really appreciate the opportunity to bring this before the committee. I'm open to any questions and would request the ability to close.
Members, any questions? Representative Alverson.
Thank you, Madam Chair. So, Representative Price, so the fiscal note is, do you think that's something that, I mean, I've obviously been hit with those too. And it's kind of frustrating when it comes out of left field and you're sort of like,
Yeah, you know,
like, where are you coming up with this?
And thank you for asking the question. It's something we've talked in here session over session about with regard to telemonitoring and home monitoring services. There is some expense, admittedly, with provision of equipment. There's going to be some expense with having that set up. However, there is no estimation in the fiscal note, and you can see that highlighted on page 2, of the cost benefits, the dynamic cost benefits. So if you avoid ER visits, if somebody's illness doesn't progress or condition progresses to the point where they have to be admitted or readmitted to a hospital, if their conditions don't worsen to where they need more significant care, those costs aren't calculable or calculated in this fiscal note. So there's no question that those costs, are going to be mitigated, and we're going to save money in the long term, but that's not the way the fiscal note calculation operates. So I just asked the committee to consider that.
Would this be, would this service be applicable for kids in the STAR program, STAR Kids program?
Yes.
Medically fragile children?
Yes.
Because, I mean, in that population alone, the ability to prevent an admission to the hospital is a massive savings. I just think this fiscal note is all wrong. So, and it's frustrating to me that there's no attempt to try to calculate the savings here.
I don't disagree with you.
I'm with you on this bill. I'm support you.
I appreciate that.
Yeah.
Thank you, Chairman. Thank you, Madam Chair.
Other questions, members? Righty, we will move to public testimony. The chair calls Nora Belcher. And I show that you are Nora Belcher with Texas eHealth Alliance, and you're for the bill. Is that correct?
Yes, ma'am.
Thank you.
Good morning again, Madam Chair, Representative Price, members of the committee. I want to speak just for a minute about my support of House Bill 2727, make maybe 3 points quickly, and then move you on with your day. First of all, this bill came out of the interim discussion of the Public Health Committee, and I think it's interesting that sometimes people think I don't work when y'all aren't in session. And that is simply not true. We all work, and that's what that interim hearing process and those interim reports is for. So I really want to thank the chair for her leadership in moving us through that, and Representative Price for his engagement. I think the second thing I would ask, and this is a rhetorical question, is anyone carrying their cell phone from 2011? Anyone? Because if you are, we need to talk. Technology evolves. And we need to evolve this benefit to evolve along with the technology. So we established this benefit at a time when the technology, bandwidth, all the tools were very different. We need to modernize it. We need to continue to modernize it. And then the third thing I'd like to draw your attention to is in the section of the bill where we've changed some of the qualifying criteria, I was really surprised when I reread it and was reminded that you have to have already fallen down before you can qualify for home monitoring. So we are waiting until people get hurt before we can give them this benefit, instead of doing what every healthcare provider knows how to do very well, a fall risk assessment, and then potentially treating people before they fall down instead of after they fall down, which follows the logic Representative Price was discussing around the fiscal note and the dynamicness of it. So I appreciate the committee's time and attention. I appreciate Dr. Oliverson's comments very much, and I'm happy to answer any questions.
Questions, members? All righty, thank you for your testimony.
Thank you.
Chair calls Jennifer Mertz. And I show your name is Jennifer Mertz with the Texas Association of Community and Health Centers.
Yes, ma'am.
And that you're for the bill, is that correct?
That is correct.
Thank you. Please begin.
Good morning. My name is Jennifer Mertz, representing the Texas Association of Community Health Centers, and I'm here testifying in support of HB 2727. I'm the Chief Nursing Officer at HealthPoint, which is a federally qualified health center, and my comments represent the Texas Association of Community Health Centers and the 73 FQHCs in the state of Texas. FQHCs provide a wide array of primary and preventive care services, including medical, dental, behavioral health, pharmacy, and social support services. Health centers serve over 1.7 million Texans. 30% of those patients are on Medicaid. We serve all ages and care for all populations that are a lot of the population that's disproportionately impacted by chronic health disease. HealthPoint serves more than 48,000 patients in the greater Brazos Valley area. We have over 20 service delivery sites in 12 cities, including College Station, Franklin, and Madisonville. In our health center, close to 40% of our patients are covered through Medicaid. At health centers, we have learned to do more with less. We look to innovation that promotes preventive care that can save patient time, support healthy outcomes, and reduce costs. Remote patient monitoring helps us track high-risk patients remotely. This will help prevent conditions from getting worse and save state dollars by avoiding emergency room visits. HealthPoint participates in a program to extend remote patient monitoring. Our patients have chronic conditions and are contacted on a regular basis for management and intervention. One of the success stories that I want to tell you about is a gentleman that I'm going to call Ray. Ray is a 58-year-old male living in rural central Texas. Our clinic is the only access for him for primary care, and he lives over 2 hours away from a hospital. Ray is blind, has no transportation, and has a very limited support system. Ray has uncontrolled diabetes, and he has struggled with complications due to his chronic condition. We were able to provide Ray a continuous glucose monitoring system. He shares his readings with his RN care manager, and she provides assessment and intervention in a timely manner. Ray has made changes to his overall health, bringing his uncontrolled diabetes to a place where he can manage his disease successfully and as independently as possible. We offer RPM services to patients through grant funding presently. Due to the reliance on grant funding, the participation is limited and it is not sustainable long-term. We fully support HB 2727 and believe it will provide clinically effective services to health center patients. Home telemonitoring services will help support high-risk patients manage their chronic illnesses and safely and affordably be able to do that from their homes. In closing, we look forward to the opportunity to expand telemonitoring to more Texans in our communities through HB 2727. Thank you.
Members, any questions? Thank you.
Thank you.
Is there anyone else wishing to testify on, for, or against House Bill 2727? Chair recognizes Representative Price to close.
Madam Chair, this is a win-win for the state and for the patient, and I appreciate the opportunity to lay this out. We need to be innovative and continue to lead in this area. I think it's a great thing, an opportunity for the state of Texas. I respectfully ask the committee's favorable consideration. With that, I close.
If there's no objection, House Bill 2727 will be left pending. The chair hears no objection. House Bill 2727 is left pending without objection. Okay, the chair moves to reconsider the vote by which HB 2767 was reported from committee. Is there any objection? The chair hears none, and the motion prevails. Representative Campos moves that 2767 without amendment be reported favorably to the full House with a recommendation that it do pass and be printed. The clerk will call the roll. The clerk will call the roll.
Click.
Aye.
Campos.
Aye.
Jeton.
Aye.
Johnson.
Yes.
Jones of Harris.
Yes.
Jones of Dallas. Oliverson.
Aye.
Price.
Aye.
Smith. Tenderholt. Is he here? Oh, he's not here. So it's 9.
There being 9 ayes and 0 nays, the motion prevails. We're doing hers next?
Yeah.
Okay. The chair lays out House Bill 2544 and recognizes Representative Campos to explain the bill.
Good morning, Chairwoman Click and members of the committee. Thank you for the opportunity to lay out House Bill 2544 relating to the creation of a physician assistant licensure compact. House Bill 2544 will facilitate the ability of licensed PAs to practice in multiple states without having to obtain an individual license in each of those states to practice. The compact would be developed with assistance from the Council of State Government. Texas already belongs to several other occupational licensure compacts, including physicians, nurses, physical therapists, psychologists, and emergency medical personnel. The success of these other interstates compacts has encouraged the Federation of State Medical Boards and other organizations to facilitate the licensure privilege to practice model for PAs. This will ensure that Texans retain our ability to protect the public and enforce our state's law. Utah has recently adopted the PA Licensure Compact. Legislation is pending in Rhode Island, Minnesota, and Ohio this year. The PA Licensure Compact will include requirements for states to adhere to. This will ensure a baseline of standards must be met. The PA must have graduated from a nationally accredited PA program, hold a current National Commission on Certification of PA certificate, pass a background check and jurisprudence exam in states where those are required, have no disqualifying criminal history, and no limitations or restrictions on any license or compact privilege in the previous 2 years. Additionally, this will alleviate burdens for military families by allowing active duty personnel and spouses to obtain this privilege based on having an unrestricted license in good standing from a participating state. I am open for questions and respectfully reserve the right to close.
Representative Alverson.
Thank you, Madam Chair. Representative Campos, I appreciate this bill very much, and obviously I do think that to the extent to which a person, a healthcare provider, can move from one state to the other is useful. I guess, and maybe I can ask some witnesses. Do we have any witnesses on this? Do we have anyone from the medical board here as a resource? Okay.
Yes.
Okay, great. So, I mean, and I guess the question that I wanted to ask, and you and I've just visited about it, has to do with, so every state regulates the practice of medicine a little bit differently. And so I think one of the things that we always have to be thinking in these compact situations is making sure that the compact itself doesn't basically become a method by which we trample on the Medical Practice Act for a particular state. In other words, the practitioners should obey whatever requirements for supervision, whatever requirements for the delivery of healthcare services, services that are required, services that are prohibited, all of those things. You wouldn't want to create a situation where essentially we're defying state law vis-a-vis an interstate compact license. And I don't know the degree to which your bill contemplates that, but it's something that I think hopefully the medical board can answer for us.
Thank you for that. And yes, I am completely in agreement with you. So thank you for bringing that up.
Other questions? Other questions, members? All righty, we'll begin our public testimony. The chair calls Janeth Mills. Janeth, I show that you are representing the Texas Academy of PAs and yourself, and that you're for the bill. Is that correct?
That is correct.
Okay, please begin your testimony.
Thank you. Good morning, Madam Chair Click, Vice Chair Campos, and members of the committee. My name is Janeth Mills, and I am representing the Texas Academy of Physician Assistants and myself. I am a practicing PA going on 37 years and currently practice in pediatric neurology at a comprehensive epilepsy center in the Dallas area that treats patients with epilepsy both medically and surgically. I am also the president-elect of the Texas Academy of Physician Assistants. I am here to provide testimony in support of House Bill 2544, the Physician Assistant Licensure Compact. Since COVID-19 pandemic, telemedicine has increased substantially. The positive impacts from telemedicine have left a significant mark on how medical teams provide care. Licensing requirements, however, have not permanently changed to give a framework to recognize virtual care provided across state lines. What an interstate compact allows is for portable and direct delivery of safe and quality health care for any patient that seeks care in Texas, but also for clinical practice or healthcare systems looking forward to provide excellent health care. If House Bill 2544 passes, it would be a win-win for multiple reasons. One, it would strengthen labor markets by expanding markets for medical clinics and hospital centers, improve access for quality care for our patients. Our center that I work in treats patients not only in rural areas in Texas like Atlanta, New Boston, Abilene, Palestine, but also rural areas adjacent to Texas in Louisiana, Arkansas, Oklahoma, and New Mexico. So these patients have to travel a long distance, and it is sometimes a hardship for these patients. Sometimes the families have to take days off without pay in order to come to Dallas. It's costly. They also have to arrange for care for their other children. And some parents, they don't have the luxury of having a job that you can take PTO. So that's an economic burden for them. Traveling with children is not an easy task. Traveling with a child that has disabilities is a daunting task. Children with epilepsy have a high association of having ADHD and autism. traveling with him is very difficult. And some of our kids have wheelchairs with ventilators, so they have breathing tubes, and then they also have gastrostomy tubes that require, timed treatments, making that even harder. So it would be very beneficial to have our the compact bill. All right. Secondly, hang on a second. I'm sorry. Secondly, okay, so we talked about it strengthens the labor markets for medical care clinics and hospital centers. Lastly, military families will benefit from the PA licensure compact. The compact will alleviate burdens military families face by allowing active duty military personnel and their spouse to obtain a compact privilege based on an unrestricted license in good standing from a participating state. The Department of Defense is a supporter of the PA licensure compact.
Your time
In
has
conclusion,
expired. Your time has expired.
Okay, it's expired. Thank you.
Yes. Questions, members? Thank you for being here.
All right, thank you.
Chair recognizes Representative Collier is present. The chair calls Stephen Carlton. I show your name is Stephen Carlton, and you're with the Texas Medical Board, and you're neutral on the bill. Is that correct?
Yes, that's correct. I'm here just as a resource to answer questions.
Representative Alverson.
Thank you, Madam Chair. Brent, appreciate you being here today. So you heard some of the questions I was asking Vice Chair Campos. So I was just wondering if we could walk through this a little bit. So, these compact licenses can get a little bit dicey if they're not set up properly, because you are creating a multi-state sort of quasi-governmental entity that sort of has jurisdiction concurrently in multiple states. And so I want to be sure that all of the requirements as far as the Practice Act, as far as supervisionary requirements that we have here, nothing's changing if this passes. Is that correct, or what are your thoughts on this?
Well, it is brand new. As you said, with the medical compact, it was in effect for several years before Texas joined, and so we were kind of able to see how it was operating in other states first. It is my understanding that supervision requirements would still be in place if you were to get a compact here through this PA compact, a license to the PA compact. One of the things that are, again, a little unclear from the medical board's perspective is it does say that the PA compact, the commission has the power to create a code of ethics, which is enforceable. So I'm not really sure, we're not really sure what that means or what that looks like, and if that would create some sort of a different standard for those that have a PA compact privilege to practice here versus a regular PA license. And just a few other things that are a little unclear are things like being able to charge the state a fee. I'm not sure what that amount would be. And it also gives the commission the power to borrow state employees. We're not sure if that means that they can, if we offer them up to help out with something, they have the ability to accept that help, or if it means that they have some other type of proactive power in borrowing state employees.
So the commission, if adopted here in Texas, would have the ability to borrow your employees?
That's part of the language that's in the bill of the powers of the commission.
Okay. And so obviously the other thing that concerns me a little bit is I just want to make sure that, so the legislature here, we do things all the time, direct you as the medical board as to what we believe the standard of medical practice should be here in Texas. And I think it's important to recognize that there's not regulatory consistency across all 50 states. So I guess, does this compact allow for or make the requirement for people who have a compact license that they have to follow the Medical Practice Act in the particular state and be subject to that medical board's disciplinary proceedings should they violate that standard?
That's my understanding, is that they would have to follow the rules and statutes here in Texas. This just gives them a different pathway to getting that license.
Okay.
Again, that's my understanding, but again, we're not really sure what the the code of ethics would mean.
Yeah, I guess so. Would it be conceivable that the Code of Ethics could direct the license holder to do something that would violate the Medical Practice Act in a particular state?
We're not sure. I guess there could be some type of conflict that could come from that.
Okay. Well, so, I mean, obviously, I think it's a reasonable idea, and we certainly need more healthcare employees. So I guess the last question is, how do we help resolve these concerns so that we can move this project forward? What do we need to do?
We're certainly happy to work with the bill author and see, if there's some further clarification on what that means. Again, it's my understanding that this language is the kind of the model language that was developed at a national level for all the states to adopt. So I'm sure there's some areas to again kind of clarify what was the intent of that language.
Okay. Okay. Well, look forward to working with you on that and appreciate that. Thank you.
Other questions, members? Representative Jones.
Thank you, Mr. Carlson. So I actually had the same questions and concerns about this because, like, for example, as a lawyer, you can now sit for the bar, and if you get certain scores, then I think you can be licensed in up to, I want to say like 42 states or something like that. So there's some consistency about your marks on the bar, and certain states have higher and lower, right? So you might qualify to practice in Idaho, you might not qualify to practice in Texas. Is this something similar to that, if you know, or like what happens to the people that are already PAs somewhere? Do they grandfather in? I mean, I know you're not the bill's author, but I was just wondering.
My understanding is that whatever scores they had in their national exam is not necessarily taken into consideration for whether or not they get a license or the privilege to practice in different states. It's just if they passed it and there are a qualified PA in what do they call it, participating state, that you would be able to practice in the other states that are members of the compact.
Because with the bar, you pass it, you have to pay an admittance fee, right? So you might get a high enough score to practice in 42 states. You have to go to each state and pay whatever it is. If you know, is that the same thing with this?
Yes, if you have a license here, each participating state would be able to assess a fee for the kind of the incoming PA to have that privilege to practice in that state.
Okay, thank you.
Other questions, members? Thank you.
Thank you.
Thank you.
That's all. Is there anyone else wishing to testify on, for, or against House Bill 2544? The chair recognizes Representative Campos to close.
Physician assistants practicing in Texas under privileges to practice will adhere to Texas existing laws and regulations. The compact will provide for greater in-person and telehealth access to care and will significantly enhance practitioner mobility, including in times of public health emergencies. With that, I respectfully ask for your vote, and I close.
If there's no objection, House Bill 2544 will be left pending. The chair hears no objection. House Bill 2544 is left pending without objection.
Good morning. The chair lays out House Bill 3039 and recognizes Representative Click to explain the bill.
Thank you. Members, we have widespread medical workforce shortages in the state of Texas, including the dental field. In 2019, Department of State Health Service issued a report titled Texas Supply and Demand Dental Projections for 2018 through 2030. It stated that demand for dental hygienists is projected to exceed supply every year between 2018 and 2030. The supply of dental hygienists is projected to grow by 17.4%, while demand is projected to grow by 18.6%. increasing the shortage of dental hygienists by 28.4%. During this past interim, this committee had testimony on these issues, and our interim report discussed the challenges encountered by rural patients seeking dental care and how delays in getting this care results in preventable and costly emergency room visits. In 2016, over $226 million was incurred for emergency room visits for non-traumatic dental conditions in Texas, and another $216 million was incurred via inpatient admissions during the following year. Last session, we passed HB 2056, expanding access to teledentistry, but the current shortage of dental hygienists threatens to undercut these advances. One proven solution for workforce shortages that have occurred in other medical fields are interstate compacts. Currently, the Texas Medical Board, the Texas Board of Nursing, Texas Behavioral Health Executive Council, and the Texas Board of Physical Therapy Examiners each take part in interstate compacts. There's no such program for dentists and dental hygienists. House Bill 3039 would allow Texas to participate in the new Dentist and Dental Hygienist Compact. This compact was finalized this spring. 7 states are currently considering adopting this language. To qualify for the right to practice in Texas, out-of-state dental professionals would need to meet several requirements, including holding an unencumbered dental license, undergoing criminal background checks, paying fees, and completing a jurisprudence exam. I've requested a committee substitute to make corrections to HB 3039 as the compact's model language was not finalized before the Legislative Council's deadline for requesting drafts that occurred earlier this year. Substantively, the committee substitute remains true to the bill as filed. Any minor adjustments will be explained when the committee substitute is available. We do have a witness from the National Center for the Interstate Compacts to answer specific questions regarding this compact. With that said, I'm open for any questions and reserve the right to close.
Thank you, Representative. Member, are there any questions? Okay, if there are no questions, we will proceed to testimony. I'd like to call up, Chair calls up Steve Brenson.
Morning, members. Madam Chair, thank you very much for carrying this bill. I'm Steve Bresnan. I'm here for the legislation on behalf of the Association of Dental Support Organizations. Our association, offices supported by our association, delivered almost 2 million patient visits last year. We have over 500 dentists in offices supported by ADSO members and about 450 hygienists. The first question that you should ask, does Texas have a problem? We've delivered to each one of your offices a one-page sheet that shows where the particularly heavy dental professional shortage areas are in Texas. Hygienists are a particular focus because it's universally agreed we don't have nearly enough hygienists. And you know, you passed great telehealth legislation last session, but if you don't have hygienists, you don't have telehealth. So we really need to address that sort of thing. And you'll notice on here that dentists are in a different area, shortages than necessarily the hygienists. It is true, and we agree with those who say that, do we have enough dentists in Texas? Some areas we have enough, others we don't. Walking you through your package just a little bit, I've put this document in here, just excerpted pages that have a graph for each of the 8 dental health regions in Texas. And the first few pages are where the hygienists, how we stand on hygienists projected up to 2030. And the next few pages are where we stand on dentists projected up to 2030. Y'all passed a great bill last session, House Bill 1616, which is the Physician Compact. It's been hugely successful. I've placed a copy of the interim report from the medical board in your packet that I think bears that out. The medical board's to be congratulated for flawlessly implementing that legislation. Also in your packet, there are some frequently asked questions about the compact. I do want to note a couple of things. This pays for itself. The fees that are charged by people who are applying for a compact privilege on your fiscal note, you can see that it pays for itself. It actually had about a $500,000 positive impact projected over on the medical board side. There were only 2 no votes in the entire legislature, 1 in the House and 1 in the Senate on the physician compact last session. Dr. Alverson, the questions you ask are at the heart of it. This bill does not affect the standard of care applicable to dental health professionals. It does not affect and preserves the scope of practice for dental health professionals. And it goes one step further, because if a dentist with a compact privilege in Texas or a licensed dentist in Texas who has a compact privilege to provide services elsewhere violates Texas standards, there's an action taken against them. It gets reported to all the other compact states, and they have to freeze that compact privilege as well. So this, the ability to skip between states for bad actors is thoroughly curtailed by this concept. Madam Chair, I've lost track of my time, so if I need to shut up, I'll be happy to and answer any questions.
Dr. Oliverson?
Thank you, Madam Chair. Steve, I appreciate you being here today and bringing this. And obviously, you know, we need any and all ideas to help address the workforce shortages. So I'm glad you kind of brought that up. You know, for better or for worse, and we've certainly heard the bill in here before, and some will support it and some oppose it. You know, the practice of dental hygiene in the state of Texas is somewhat more limited in scope of practice than it would be in other states. And so I just want to be clear that in all respects, not just sort of like, you know, well, whatever, that we understand that these compacts specifically written into statute, there's a requirement that whatever the rules are, whatever the Practice Act says for that particular state, they're bound by that in that state, or they are subject to disciplinary action.
Yes,
just want to make sure that's in the bill.
Yes, sir. And my friend from the Council of State Governments will can elaborate on that as well. These compacts are meaty, but most of the verbiage that you have in there are really about the operation of the compact itself. Some have raised questions, as were raised on the physician assistant, about, you know, this is new, nobody's done it for dental care or physician assistants. I think Texas is heavyweight as we are. If we get in early, then some of the ambiguities that may exist now can be fleshed out by the rulemaking authority that the commission would have. With respect to the ethics question, the way I'm going to follow up with you on this, but the way I read this, it's for ethics for the commissioners and the commission staff, and not to impose something on professionals that would deviate from the Dental Practice Acts in the states.
Well, and I mean, these are big questions, right? I mean,
Yes,
the medical compact license took several sessions to pass, and mainly because there were these questions about, you know, what is the relationship between the interstate compact and individual requirements under different practice acts across different states that may be dissimilar.
Yes, sir.
And so, I mean, these are not simple, like, cookie cutter type questions. These are, you know, these are things that have to be analyzed carefully. So I appreciate you at least talking about these things, because I think these are the questions we should be asking for all of these health professions compact licenses.
We're serious about it because we support a lot of group practices. They need associate dentists. They need hygienists. And so if you're going to bring people in to work in those, you can't very well set them up for a problem, because those practices are going to ultimately be on the hook for people who violate Texas law.
Thank you, sir. Representative Smith?
Thank you. Hey, Steve. Good morning.
Good morning.
Along Dr. Oliverson's lines, are you aware of any circumstances where a practitioner has been put in some type of a conflict position between his state rules, so to speak, and the compacts?
No, sir, I'm not. It's an excellent question, and my colleague from the Council of State Governments may know the answer to that, and we need to know the answer. The good thing is there's a lot of history with compacts of various kinds, and so we're not reinventing the wheel completely here. So we can gather that information and provide it to the committee.
It sounds to me like one of the benefits of the compact, whether it's in this particular bill or Ms. Campos, is that when we were talking about bad practitioners, that the compact, is it true that the compact is there in some ways to provide additional backstop for making sure that some guy doesn't move from state X to Texas?
Yes, sir. Yes, sir. The compact members are obligated under the compact to report bad actors to the commission, and that information gets disseminated against the compact members. So very much so.
Okay. All right. Thank you very much.
Madam Chair, thanks for bringing this bill. Really appreciate you.
Thank you. Any other questions? Thank you for being here.
Thank you.
Thank you. The chair calls Matt Schaefer. Mr. Schaefer, thank you for being here. I show that you are with the Council of State Governments and you are for the bill. Is that correct?
Yes, that's correct.
Thank you.
Thank you, Madam Chair, members of the committee. I'd like to express my appreciation for your consideration of the Dentist and Dental Hygienist Compact. For the record, my name is Matt Schaefer at the Council of State Governments. My testimony is meant to provide some background information on the compact. So, the Council of State Governments is a nonpartisan membership association for state government officials across all three branches. CSG, through its National Center for Interstate Compacts, has facilitated the development process of all 15 of the active licensure compacts that exist, including the 5 that Texas is already a member of. I'd just like to point out that Texas is also a member of 30 interstate compacts not related to professional licensing. So Texas is not a stranger to entering into these types of agreements. So for the past 18 months, CSG has been developing the model language with stakeholders from these professions, from the American Dental Association, American Dental Hygiene Association, and state regulatory boards. The compact is similar in form and function to the 5 licensing compacts that Texas is already a member of. The compact will enable Texas dentists and dental hygienists to obtain a compact privilege in a remote state that is a member of the compact rather than get an individual license in every state in which they want to practice. To utilize the compact, a Texas dentist or dental hygienist must have a license that's in good standing, that is a member of the compact, and when a licensee wants to work in another participating state, they obtain a compact privilege. Practitioners must also pass a background check, meet other eligibility requirements related to education and examinations. I'd also like to emphasize Texas will be able to charge a fee for that compact privilege, and Texas retains the authority to set that fee at whatever they would like. The Dentist and Dental Hygienist Compact preserves Texas's regulatory authority to protect public health and safety through its existing regulatory structure. So unlike national licensure initiatives that often supersede state regulatory authority, the compact allows Texas to continue to determine requirements for a Texas license and maintain Texas's unique scope of practice for anybody practicing in the state of Texas, whether through a Texas license or through a compact privilege. So any licensee from another state seeking to practice in Texas must abide by all of the laws, rules, and regulations that govern the practice of dentistry and dental hygiene in Texas. The Dentistry and Dental Hygiene Compact also benefits military families that are stationed in Texas. If a family gets assigned to a new duty station in a compact state, they would be able to continue to work under their privilege. And like all the other licensure compacts, it's governed by a commission, and that Texas's representative would be from the Texas Board of Dental Examiners. Like has been mentioned, the compact will come into effect when it's enacted by 7 states. There are currently 7 states with pending legislation. And with that, I'll conclude my remarks and stand for questions.
Thank you. Are there any questions? Representative Tenderholt?
Thank you, Madam Chair. My concern would be continuing education. Is it different in every state for continuing education for these folks or not? Or don't you know?
There is some variance in continuing education. I don't think it's a significant amount of variance. The way continuing education works with this particular compact is the licensee would have to complete continuing education in the state where they're licensed, but not in every individual state where they hold privileges.
Okay, thank you.
Thank you, Representative. Any other questions? Representative Collier?
Thank you. A question about the compact when it comes down to somebody applying. I thought I heard you say, please correct me, that if somebody is licensed, it sounds like it's just one license, or do I get a license in my home state and the compact?
So you maintain one license in any state that's a member of the compact, and then to work in other compact member states, you apply for individual compact privileges.
And would you anticipate an additional fee for that?
Yes, there's a fee for each individual privilege. It's a fairly nominal fee. We don't know what that fee will be because the commission, the governing body of the member states, will set that fee. I'll say just anecdotally, with other compacts, the PT compact privilege fee is $45.
So is it automatic? Because one of the things in the very helpful and useful handout that I got said that the license may not have any current encumbrances related to an adverse action. What if they had past adverse action? Do they look at that before they can apply or approve, before their application is approved?
If it's a prior action and the disciplinary process has occurred and that person has been remediated and their license is restored to full standing, then they would be eligible for a compact privilege. So if it's a current encumbrance on their license, they would not. But anything previously that's been fully remedied, they would still be eligible for a privilege.
And can you define encumbrance in the context that you're referring to?
Sure. It would just be any limitation on the license whatsoever. So if there's any kind of suspension or a temporary cease on their license, you can't practice for a certain amount of time, that would be considered an encumbrance.
Okay, thank you.
Thank you, Representative. Representative Oliverson?
Okay, quick question about CME, because I do think we should think about that for a second. So whatever state they choose to get a license in, so what if they pick the state that has the fewest continuing education requirements of all states participating in the compact, and that sort of becomes the default, even though the majority of their practice is not spent in that state?
Yeah, and I understand. I'd have to pull the data to see exactly, but I don't think there's a significant variance in continuing education across the states in terms of specific hours requirements.
And look, I know you don't write the compact, but I'm just saying it seems to me like it would be simpler to just say whatever state you're practicing in, you're required to do whatever the highest standard of continuing education is, or whatever state you're practicing in, that's the standard you have to meet. Rather than just wherever you're licensed, because I mean, then you just create a race to the bottom, I think.
Yeah, and I understand the point. I think the thinking here with tying it to the state where your license is continuing education is typically a component of license renewal. So the fact that they don't actually have a license in that remote state, they just have a privilege, I think that's why typically we tie it to the state.
That doesn't actually, I mean, I hear what you're saying, but that doesn't actually address my concern, which is that essentially then everybody gets licensed in whatever the most lax state that's participating is, and you can now practice in, whatever. In other words, these requirements for CE are set forth by the legislature through the Practice Act or by, delegation to the Practice Act in a way to ensure the standard of care for that state. That's the whole purpose of CE, is to make sure that everybody's practicing dentistry or dental hygiene in that state is exceeding the minimum standard to ensure that they're practicing at appropriate level of care. Unfortunately, that's not the same everywhere, but I don't know. I feel like that it would be better if it was you had to comply with whatever state you were practicing in at the time.
Yeah, and I understand the concern. I think another thing to consider is with this compact, you could be practicing in multiple states at one time. If you're living near a state border, you might have your license and then 2 or 3 different compact privileges depending on where you're located. But I understand the question and the concern, and I'd be happy to get this committee some data on continuing education and the amount of variance across states, because I do think it's pretty minimal.
Maybe they could just take the average, like whatever the median number of hours for all participating states. That's what it ends up being. I don't know. It just seems like you'd, well, anyway, I've said enough.
Thank you, sir. Representative Smith?
Yes, sir. Thank you so much. So, to kind of follow up on Dr. Oliverson's point, when you get licensed to be a dental health professional, let's say what are we talking about here? Hygienist. Okay. There's a residency requirement, is there not?
Within the compact?
Well, no, for whatever state you're going to apply for.
I don't believe that's typical, that there would be a residency requirement associated with the license that you must live in that state.
Okay, so when I come out of hygienist school, I can just pick whatever state I want to get licensed in?
Well, currently you would be limited to practicing within that state. You wouldn't have access to any other states.
Is there one state, or are there several states where people like to cherry pick to get their license at this point? Are you aware of that?
No, I don't believe so, and I think that's why healthcare has been the sector of the licensed professional workforce that has quickly adopted these compacts, is because there's such uniformity across the states in terms of what it takes to get licensed, because these compacts lend themselves to uniformity. The states are all agreeing on the standard, and because that uniformity already exists, that makes developing a compact much easier.
Does the compact license have any restrictions on it?
In terms of what they're allowed to do or time limit or things like that. So it doesn't have any restrictions in terms of what they're able to practice. They're under, like I mentioned in my remarks, they're under the scope of practice in the state where they have the privilege. So, but they can fulfill anything within that defined scope of practice in that state. And it is renewed in sync with the license that they hold. So if their license is on a 2-year renewal cycle, then those privileges would need to be renewed every 2 years.
Okay. Are you aware of anyone having their application to be a dental hygienist through the compact denied?
Well, since the compact doesn't actually isn't formalized yet, no, but.
How about, we have one for the dentist? Is that what you're saying?
So dentists and dental hygienists are both covered in this compact. In this one, yes. I will say that with other compacts, there is that background check requirement in place. So if there's any prior criminal history that the state would deem as disqualifying, then that person would not be granted a compact privilege.
So there's not a dental hygienist or dentist compact that exists today and issues license for other states?
That's correct. So House Bill 3039 would be entering Texas into that agreement. This language was finalized in January. So we're bringing it to you, and it's new. There's 7 states that have introduced legislation right now, including Texas.
And there's not one in existence in anywhere in the United States for dentist or dental hygienist yet?
That's correct, because this language is so new. So all the states are currently considering joining this compact. So.
Wow. Okay. Thank you.
Thank you, Representative. Representative Collier?
Forgot I had asked. So the packet that was provided to the committee, it said, and going on about the criminal history background, you said, I did see something in there in the bill about the criminal history, but one thing that the physicians in that bill that was mentioned from last session, it says that they must not have any history of disciplinary actions toward their medical license. But is that going to be the same for this particular compact?
So each state gets the ability to, when they apply for their initial compact privilege, they would undergo a background check, and the state would determine whether or not they meet the requirements set forth in the compact. It does not say in the dentist and dental hygienist compact that they can't have any criminal history at all, it just leaves that discretion up to the state. So if Texas deems somebody to have criminal history that would disqualify them from getting a compact privilege, they would be able to make that determination, but there's no universal standard around can't have any prior criminal history. It would just be up to the discretion of the state.
Okay, so that's not in this bill or the substitute that's proposed?
No,
Going to
ma'am.
be proposed. Okay, and then the same thing with the disciplinary action. I mean, I just want to make sure that we're, following pretty, being pretty even and having the same expectations for our healthcare professionals. So if the physicians says that in order to be eligible for the SPL status, not have any history of disciplinary actions towards their license, is that something that could be added for the dentist and dental hygienists, or do you think that that's going to pose a problem?
Well, again, with this particular compact, we left it up to the discretion of the state around previous criminal history. So they can't have anything current on their license, but like I mentioned in my previous answer, if there's something that had been adjudicated and the disciplinary proceeding had been completed, then that person would be eligible. And I'll emphasize here that because this is a compact, that's a contract between states, the language really can't have significant variances across the different bills that states are passing. So the language does need to be substantially similar.
Yeah, but I don't want us to lower the standards for those who practice in our state. So the physicians have not currently be under investigation. So yes, you agree to that. But what's wrong with adding these other provisions? And they also say not have any history of controlled substance actions toward their license. I mean, isn't that something that we should expect as well?
Sure, and I think the thinking here was that we would leave it up to the discretion of each state, and when choosing whether or not the person would be eligible for a compact privilege. And I'll say, in the current situation, if somebody was coming and applying for a Texas dental license and they had something in their previous state that had been totally adjudicated and they had undergone the disciplinary process, I don't want to speak for the Texas Dental Board, but I would assume that they would grant that person a Texas license if they had satisfied everything that the other state had required them to do around discipline.
So the bill would allow for the medical board, who the dentists fall under, or the dental board?
Dental board.
Sorry. The dental board to create additional eligibility standards or requirements to comply with the SPL or to participate in the SPL?
They would not be able to impose any additional requirements on the compact privilege holders coming from another state. It's up to the discretion of the state where they're licensed.
Okay, so if we wanted to get these provisions in there, that they not have any disciplinary actions, that they not have any criminal history or not have any history of controlled substances, we would have to do that now.
Yes, ma'am.
Okay, thank you.
Thank you, Representative. Representative Jones?
So what if somebody's who's trying to come to Texas has had, I don't know, 5, 6, 10 previous disciplinary actions and they're all complete? Are you telling me that as long as they're complete, they could, well, I guess for lack of a better word, waive in here?
And that would be up to the discretion of the state where they're licensed. But yes, the thinking is that with due process, somebody has completed what was required of them, and their license is currently clean and unencumbered. Then yes, they'd be eligible for a privilege.
So I don't guess I have a problem with them being currently clean where they are, I guess, based at or licensed at. But I think that if somebody's got 10 prior disciplinary actions, and even if they're clean, it's showing you something. I mean, we see that all the time in whatever area. After somebody's dead or somebody's injured, then they're like, oh, the signs were there. We should have known. So I can just tell you that particular provision would bother me. And so we don't have to go back and forth because I've heard you answering the other ones, but I think that's significant. I think that people who go to the dentist in Texas would probably not want to be worked on by people that get in trouble a lot, wherever. So, so I think that you guys should probably, I guess, with the bill's author, like work on that, because that concerns me. Because you could hurt somebody, you could kill somebody, you know, when you're in their mouth or whatever with needles and stuff like that. But I'm done. You don't have to explain anything else.
Yeah, thank you, Representative. And I would just emphasize that, you know, with these compacts, you are agreeing to a certain level of trust with the other member states that are a part of the agreement, that they have done their due diligence in licensing this person. But I'd also like to emphasize what my colleague Steve brought up with the information sharing that occurs amongst the member states. So if anybody is practicing under a compact privilege in a remote state, they come under investigation. All of the member states are immediately notified and that privilege is suspended. So there's really some safeguards within the compact to protect against any scenario where somebody is hopping from state to state undetected.
So you just made me think of something else. So me as a person who needs to go to the dentist and get worked on by whomever, can I Google it? Can I go to something and find out? I mean, if let's just say Idaho, I don't know why I'm picking Idaho, but let's just say Idaho is a part of this compact and they've cleared the person. They say, oh, you are licensed to practice. Do I, as a consumer, have a way to go do my own independent research to decide whether I want somebody in my mouth who has been in trouble a whole bunch of times wherever? Is that information public?
So in all of the existing licensure compacts, there is a website where you can go and see everybody who has a compact privilege in whatever state.
That's not my, I'm sorry. Super simple question, right? Can I, as the patient, go to something and see all of the disciplinary actions of the person who might be in my mouth? That's like a yes or no question.
No, ma'am, no.
Okay, thank you.
Thank you, Representative Smith.
So a moment ago, you represented to us that if someone gets a grievance, I'll call it a grievance because I'm a lawyer, it's called a grievance. That's what they tell me. Anyway. In another state, that immediately their right to practice through the compact is suspended until that investigation's complete. Is that correct?
If there is an action taken by a board, then the compact privilege is suspended immediately. If the person is still under investigation, nothing has been proven yet, they are still eligible to practice. It would need to be a final board order that's taken that would then automatically suspend all the other privileges.
Okay, I think I misunderstood you then. So just for those of us who aren't in the medical field, help us understand. When I apply, let's say I'm a hygienist and I apply for an application through the compact, who all makes that decision as to whether or not to grant me that licensure? Is it just the compact, or is it the compact and then the state that I'm going to? Who all is involved in making that decision?
Sure. So as all of these licensure compacts have a data system that the member states are uploading their information to. So the state where you hold your license, if you're eligible for the compact, they would upload your information into that data system. And then you, as a practitioner, when you would go to apply for a privilege, you're already in the system, so you're on the good list from that state. You can just go and apply for a privilege in any of the other remote states, and it's granted in a matter of minutes. So because the other state has vetted you, they've put you on their good list, per se. You're in the data system. You, as a practitioner, can go and apply for privileges in other states, and it's done in a matter of minutes.
So what you're telling us then is it's not possible, let's just take Texas, okay? What you're telling us is, under this system, it's not possible for me to apply in Texas to be a dental hygienist, be denied, and then be able to practice in Texas as a dental hygienist by applying through the compact.
So I just want to make sure I understand the question. So they come to the Texas Board of Dental Examiners, apply for a Texas license, they're denied, and then they go and try to practice through a compact privilege.
Right.
If they were granted a license in another state and they meet all the eligibility requirements that are in the compact, then they would be able to apply for a compact privilege in Texas and be granted a privilege. If they meet all the eligibility requirements that are in the compact, which are pretty standard across states in terms of education, examinations, things like that.
Yeah, go ahead.
Representative Johnson?
We're tag teaming. So if we're both hearing what you're saying, somebody tries to come apply in Texas, they get denied in Texas, so we don't want you to practice here. They then supersede the judgment of Texas by going back through the compact to waive in to Texas. That's the question. Can that happen under this provision? Is that what you're asking? Yes. Yes.
That's a great question, and I would have to I'd have to follow up with our drafting attorneys on that one and get back to you. The idea is that there's uniformity across states, and so that's why the granting of the privilege can happen almost instantaneously, because there's uniformity across states in terms of education and examination and things like that. So I'd like to confer with our drafting attorneys and get back to you on that situation. I understand the concern there.
Because what you said a moment ago was that, the data would be uploaded from the state, and if you're on the good list, but you assume that I'd be on the bad list in Texas if I got my application denied, right? So yeah, I bet you. Let's get some more information.
Yeah.
Absolutely. Thank you.
Representative Tinderholt?
Thank you, ma'am. I'm trying to, it's your name, Matt?
Yes.
Matt. I got to tell you, we asked you a lot of questions. You're doing a great job. Honestly, you are. You're answering a lot of questions.
Thank you.
I almost feel like it comes down to a couple things. We either have to make it a little more difficult to do, or we have to eat a little bit of risk. And I think the bill's super important. I think we have to do something. And I think the discussion that probably needs to happen is, do we eat some of the risk? I don't know. Or do we add some standards into it that make it a little more difficult for someone that's had tons of discipline? But I wanted to tell you, you've done great. We've been asking a million questions, and you've been up there a long time, so thank you.
Thank you. I very much appreciate that.
Thank you. Any more questions? Thank you for your testimony.
Thank you.
The chair calls Kathy Nobles. Thank you, Ms. Noble. I show that you registered as Kathy Nobles, and you're with the Texas Dental Hygienists Association, and you are for the bill. Is that correct?
That is correct.
You may proceed with your testimony.
Thank you. Good morning to everyone. My name is, as she said, Kathy Nobles. I am actually the president of Texas Dental Hygienists Association. I am also a hygienist. I do ask that you support the passage of House Bill 3039. I'm testifying on behalf of Texas Dental Hygienists Association, which we will call TDHA, in support of the bill. TDHA supports the mobility of dental hygienists through the creation of the Interstate Compact legislation that will create reciprocity among participant states and reduce the barriers of license portability. The Texas Dental Hygienist is actually a member of the Coalition for Modernizing Dental Licensure, which supports the Interstate Compact. It creates a pathway for licensed professionals rather than then obtaining certain multiple licenses in multiple states. The legislation will remain the public health and safety and maintain the public health and safety to preserve the state's authorization over professional licensing. Hopefully that helps answer some questions. And help hygienists who are spouses of military, who are trying to maintain their dental hygiene career, as supporting their spouse, they have to relocate. Licensing for Texas, the licensing fee for licensee in Texas will remain in Texas. It will not be, the license fee will not be collected by the Interstate Compact. What I mean by that, Interstate Compact will have their own license fee, but the license fee for Texas stays in Texas. And also, so does the requirements established by the participating states. TDHA agrees with that all hygienists in the compact must meet mandatory requirements to obtain compact privileges. Those requirements are a CODA accredited education. CODA is the certification of dental accreditation. I know that's sort of a double entendre there, but so the education, we all take the national board. We don't take a state board. We take the national board. So it's all the states. Okay. We also have to take a clinical assessment exam in order to get our license in Texas. And that's governed by the TSBDE, which y'all governed the TSBDE. When we go to a different state, or when someone comes to our state, they have to practice by the provisions of the state. Some states may require a special license or special certification. So let's say if someone comes in that Texas has a special certification, they will not be able to practice that certification until they take the class and get certified or licensed.
Ma'am, your time's expired.
Oh, wow, that was quick. Okay.
Do you have any questions?
Yes.
Representative Collier?
Can you continue, because you're providing some good information that I need to know. Sorry.
Okay.
Just tell me what you were going to say next.
Okay. What I was going to say next, well, it addresses the challenges of the state of Texas for dental care, for dental hygienists. Demanding dental hygienists proceed in excellence and exceed supply every year between 2018 and 2013. Our need is not equal to dental hygienists is not equal to the need of the growth of the public. So therefore, the safety of the public. Is
the rest you're going to say?
Nope. Sorry. Disciplinary actions?
Yes.
Okay. So if a licensure has a disciplinary action against them, the licensee can no longer participate in compact privileges until all the conditions for removal of the discipline have been met.
So there's an expunction provision in the dental hygienist or dentist compact?
Yes.
It's in the bill?
Well, I don't know if it's in the bill.
Oh.
There is a publication out that has all this information in it. I would be glad to share it with you.
Oh, will you please?
Yes.
So there'll be an expunction process in their home state?
Actually, yes. And any states are practicing it is what I'm understanding. Let's say if Arkansas comes to Texas and there's a disciplinary action in Texas against that Arkansas dentist, that is reported. The data system they were talking about earlier, that is reported immediately. It isn't on one time. I mean, sorry, not a one time. It is, it's a real-time sharing.
Do you have any data that talks about any disciplinary actions across the country for dentists or dental hygienists in regards to controlled substance actions towards their license?
That I do not know.
Okay.
What I can say, you can search the TSBDE website and you can see disciplinary actions on there, but as far as I know, it's only current disciplinary actions. So to answer your question earlier, there could be a dentist in Texas that has one or two disciplinary actions against them, and once they satisfy what TSBD has, their peer review, whatever it is that they have to go through, their remediation, as far as I know, that disciplinary action may be wiped.
Okay. Thank you so much. I appreciate the information.
Thank you, Representative. Any other questions? Representative Jones?
So you do or you don't know the answer to whether there's an expunction process?
I do not know, but I will find out and get back with the committee.
So I'd like to know that. And just really quickly, just so I already was concerned that I, as a patient, as a consumer, don't have a way to figure out if the person who's going to be in my mouth has had issues, right?
Correct.
But I then get further concerned if not only do I not know how to find it, but that somebody could wipe all of them out and I wouldn't have, because expunction, unless I'm misunderstanding expunction means I can go and get it cleared from my record.
Well, that's what I want to find out for sure.
Okay.
Because I know that I have looked up disciplinary actions on people that I know that have been turned in, and the actions are no longer there. Now, remember, TSBDE has rules and regulations on all the disciplinary actions, and they have, I believe it's a third-party company, that they use for their disciplinary actions to alleviate those actions. There are certain remediation hours and certain actions they have to satisfy to be able to start practicing again.
No, I don't disagree with you there, right? I do not. I'm a lawyer. We can have grievances filed against us. We can be sanctioned. It can be public or private or whatever. So I understand that, right? But I just know that with medicine, people can kill you. I mean, for almost anything. I'm not saying that they will. And I just want to know if I'm assuming a risk. And one of the things I learned from my son, on account I'm older, he's like, Mom, always look at the reviews, right? That's what my son said. Look at the reviews, because people will let you think stuff is beautiful when it ain't. That's Ebonics, in case y'all didn't know that. But we don't have to go back and forth. We can talk later.
Yes, yes.
And again, I can speak with Chairman Click about those concerns, because I just don't think that the ultimate user, the patient/consumer, should absorb the risks of what could happen to them if somebody has a bunch of disciplinary actions.
Well, and like I said, it's up to the legislatures to write the rules of Texas and hand it down to TSBDE. So,
Thank you.
Thank you, Representative. Any other questions? Thank you, Ms. Nobles.
Thank you
for your testimony. Anyone else? Terry?
No.
If there are no other witnesses, the chair recognizes Representative Click to close.
Thank you, members. Joining the compact is a way to allow Texas to address some of its dental workforce shortages. I'm happy to work with members of the committee on any substitute language that they think might be beneficial. And I thank you for your listening to our witnesses, and I close.
If there is no objection, House Bill 3039 will be left pending. The chair hears no objection. HB 3039 is left pending without objection.
The chair lays out House Bill 3039, and I'm sorry. This one. Okay. The chair lays out House Bill 1847 and recognizes Representative Howard to explain the bill.
Thank you, Madam Chair and committee members, for hearing House Bill 1847. On September 2nd, 2022, then Commissioner of the Department of State Health Services, Dr. John Hellerstedt, sent a letter to the governor stating that the 2022 Maternal Mortality and Morbidity Review Committee's report would not be released by its statutory deadline of September 1. In the letter, he said that the department was still in the process of reviewing maternal death cases for the 2019 cohort, but that the extensive nature of this process, coupled with staffing shortages, had led to a delay in the committee's ability to release the report by September 1. The extensive nature that he was referring to was the process of redacting information from maternal death case files. According to the department, Texas is unlike any other state in its data collection because it has to take an extra step of redacting the maternal mortality records before they are reviewed by the nurses who are responsible for analyzing the data for the committee. The purpose of the redaction is to provide the nurses who review these cases an exemption from reporting a violation of conduct under the Nurse Practice Act. However, the additional step of redacting this information has caused significant delay in the preparation of the report and contributed to last year's untimely delivery of the report. It's an important distinction to make here that these reviews are not conducted as peer review, but rather as expert review focused broadly on improving systems and care provision. So this is not a peer review process. The Maternal Mortality and Morbidity Review Committee was established in 2013 to review findings. Statewide rates, ratios, and trends show opportunities exist to address maternal mortality, morbidity, and disparity contributors in Texas. And the legislature has created this committee because Texas had and continues to have an unacceptably high rate of maternal mortality and morbidity. Since 2013, the committee's work has been instrumental in addressing the state's maternal mortality rate and has led to important policy changes that have improved the maternal health care in our communities. The purpose of requiring the report to be released by September 1 is to allow the legislature time to review, draft, and file legislation related to the recommendations made within the report. Even though the report did not end up being delayed until 2023 as originally projected, the final report was still released more than 3 months after its statutory deadline. So in order to ensure timely analysis in the future, HB 1847 would allow nurses to review unredacted materials related to maternal mortality and morbidity cases in the course of preparing the review committee's report and would accelerate the process of abstracting data from maternal death cases. With that, I'm happy to take any questions and reserve the right to close.
Any questions, members? Okay, we'll reserve your right to close and begin with public testimony. The chair calls Taylor first. I hope I pronounced your name correctly.
Right.
Okay, so I have your name as Taylor First, First United Methodist Church of Austin, and yourself is who you're representing, and you are for the bill. Is that correct?
Yes, that's
Thank you.
correct. Good morning, committee members. Thank you for taking the time to hear testimony on this and consider this bill along with all of the others regarding maternal mortality and morbidity rates in Texas and addressing that issue. I serve as the senior pastor at First United Methodist Church next door. We are trying to rival the Capitol in the amount of scaffolding on our building, so that's an easy way to identify us over there. Our church includes a group of young women leaders called Circle Up, which is a group within the United Women in Faith, formerly known, you may know it as United Methodist Women. These leaders have been advocating since 2017 for bipartisan efforts to improve maternal outcomes for Texas women, and they are part of a large and growing coalition of organizations who are working for the same purpose. Make no mistake, Texas women and people of faith are watching this legislative session, and we appreciate the legislative attention that we are seeing focused on the incredibly high rate of maternal mortality and morbidity in our state. The state of Texas can no longer shrug our shoulders and look the other way, not when the most recent data confirms that 90% of pregnancy-related deaths are preventable. As an organizational leader, as a pastor, and as a practicing disciple of Jesus, I know that change happens in the areas where we pay the most attention. We have to pay more attention here, and we have to clear the obstacles to make way for more data, better data, and more efficient data so that we are better equipped to address these preventable deaths. We believe that this bill and several others will take another step in the right direction, but what I want you to hear from me today is that people of faith care about these issues. and we are asking for your help to address them. I'm grateful for Representative Howard and the other representatives who are shining the spotlight on these challenges, and respectfully ask that you not only support this and other bills supporting improvements in maternal care, but that you urge fellow representatives and state leaders to bring this issue front and center on the state's agenda. Thank you.
Questions, members? All right. Thank you. Is there anyone else wishing to testify on, for, or against House Bill 1847? House recognizes Representative Howard to close.
Thank you, Madam Chair. This is a real simple fix to a problem that was delaying getting the information that we need to make some timely improvements to save moms' lives. And I'll answer any other questions, but would ask you for favorable consideration, and hopefully this could go to local and consent.
If there's no objection, House Bill 1847 will be left pending. The chair hears no objection. House Bill 1847 is left pending without objection.
Thank you. I close.
The chair lays out House Bill 59 and recognizes Representative Goodwin to explain the bill.
Thank you, Madam Chair and members. So today I'm laying out House Bill 59, or COTIS Act. This bill actually passed the House last session, just did not make it past the Senate. So we are here again to address drowning prevention. This, just like the last bill, would save lives and also injury. So in June of 2019, 6-year-old Katy de la Pena drowned in a pool that she was visiting with her summer camp. Her mother had told the camp officials that Katy couldn't swim and had asked them to be sure to put a life jacket on her. But when Katy died, she was not wearing one. When Katy's parents, Corey and John, came to my office to share their story, I wanted to help them ensure no other parents had to go through this same pain. The result is this bill, COTIS Act. Too many Texas children drown every year, and these are preventable deaths. According to DFPS, an average of 90 kids have drowned annually in the state over the last 5 years. When a drowning occurs, it happens quickly and quietly. The only way to ensure the safety of non-swimming children in the water is to make sure they wear life jackets. COTIS Act is designed to enhance child water safety by providing specific requirements on organizations that provide water-based activities for children under 12 years old. This bill ensures that organizations such as day camps, schools, and child care facilities take appropriate measures to assess and address the risks associated with water activities. The parents would have to let the child care provider know if the child can swim, and if not, the child care provider would be required to put the life jacket on. COTIS Act establishes clear, simple, and consistent guidelines for organizations across the state. So together we can create a safer environment for our children. I do have some witnesses, and I would like to reserve the right to close.
Have any questions? No questions? Thank you. We will call testimony. The chair would call Karina de la Pena. Thank you for being here today. I show that you registered as Karina de la Pena, and you are here on your behalf, and you are for the bill. Is that correct?
Yes.
Thank you, ma'am. You may continue with your testimony.
Thank you to the committee for allowing the hearing, and I was hoping my husband would go first. I could tell you the story about Katy, but I'll just proceed with what I was going to tell you, and you'll hear more details from him. My husband and I took every step we thought would be possible to make sure Katy would be safe in their summer camp. We learned that as parents we were ignored, And we started to ask questions. We learned that Child Care Administration provides many types of training, including baby shaken syndrome, CPR. In fact, when they take kids in a vehicle to a field trip, they're required to take transportation training. As you know, child care ratios are high. When you add water activities to that, you increase that risk factor. Drowning is the #1 killer of children under 5 in the nation, and yet there is absolutely no training or language about drowning prevention in our child administration code. The purpose of the bill is to fill in that gap of non-existent water safety language. The bill was crafted by many stakeholders in the water safety industry across the state and the nation. The American Red Cross, U.S. Coast Guard, the YMCA, and many other leading aquatic professionals urge non-swimmers to wear a life jacket when around water. If passed, this will not only protect children from drowning, but it will also make the jobs of camp staff, aquatic staff, and lifeguards easier, as they would be identified as non-swimmers. A life jacket would be put on them before entering the gates of the pool. And we believe that it will increase the safety of groups of campers arriving at your pools. It would also bring water safety awareness to staff, parents, and caregivers. A lot of times, first-time parents, child care facilities are many times the first time they hear about child safety. That's when they learned about the flu vaccine, what vaccines they need, car seat safety, bike helmet safety. We want water safety and drowning prevention to be part of that awareness. We believe that if we begin to add water safety language, those conversations will begin to happen between staff, parents, and caregivers, bringing drowning prevention awareness directly to parents. Our bill is simple. The life jacket can be brought by the parent or the camp. It does not cost the state any money. We feel that the bill would be a significant step towards drowning prevention for children in Texas. And last session, Gatti's Act passed this committee and the House overwhelmingly, and we ask that you help us do this again this session. So thank you so much, and I'm here for any questions.
Thank you, ma'am. Do we have any questions? No questions. Thank you for your testimony.
Oh, this is my little girl.
The chair calls John De La Peña. Thank you, sir, for being here today. I see that you registered as John De La Peña. You are here on your behalf, and you are for the bill. Is that correct?
That's correct.
You may continue with your testimony.
Good morning. Thank you, Madam Chair and committee members. Thank you for representing all of us in our great state. Like I said, my name's John De La Peña, and I'm a guardian and Gatti's dad. I'm here to talk to you about our daughter, Gatti, and, why we wound up here in front of this committee. In March of 2019, like Representative Goodwin said earlier, we enrolled both of our daughters at High Hope Summer Camp in Cedar Park. We took every precaution we could. We toured the camp with the director and our girls to make sure that we all felt comfortable with the staff in the facility, and to make sure that the staff knew that Gatti could not swim, and that we told them that in writing and verbally. We asked about bringing her own life jacket on the days the camp would visit the pool, but we were assured by the camp director that there were life jackets available and we did not need to bring Gatti's own life jacket. On the second day of camp, June 4th, Corey, my wife, dropped the girls off at camp, and unfortunately at 3 p.m. that afternoon, we got a call about an accident at the pool, and basically just asking me where they should take Gatti to, what hospital. So we raced to the hospital here in Austin and got there before the ambulance even showed up. We were there when the EMTs brought in our daughter and worked on her in the emergency room. The medical team worked on her that evening, and she was able to be transferred to Dell Children's Hospital the next morning. The teams at both hospitals tried their best, and we are so thankful for them, to them for that. We now know that God was just giving us a little bit more time with her. But she did go to heaven that afternoon. Every day since then has been a struggle, but we have managed through the grief and the pain because of our faith. We are here because Gatti taught us how to advocate for her and how to fight for what's right. We know that nothing we can do can bring her back, but after finding out the details about what happened that day, we know this was and is preventable, and we don't want any other families to go through what we have been through. We told the camp she could not swim, to put a life jacket on her. They did not. We asked all the right questions, made all the correct requests, yet that was still not enough to have our clear instructions followed by the camp. All the state agencies involved have told us they have done everything according to their standards. The camp refused to change their policies, but eventually they did close down. We know that the way to make this change is through legislation. If a child does not know how to swim, then a child care organization should know it and properly place a life jacket on that child before they enter the water facility. That's all this bill is about, water safety for our children. We entrust our children to these organizations. This can happen to anyone's child or grandchild. We know that life jackets save lives. We believe this so much that on Gati's 7th birthday, we launched our nonprofit organization, Live Like Gati, to keep her legacy alive. Every spring and summer, we donate and deliver life jackets. Last year, we did over 40 summer camps across the state. We'll be up to over 1,600 life jackets from the Panhandle to the Rio Grande Valley, from Houston to El Paso. We try and deliver them in person to be able to train those camps as well as much as we can. Last summer, along with our partners at Collins Hope and the Health Human Services Child Care Administration, we were also able to provide over 1,000 hours of online water safety training to child care staff across the state. That's about 800 staff members for each of these camps. Many of the staff that were attending the training were very surprised that this type of training hasn't been available to them before, and mentioned that pool trips are when they are the most stressed about something happening. And it does happen. It happened to us. And our Gati. Thank you.
Members, any questions? Thank you for being here and taking what was a real tragedy to,
thank you.
You know, some action.
Mm-hmm.
Thank you.
Reggie had a question.
Chair calls David Zane.
Good morning, Madam Chair Click and other committee members. My name is David Zane. I live in Austin here, and I am testifying as a private citizen in support of House Bill 59 on child water safety. As an active swimmer, I add my voice to others speaking today to raise awareness on the importance of water safety in our state. I am retired now, but I had a career as an epidemiologist, and I can say that drowning is a public health problem in our state. Over 400 Texans die yearly, or to put it another way, on average, one Texan dies every day from fatal drowning. Different types of water settings pose different levels of risk depending upon age. Infants under 1 most often drown in bathtubs. Children between the ages of 1 to 14 most often drown in swimming pools. Children or teenagers 15 years and older, and adults most often drown while in natural waters like lakes and rivers. But young children are at most risk of drowning. Texas children 1 to 4 years of age had the highest death rate among any age group in our state. Around 60 of these children die from drowning every year. Let me put it in a different perspective for you. Drowning is the leading cause of death of our kids 1 to 4 years of age, the leading cause of death. We have about 1.5 million kids in that age group, and drowning killed more of them than car crashes or birth defects or homicide or cancer. Drowning is the leading cause of death of our kids 1 to 4 years of age. But drowning is not always fatal, though. There are many non-fatal drownings that occur. Non-fatal drowning has a range of outcomes, from no injuries to serious injuries like brain damage. Many patients do not fully recover, however, resulting in long-term neurological complications. It is estimated that for every fatal drowning of a child, there are 8 other children that seek emergency department care for a non-fatal incident. This bill focuses on kids under the age of 12. There were 94 children in that age group that drowned in 2021, 94. And if you apply that 1-to-8 ratio to that, I would estimate that there were 800 children in that age group that sought emergency department care for non-fatal drowning. These are clearly preventable. So despite these sobering data, we all know that drownings are preventable, and I thank you very much for your time for me to speak today on water safety, which is a public health issue in our state. Thank you.
Questions, members? Thank you for being here.
Thank you.
The chair calls Christopher Albin. I show that your name is Christopher Albin, and you represent the North Texas Aquatics Association and yourself. Is that correct?
That is correct.
And you are testifying for the bill.
That is correct.
Okay, please begin.
Thank you, Chair Click and members of the Public Health Committee. My name is Christopher Albin. I'm the president of North Texas Aquatic Association. It's a not-for-profit 501c3 public charity organization, and I'm here representing the interests of aquatic operators in 115 counties in the state of Texas. Our member agencies have a long-standing tradition of promoting, maintaining, and educating the public, as well as other aquatic professionals in programming, service, and management. North Texas Aquatic Association works to develop and maintain the health and safety of all types of aquatic facilities within the area and around the state. In addition to serving as the president of NTA, I also serve as an aquatic supervisor for the City of Plano Parks and Recreation Department, and I have personally facilitated and seen the positive effects of CATI's Act. I appreciate the opportunity to appear before you as North Texas Aquatic Association expresses our full support in favor of House Bill 59, because with drowning as the leading cause of unintentional deaths for children under 5 and the leading causes for ages under 15, our belief that is layers of protection are the best way to prevent tragic water incidents. Life jackets act as an important layer of protection to protect non-swimmers especially. Additionally, active supervision, proper barriers, and having trained responders are other important layers of protections at our pools. Aquatic operators across North Texas and the state, we're always implementing ways to advance water safety tactics that ultimately keep our citizens safe while in and around water at our pools. Not only is CATI Act great practice, it has also shown positive outcomes. The City of Plano has taken these steps in creating extra layers of protection when it comes to safeguarding non-swimmers or at-risk swimmers visiting our aquatic venues during official day camp or daycare visits. With the anticipation of CATI's Act, our agency thought that the measures presented would not only further protect camp and daycare participants from drowning, it would also increase layers of protection for our aquatic staff and lifeguards. Prior to the start of our summer 2022 outdoor pool season, while not required, we decided that we would implement the measures presented in CATI's Act. What we found by the close of summer was that the policies implemented were a huge success. Jack Carter Pool, which is one of the locations that I supervise, in the summer of 2022 was considered the busiest season in its history, with an average of just shy of 1,100 visitors per day, where we would see about 2 different day camp daycares per day during the week. Visiting camp daycares would be typically between 50 and 100 campers, which would add a noticeable strain on operations during their visit. Our operations team and lifeguarding staff would need to increase their zones of coverage to ensure proper surveillance was taking place. With staff not knowing what each swimmer's skills were compared to previous summers, summer of 22 brought more reassurance that at-risk and non-swimmers were equipped with U.S. Coast Guard approved life jackets. Ultimately, we saw a decrease in active drowning responses for our aquatic staff, which we believe was in part of the efforts implemented within CATI's Act. House Bill 59 takes important steps to advance water safety in our aquatic venues and makes children in Texas safer. With the positive results already showing with our member agencies, North Texas Aquatic Association is in favor for and fully supports House Bill 59.
Questions, members? Thank you.
Thank you.
The chair calls Alyssa Mangrum. Alyssa Mangrum, I show you testifying on behalf of Central Texas Drowning Prevention Act Team, Collins, Hope, and yourself. Is that correct?
This is correct.
And you are for the bill.
I am in support of the bill.
All right, thank you. Please begin your testimony.
Thank you so much. Good morning, all. Thank you for your time, your service, and your attention. My name is Alyssa Mangrum. I am speaking in support of House Bill 59. I've worked in water safety and drowning prevention for the last 14 years. And I've worked with over 100 families who've lost or almost lost children to drowning. Remember the names Kati, Roxy, TJ, Christian. Those are names of 4 children who've drowned while at summer camp. Sadly, there's many more, and there are more families like Corey and John De La Pena. These children were all non-swimmers and were not identified as such when they went to pools and lakes, and they were not put in life jackets like this one. Tragically, an $11.86 life jacket like this one would have saved their lives. As a water safety expert, I train aquatic professionals, I train lifeguards, I train summer camp staff. And in lifeguard trainings, we talk about the greatest risks and challenges that lifeguards face. When I ask lifeguards to tell me how they feel when a school bus full of children pulls up outside of their facility, and those children get off, often with only a few adults with them, they say these are absolutely their worst and most stressful days of their job. They know nothing about the swimming ability of those children. Even the best and most well-trained lifeguards can miss a struggling child in a busy pool. Often the chaperones that bring those children cannot swim themselves. A drowning child can often look the same as a splashing and playing child. Life jackets on non-swimmers like these would save a life, keeping them on top of the water. I also serve as a water safety advisor to a summer camp here in Austin. This camp requires all campers to be in life jackets when swimming in Barton Springs and when canoeing on Lady Bird Lake. They have now added water safety training for their staff, their volunteers, parents, guardians, and have added questions on the camper and staff applications to better understand each person's swimming ability and level of water competency. They understand the risks and dangers of taking children to water and the importance of protecting the campers. I wish all camps would do the same thing, and at the very least, identify non-swimmers and put them in life jackets. Under Kati's Act, lifeguards would easily identify non-swimmers as they entered the facility and before they got near or in the water. These children would have an extra layer of protection to keep them on top of the water. Lifeguards and camp staff could do their jobs more easily and keep children in their care safer. Families would have their children return home safely from a day at camp, sharing stories of swimming and boating and playing with their friends. A life jacket costs $11.86. There are many organizations in Texas, such as Collins Hope, Live Like Kati, the LV Project, and many other civic organizations that would help provide those life jackets if needed. Life jackets are a layer of protection. They save lives. Thank you so much for your time.
Questions, members? Thank you. Is there anyone else wishing to testify on, for, or against House Bill 59? Chair recognizes Representative Goodwin to close.
Thank you, Madam Chair and members. As you have heard from the testimony, this is a bill that could save lives, but also save emergency room visits and save parents from the trauma of drowning accidents. So with that, I ask for your favorable consideration, and I close.
Representative Collier has a question.
Hi, Representative, thank you, Madam Chair. On page 1 and 2 of the bill, it says this section does not apply to a youth camp license under Chapter 141. What is that?
So I believe that's DFPS has their own, or actually Boy Scouts. I believe that's the Boy Scouts. Anyway, the reason for the exception is that they're already covered under a similar law that requires either a flotation device or training.
Okay, because here it says, this is under the health, I just clicked on 141 from the bill, and it says this chapter may be cited as the Texas Youth Camp Safety and Health Act. So I don't see like and that's chapter 141. It says youth camps. So I'm not sure. It says it's for day camps. It does not include the camps that are licensed with the Department of Family and Protective Services.
You know, I can get back to you on that.
Okay, I just wanted to see, because it seemed like it excluded everybody you're trying to address, but I wasn't sure. Just want to make sure.
I will double check.
Okay.
So that I give you accurate information.
All right.
Representative Jones.
This bill seems like a no-brainer to me.
Yeah.
I know, sad to say this, but I know a number of kids that have drowned. My brother, I mean, in the law, pools are considered like attractive nuisances because kids that don't know how to swim, they don't always know they don't know how to swim. It just looks so easy. And I'm so sorry about what happened to Tati. And I'm glad that her parents are trying to do something to make her death not be in vain. But I was going to have the same question as Rep. Collier, because I'd like to know why anybody is taken out of it. But I know you don't have the answer yet. We can work on that.
Sure.
But I also know that kids push kids in the pool. I know that. And I can remember when I was in college, one of the guys that we were recruiting at my university literally told everybody I can't swim. And everybody was pushing people in, and for whatever reason, they thought he was lying. And they pushed him in the pool, and he almost drowned. By the grace of God, I was able to save him. I almost drowned in the process, but I'm still here. But my point is, I'm actually surprised that this doesn't always already exist, but I'm happy to support it. Yeah. But I just need to know why anybody is pulled out, because my sister was on the Houston-Harris County Child Fatality Review Board, where they investigated deaths of children from birth to 16, and there were a number of drowning deaths, which again, they were trying to focus on which deaths were preventable. And I also think that, like the gentleman who came up before, we shouldn't be just looking at who drowned, because you can get a lot of damage, brain damage, and all other kind of things. Right. So you don't have to actually die in order for it to profoundly affect you and your family. So thank you for being astute enough to bring this. I appreciate it.
All right, and I'll find out about 141.
Representative Tinderholt.
Thank you, Madam Chair. So all the stats are showing 15, so I'm just curious, have you thought about making it 13, 14, and 15 as well? And if you don't have that answer right now, I'm fine with it, but it's a consideration that's going through my mind.
Sure. That age came about last session in working with all the stakeholders, and that was the age that we reached that everybody could agree to.
Okay. Thank you.
You're welcome.
Other questions, members? Thank you, Representative Goodwin.
Thank you.
If there's no objection, House Bill 59 will be left pending. The chair hears no objection. House Bill 59 is left pending without objection. The chair lays out House Bill 1876 and recognizes Representative Guillen to explain the bill.
Thank you, Madam Chair. Members, there are tens of thousands of Texans receiving dialysis due to impaired kidney function. The cost of providing this treatment is high and directly affects Texas taxpayers. This disease continues to grow at an alarming rate, but early identification of chronic kidney disease combined with appropriate intervention can delay the progression of the disease. By doing so, we could reduce suffering, allow for fewer deaths, and reduce healthcare costs in the state. Members, HB 1876 will create a chronic kidney disease centralized resource center within HHSC. It'll encompass a multi-layered approach to provide awareness, education, and resources at every level of chronic kidney disease for the general population as well as for healthcare professionals. The Chronic Kidney Disease Centralized Resource Center will also help address the lack of standardized referral process for early detection, treatment, and kidney transplantation. In coordination with the Chronic Kidney Disease Task Force, it'll create a website for the center that'll include all information and resources directly related to combating and creating awareness around chronic kidney disease. Members, we're working with the agency to better understand why the fiscal note multiplied from last session to this on the same language. And today and testifying today, we have Mrs. Littlefield with us. She has worked for more than 3 decades to improve the lives of kidney patients in Texas. She's been the driving force behind
our Kidney Disease Task Force, and at age 89, her commitment to this cause is inspiring, and it's because of her dedication and advocacy that we're here laying out this bill today. I can help answer any questions if y'all have any.
Questions, members? We'll reserve your right to close.
Thank you.
Chair calls Rita Littlefield. Good morning, Ms. Littlefield. I show your name is Rita Littlefield, and you're testifying on behalf of the Chronic Kidney Disease Task Force and yourself, and that you're for the bill.
Yes.
Is that correct?
Correct.
Great. Please begin your testimony.
Well, I think my testimony begins 30 years ago. As I looked down at my daughter laying in her casket, I made her a promise that I would not walk away until kidney patients were recognized, which they haven't been. As we all know, we have a service at the Department of State Health Services. It's moved over to HHSC now, I think, but it's a service division. We have never had prevention or anything for our patients, and it is a silent disease. It's a silent killer. And if we do not do something now, it is going on. I have been involved since there was 5,000 patients in the entire state of Texas on dialysis. Now we have over 77,000. And that is not something that even Medicare can take care of very much longer, because at $138 billion for chronic kidney disease and end-stage renal disease, it's going to break the bank. And we have got to do something, and prevention can do that. And if you have listened to what Representative Ginn had to say, it lists so many things. We had 8 doctors on the task force, and all of them were extremely busy in actually trying to make sure that we had everything covered that would help patients. And I have, besides my daughter, of course, that was 30 years ago that she passed away this past December, but I have not been away from patients at all. I have stayed in touch with the patients, with families, and I am here to actually beg you today to make this happen, because if it doesn't, it's going to be really bad. As I said, talking about the funding, the funds that were spent, at first, I remember it cost about $16,000 a year to dialyze one patient. Nowadays, it costs over $100,000 to dialyze one patient. And throughout America, we have, one figure I saw was over 700,000, and that was on the Society of Nephrologists. And I don't know that, I know that some of their figures were pretty old, but of course, some of the reports that we get are too, like CDC updates every couple of years, USARDS, actually, the United States Renal Data System actually puts out a report annually, and according to them, you know, we're spending, as I said, $138 billion a year. Medicare is, I'm sorry, and Medicaid is involved in that in many cases. So in Texas, you have some of that, but most of our patients, no matter what their age is on Medicare.
Great. Thank you for your testimony. Questions, members? Thank you for being here.
Thank you.
The chair calls Tiffany Jones-Smith. I have your name is Tiffany Jones-Smith.
Yes.
And you are representing the State of Texas Kidney Foundation and yourself, is that correct?
Yes, ma'am.
And you are for the bill.
Yes, ma'am, I'm for the bill.
Please begin your testimony.
Good morning, Chair Click and esteemed members of the committee. My name is Tiffany Jones-Smith, and I proudly serve as the president and CEO of the Texas Kidney Foundation, and I'm a member of that task force that Ms. Rita just mentioned. As the state's early detection leaders, we have implemented the most comprehensive nonprofit free testing program in both Texas and the nation, testing over 16,000 Texans to date. Under my leadership, we have identified the disease in 36% of those we've tested, providing essential early detection and interventions in those in need. Moreover, we have also created and launched the most successful PSA campaign in Texas, reaching 39,000 homes and engaging with the public about the importance of early detection, care coordination, educating the public and practitioners about kidney diseases, lifestyle changes, and food as medicine. Our PSA campaign has been viewed an impressive 362 times, with 37,000 homes watching the PSAs all the way through, achieving a remarkable engagement rate of over 90%. In fact, we've outperformed even Super Bowl commercials in terms of engagement. I am honored to be here today in support of House Bill 1876 by Representative Guillen, which is a critical step towards enhancing early detection, improving communication and reporting among practitioners, and standardizing methods for combating kidney disease. Kidney disease affects about 1 in 7 adults, but 9 out of 10 of those adults affected by kidney disease do not know that they have it. Without proper treatment, kidney disease can progress to kidney failure. At that point, only a kidney transplant or dialysis, both very expensive, can keep you alive. As someone who lives with APOL1, a rare genetic allele associated with kidney disease, and I've experienced the devastating loss of 15 family members to this and other chronic forms of kidney disease, I'm deeply passionate about medical transparency, because there's a big problem with that. Practitioner clarity, patient empowerment, raising awareness, and advocating for standardization of early detection. My personal connection to this illness drives my unwavering commitment to educating both the public and medical practitioners in order to prevent others from experiencing the same heartache and loss that I have. My vision for House Bill 1876 is the creation of the Rita Littlefield Resource Center, which would provide a comprehensive resource for all kidney diseases, including both chronic and rare kidney diseases, because we're discovering more and more connections to kidney disease than just chronic. Currently, patients face significant challenges due to a lack of transparency in communicating early-stage chronic kidney disease. Although current standards recommend that practitioners monitor patients, they often fail to inform patients after the detected stage of the disease until it reaches stage 3.
Excuse me.
The recommended diagnosis stage.
Your time has expired.
Oh, I'm sorry. Okay.
Questions, members? Thank you very much for your testimony.
Thank you. And please support this bill.
Is there anyone else wishing to testify on, for, or against House Bill 1876? Chair recognizes Representative Guillen to close.
Thank you, Madam Chair. If there's no further questions, I'd ask for your favorable consideration.
If there's no objection, House Bill 18, I'm sorry.
I actually just wanted to say something. My ex-husband died at 54 years old when his kidneys failed. A number of people in my family have had kidney disease, and I think this is, again, I think it's a no-brainer, just so you know. But I believe that people don't understand the impact on families. I didn't realize how long dialysis is. I once had a staffer who I allowed to leave to go to dialysis. I'm certain it negatively affects business in the economy in Texas. I'm certain of it. I don't know how much it costs, but you told me it's expensive, so I'm going to trust you on that. When I was on city council on City of Houston, I actually rode with the ambulances for 24-hour shifts. And the vast majority of all the calls were people who had dialysis, who needed to take dialysis. Anyway, I say that to say this, that I think that if we get a handle on this and people get early detection, because I know you can fix it if you detect it early, I think it'll save a lot of stuff from your health to just the economy in Texas. So, thank you.
Absolutely. So most dialysis patients either go every day or every other day to a dialysis center for treatment. And so you can imagine what that costs throughout a year or several years of treatment per person.
Thank you.
Thank you.
If there's no objection, House Bill 1876 will be left pending. The chair hears no objection. House Bill 1876 is left pending without objection. The chair lays out House Bill 663 and recognizes Representative Theory to explain the bill.
Good morning, Madam Chair, Vice Chair, and esteemed members of the committee. Thank you for the opportunity to lay out House Bill 663 for you today. This bill seeks to address the maternal mortality and morbidity data backlog. As many of you recall, and Representative Howard testified as to this earlier this morning, just last year, the Maternal Mortality Review Committee was unable to timely release its findings, its data findings, on or before September 1st, 2022, pursuant to statutory authority. Our former commissioner, Dr. John Holistad, revealed it was due to the committee's inability to complete review of the case studies in time. Much of this had to do with the cumbersomeness of data collection and retraction. In the Maternal Mortality Review Committee, I will refer to that sometime as the MMRC, and the DSH's Joint Biennial Report in 2022, the committee expressed a need for process improvement strategies for maternal mortality, review protocols to support and increase case review capacity, quality, and recommendation. House Bill 663 would assist the Maternal Mortality Review Committee and DSH's with data collection and review going forward. Maternal data registry can play a direct role in setting new benchmarking standards and inform policy to improve maternal health outcomes and help eliminate preventable maternal mortality and morbidities. House Bill 663 establishes a work group comprised of health experts aiming to establish a secure maternal mortality and morbidity registry under the DSH's with the goal of improving the quality of maternal care. The purpose would be to record information submitted by participant healthcare providers on the status of maternal patients over varying periods. This would include metrics such as the frequency and characteristics of the mother's postpartum period. The work group would also assess a variety of factors related to maternal health and prepare a report with recommendations for the data registry. The agreed-upon language of this bill was provided by multiple stakeholders and directs DSH's to establish a work group to examine the efficacy of this registry. The work group, in conducting its review, would review existing or planned registries within or outside the state to identify best practices related to registries serving the same or similar purpose, review current efforts and initiatives within the state to avoid duplication of efforts and to ensure efficiency, and review and consider existing laws that govern data submission and sharing. Members, this bill was carefully drafted with expert recommendations as well as numerous meetings and discussions from stakeholders across the state. You may recall that we passed this bill last session and got it out of the House, but we did not, the infamous statement, it did not move through the Senate in time. So we have a unique opportunity here to get out the blocks early. Also, members, I would like to just share with you personally that several zip codes in my district suffer from the highest rates of maternal mortality in our state. It is vital that we have accurate data to be able to properly address the needs of all of our constituents and mothers across the state. What we do know, once the data was released, although it wasn't released in September, it did come before we convened for this session. The data that we received showed that Black mothers are still at an increased risk of maternal mortality, 2 to 3 times the rate of all other groups. And even when the AIM safety bundles were implemented, members, which is a protocol that providers will take in the event of an emergency for a mom in labor or while pregnant, even when the protocols were implemented for hemorrhage, the good news is hemorrhage went down for all other women with those AIM safety bundles, except Black women. Not only did it not go down, members, the rate of hemorrhage went up for Black mothers, and some actually became statistics, maternal mortality statistics as a result. This innovative piece of legislation, as I stated, received broad bipartisan support last session. As I stated, we have an opportunity, and I ask that we take this practical step towards saving and improving the lives of Texas mothers and babies. As most would agree, our moms are the nucleus and hearts of our Texas families, our moms and our babies, and this legislation shows support for both. Members, I believe I have some witnesses, and there's some handouts before you. I would ask that you take a look at those. There's support from the Texas Hospital Association that I work very closely with to draft this legislation.
Members, any questions for Representative Thiry? All righty, we'll reserve your right to close. The chair calls Jody Harrison. Up next will be Taylor First and Zenobia Joseph. Jody Harrison, Taylor First, and Zenobia Joseph. If you'll state your name, who you represent, and your position on the issue, please.
Yes, ma'am. Good morning, Chairwoman Click, Vice Chair Campus. My name is Jody Harrison. I am an ordained Baptist minister and chaplain, and I am speaking today on behalf for this bill.
On behalf of yourself or the organizations?
Okay.
You're testifying on behalf of yourself?
Yes, I am testifying on behalf of myself.
Thank you.
I am a member of other organizations. I completed a chaplaincy residency in Dallas Children's and Texas Scottish Rite Hospitals. My hospital chaplaincy of almost 10 years was primarily in neonatal and pediatric intensive care units. I worked with all types of trauma, which often included moms who lost their pregnancies. I provided pastoral care to patients, their families, and hospital staffs. I'm also a member of Texas Impact's Maternal Health Leadership Team and an active member of the Texas Baptist Women in Ministry. In my former life, I was in the political arena as a Texas House staffer for several legislators, as campaign coordinator for Texas State Supreme Court Justice Barbara Culver, and as a staffer for U.S. Senator John Tower, both in Dallas and D.C. offices. So with all due respect, gentlemen here, it is a joy to see so many women legislators, a woman chair, and the diversity on this committee. I have followed every single one of your committees, hearings, and both online and in person, and I have to say, it is a blessing to hear the questions from so many different backgrounds. This is nothing like the 1990s. As clergy, I first go to Scripture. Ezekiel 37, 1 through 14 is this week's reading, where God takes the prophet Ezekiel into the dry bones valley. God raises up these bones and puts flesh onto the bones and breathes the spirit of life into them again. To me, These dry bones represent and remind me of how horrific our Texas standards are for women in pregnancies, with the mortality rate, and with all the complications that still happen in hospitals and elsewhere for our women here. House Bill 663 would provide the vital statistics and the critical medical information, and the Texas Maternal Mortality and Morbidity Review Committee will shine a light on how to prevent deaths for future pregnant women and infants. Your vote yes today, or when it is voted out, will protect women's lives and those who love them, including the children who are often left behind when a mom dies. Thank you very much. Any questions?
Questions, members? Thank you for your testimony. On deck next will be Taylor First and Zenobia Joseph. Taylor First and Zenobia Joseph. Dinah Warwick. Up next would be Hattie Mason.
All right. My name's Dinah Warrench. I'm a certified nurse midwife in community practice in the Dallas area. And I'm speaking on behalf of myself. I'm also a member of the Consortium of Texas Nurse Midwives. And so I will also be on behalf of them too, although I didn't write that down. Oh, okay. Well, I'm a member.
Yeah, I've got you testifying on behalf of
myself.
yourself.
Okay.
Okay.
As a maternity care provider and a citizen. Let's go with that. So representatives of the committee, members of the public, thank you for this opportunity to testify. I'm grateful to all of you for dedicating time and energy to the topic of our maternity care crisis. It is a crisis indeed, when the rate of women dying in pregnancy and birth-related events is higher than in any developed country. And the number of women dying increases every year. And the United States is the only country with an increasing rate. And Texas is always near the bottom of the pack. Every one of those deaths is of a young mother. Every one of those deaths creates a motherless child. Equally shocking is the racial inequity of the outcomes. 3 times as many black mothers are dying as white mothers. So, of course, I testify in favor of House Bill 663. The Texas Maternal Mortality and Morbidity Review Committee is our instrument for examining, analyzing, and understanding what is happening to the mothers of Texas. It is their responsibility, based on their analysis, to recommend what actions are needed by our healthcare system to reduce the number of mothers dying. As such, it is a committee of huge significance and great responsibility. Our state legislature must do everything that it can to facilitate its vital work. So there are 3 topics covered in H.R. 663. The first is a no-brainer. The honorable, we're very fond of those bills here, I hear today. The honorable women and men who serve on the MMRC give of their time and their expertise to us citizens freely and with dedication. We must reimburse their basic expenses. It's amazing it's not even covered. I would like to point out that this is particularly relevant to the community members on the committee who may have less resources than the professionals who serve. The second topic is also a no-brainer, representatives. Let us make the hard work of the committee smoother and more efficient. Texas, I have been told, is the only state which requires nurse redaction of records prior to review by the MMRC. And Representative Howard did talk about that earlier. It's included in both bills. This slows down the work of the committee greatly. The recent biennial report was delayed partly due to the difficulty of getting to all the relevant records in time. Let's give the nurses exemption from the reporting requirements that make this necessary. Of course. The third topic, no surprise, representatives, is a no-brainer. The work of the MMRC starts with the data. The members gather death data from multiple sources, which is both time-consuming and hampers accuracy. Of course, we need a register of maternal deaths. The working group to establish such a data registry must be formed right away. We must always remember that every month that we are not acting to facilitate the work of this committee, young women are dying. Let's help our dedicated Texas MMRC to function, and let's get them the data that they need. Thank you very much.
Questions, members? Thank you. Maddie Mason, followed by McKenna Wilson. Good morning, Ms. Mason. I show your name is Maddie Mason, and you're testifying on behalf of New Life Perinatal Health Care Service.
Well,
and yourself?
Pregnant women, healthcare providers.
Okay. I have that you are testifying on behalf of yourself and that you're for the bill. Is that correct?
That I what?
You're testifying for the bill.
Yes.
And you're representing yourself.
Yes. And pregnant women. Can I just say myself? Okay.
Just yourself.
Just myself. Okay. Good morning, Chair Click, Vice President, Vice Chair Campos, and the other members of the committee. My name is Maddie Mason. I am a registered nurse that has worked with the perinatal nursing field for over 40 years. Perinatal nursing is a new term for most people. Perinatal nursing means from conception to the first year of life, which includes the newborn baby. I have been a DSH case manager in the Houston and Harris County for over 30 years, caring for high-risk pregnant women and children. I am testifying on behalf of myself. Thank you for the leadership and the opportunity to testify on this topic of maternal health. It is my hope that you will make maternal health priority for all women and families across the state of Texas by ensuring the provision in legislation. As a woman, a mother, grandmother, healthcare provider, and taxpayer, I am deeply concerned about the state of maternal care in Texas. It is with this concern that I'm asking you to pass House Bill 663, which develops a work group of subject matters experts to establish the process of closing gaps of maternal mortality and morbidity health data by creating a statewide online maternal care registry that will compile clinical data on pregnancy-related death and near death. Also, a recommended goal would be to collaborate with the DHS case management program and re-implement the PWI program to ensure care for high-risk Medicaid eligible clients. The problem is Medicaid in dealing with these women. For me, I have taken, during COVID, we provided services for over 500 women or more, helping them access Medicaid. And once they accessed the Medicaid, then they were able to get into a medical home to cover them for their entire pregnancy. And the carve-in to the CPW with MCOs have decreased the level of care. It is an unrealistic goal to think managed cares can provide case management for high-risk infants, mothers, and children. It is critical that our maternal health care providers understand the causes, trends, and patterns of maternal deaths in Texas so that we can respond and improve the care. In my experience as a former NICU nurse and a mother baby, as a case manager, I work to help high-risk pregnant women receive prenatal care early, improving the outcomes of the mothers and babies. I urge the members to vote for House Bill 63.
Thank you.
Thank you.
Members, any questions? All righty, thank you. Next on board is Nikina Wilson. Nikina, I show that you are with the Maternal Health Equity Collaboration and yourself, and you were for the bill. Is that correct?
That is correct.
Thank you. Please begin your testimony.
Good morning. Thank you to everyone who serves on the committee, to Chair Click and to Vice Chair Campos. I am Nikenia Wilson, and I am representing myself as well as the Maternal Health Equity Collaborative. While I'm also the community advocate on the Maternal Mortality and Morbidity Review Committee and the survivor of severe maternal mortality. I am coming today in support of Bill 663, and there are just a couple of things that I would like to highlight. In the review process of this committee, that is a unpaid committee doing the work of the state to protect Texas moms and babies, to improve outcomes, they receive a varying amount of information, depending on what is submitted to them after request. Okay, so that means that sometimes we get certain medical records, sometimes they would get information from family members, and sometimes they don't. And it makes a difference. Sometimes it fills in the gaps that help the committee to be able to make the most accurate recommendations and determine preventability, as well as if it's pregnancy related, which is the work that the state is required to do. I also would like to highlight the fact that the redaction process as it currently stands, we are the only state in the country that requires that. And that redaction process, depending on the case, can take dozens up to over 100 hours for one case. And that slows us down. If you are aware, before this last report, we were reporting data that was over 5 years old. We have gotten better because we have the CDC grants, and so we're more contemporary. But as an example, we just went through COVID. We need to know in real time how those moms were affected by COVID and their deaths. But as it stands, we won't get to that data quickly enough, right? So those are a lot of instances where we need more accurate and timely data. The last thing I'll say is that this gives a voice to families and individuals who've been impacted by loss, because sometimes they don't have an opportunity to voice critical insight based on their loss and their trauma. So I am in support of this bill as a survivor myself, and I hope that you will be as well. Thank you. Any questions?
Yes.
Representative Collier.
Thank you. Thank you so much for this information. I definitely appreciate Representative Thiry being a champion on this cause for maternal mortality and morbidity. Now, if we are to allocate resources to help improve health outcomes, wouldn't you agree that we should have good data to know where we put those dollars?
Absolutely.
And so this bill would help us to identify root causes and help us to be more fiscally responsible with our dollars to help improve those health outcomes.
Absolutely. It would definitely increase the efficiency and save money.
All right, thank you.
Mm-hmm.
Other questions, members? Thank you.
Thank you so much.
Chair calls Taylor first, Zenobia Joseph. Is there anyone else wishing to testify on, for, or against House Bill 663? Chair recognizes Representative Thiry to close.
Thank you, members. Texas leads the country in areas of research and technology. However, it is beyond time for our state to be on the forefront of improving maternal health outcomes with high-quality metrics on our statewide maternal health care services. This bill will provide hospitals and clinicians with a low-cost, accessible tool that will drive quality improvement of maternal health outcomes in our state. The result is a low-burden tool that gives clinicians the perinatal performance metrics and benchmarking data they need to drive quality improvement. I would ask that you vote this bill favorably out of the committee. And with that, I respectfully close.
Madam Chair, I have a question.
Representative Collier.
I would, again, want to thank you for being a champion on this issue, but I felt like we heard this bill last session. Didn't we pass this bill?
Yes, I testified earlier. We passed this swimmingly out of the committee and out of the House, and we had broad bipartisan support. I believe last session, Chairman Oliverson was a joint author. I want to thank him always for his leadership on these issues. And so let's hope we can help Texas moms and babies again this session.
Thank you.
Through the Senate.
Super.
I respectfully close, members.
All righty, thank you. If there's no objection, House Bill 663 will be left pending. The chair hears no objection. House Bill 663 is left pending without objection. The chair lays out House Bill 852.
I'm back, but it's a quickie.
The chair offers a complete committee substitute and recognizes Representative Theory to explain the measure.
Good morning again, members. I appreciate the opportunity to lay out House Bill 852. Last year, the Texas Maternal Mortality and Morbidity Review Committee was diligently studying and reviewing cases as they are charged with to identify trends, rates, and disparities in maternal mortality. Shockingly, the report found that over 90% of the related deaths were preventable. The committee was also tasked at developing recommendations to reduce maternal mortality in Texas. The recommendations that were highlighted here stated a need for new expertise currently missing from the committee. In response to these recommendations, HB 852 adds specialized physicians in emergency care, cardiology, anesthesiology, oncology, a community advocate, and a representative of a managed care organization. The bill also amends the Health and Safety Code to ensure that members serve terms with 1/3 expiring on February 1st of each odd-numbered year. Members, this bill was brought to me at the direct involvement and somewhat request of the committee. These are the recommendations for the additional members of the committee that they have identified. And I'd be happy to answer any questions, but I believe we have some expert witnesses and other witnesses on the bill.
Representative Alverson.
Thank you, Madam Chair. And Representative Theory, I just want to thank you again for your work on maternal mortality. I know that's personal, and I know that you're just an amazing champion on this, and so I commend you. And I'm excited that we're putting some more people on this task force. I think, when things go wrong in pregnancy and we have a high-risk pregnancy, it's often the case that the treatment is multidisciplinary, meaning that you need a whole team of folks to address the issues. And I remember my very first publication in anesthesia had to do with primary pulmonary hypertension, which is fortunately extremely rare. But I had a patient that ultimately had to deliver her baby in the cardiovascular ICU with all kinds of catheters and stuff and breathing this special gas just to keep her blood pressure at a normal level so she didn't die immediately after giving birth. And so it's just, these are the things that we have to think about. These are not simple issues, obviously. So I just commend you for sticking to this, and I look forward to seeing this bill become law.
Thank you so much, Chairman.
And your other one, too.
Thank you so much.
Questions, members? All righty, we'll begin our public testimony. The chair calls Nikina Wilson. On board next will be Barbara Orlando, followed by Jody Harrison.
Hello again, Nikina Wilson, representing
the Maternal Health Equity Collaborative, as well as myself as a survivor of severe maternal mortality, but also serving as the only community advocate on the Texas Maternal Mortality and Morbidity Review Committee. I am in support of this bill, having both just as a member of the community, but also having had the last 2 years of serving on the committee, recognize that we have more maternal deaths in Texas than some states have in 3 years, in just 1 year. And so the time that it takes, the review committees typically meet about 20 times a year, unpaid. And I happen to be local, but most are not. And I do not get paid for what I do, serving on this committee. But it's important that we add the additional expertise, because sometimes committees, when there's a committee review, there are additional questions that need very specific answers to make sure that there is the best recommendations possible for improving outcomes. In addition to that, specifically, I want to speak to the addition of another community advocate. As it stands right now, you have one community advocate who is representing every mother and baby in the state of Texas. That happens to be me. And it is an honor and a privilege, but it is also a heavy burden. I, having survived hemorrhage and almost losing my baby in 2016, every time I review a case, I am subjecting myself to additional trauma. But I also am proud that someone who is in community can speak and give a voice to the voiceless. As you look to the structure of the committee, there are currently 3 smaller groups that meet to make sure they're not breaking quorum. If there's additional committee members, that means that there would be probably another, a 4th, which means they can go faster. And there would need to be another person that's a non-medical professional to make sure that there's a lens for lay people, so that when they're looking at it in a medical lens, there is a community advocate looking at it to say, well, what about this? What about that? Here's what I'm seeing as someone who has experienced this. So I hope that, and I believe that you all have already done such great work to protect and to support moms and babies in Texas, and I look forward to you supporting this bill as well. Thank you.
Questions, members? All righty, thank you. Next on deck is Barbara Orlando, Jody Harrison. Dr. Orlando, I show that you're representing the Texas Society of Anesthesiologists and yourself, is that correct?
That is correct.
And you're for the bill?
I am in favor of the bill, yes.
Thank you. Please begin your testimony.
Good morning, Madam Chair, members of the committee. So my name is Dr. Barbara Orlando. I'm here today representing myself and the Texas Society of Anesthesiology in support of House Bill 852. On behalf of the 3,800 TSA members statewide, thank you for your time today. I'm the Chief of Obstetric Anesthesiology at Memorial Hermann Hospital, Texas Medical Center. I'm an Associate Professor of Anesthesiology and Adjunct Associate Professor in OBGYN at the McGovern Medical School at the University of Texas Health Science Center in Houston. I have over 22 years of experience. I specialize in obstetric anesthesia with a special interest in maternal health and wellness. My interest in maternal health has been growing over time, as the number of high-risk parturients and women in labor who are at higher risk of maternal mortality and morbidity. The reason I am in favor of this bill is that anesthesiologists are essential in labor and delivery, not only because they provide pain management and pain relief during labor, but they also take care of maternal comfort and safety during childbirth. They are trained to handle any complication that may arise during the delivery process. In addition, obstetric anesthesiologists often have the unique task of being the intensivist in the obstetric suite, someone who possesses the adequate training and skill to take care of critically ill patients. According to the statement on level of maternal care that has been issued by the American College of Obstetrician Gynecologists and the Society of Maternal and Fetal Medicine, the maternity service with the highest level, which is level 3 and 4, should include the 24/7 anesthesia service coverage, as well as a board-certified anesthesiologist who has a special training or experience in obstetric, who is in charge of the obstetric anesthesia service. Outside of the labor and delivery room, anesthesiologists are taking on leadership roles to reduce maternal mortality and morbidity rates and are leading efforts to make physicians and nurses aware of the early warning signs of pregnancy complication. However, the Texas Maternal Mortality and Morbidity Review Committee does not currently include an anesthesiologist. Because of our hands-on role in labor and delivery, TSA strongly recommends this committee and legislature to support the House Bill 852 to add an anesthesiologist to the review committee. Requiring an anesthesiologist to participate will provide essential insight and perspective into the case that are being reviewed by the review committee, and it will increase the level of collaboration in Texas on this important topic. I would like to thank this body and Representative Thierry for the strong work you've done to help combat maternal mortality and morbidity in Texas. And I appreciate your favorable consideration of this next piece of the puzzle. Thank you. Happy to answer any
questions, members. Thank you. Next up is Jody Harrison, Zenobia Joseph, and then Taylor first. I show that your name is Jody Harrison. You're representing yourself and you're for the bill. Is that correct?
That is correct, Madam Chair. Thank you. I have very little here to say except to ask for support of this bill. And I want to say one of the reasons is for those of us who have worked in a hospital setting, when you have different experts come together within the community, you hear so many different types of experiences. And when those all come together regarding a particular patient, then you get a better picture of the situation at hand. Therefore, I urge you today, as a chaplain and as an ordained minister who often hears a lot of different stories from moms and their families, please vote for this bill, and thank you for your support.
Questions, members? Alrighty, thank you. Zenobia Joseph, Taylor first. Is there anyone else wishing to testify on, for, or against House Bill 852? The chair recognizes Representative Thierry to close.
Thank you, Madam Chair, Mr. Vice Chair, members. With that, I ask that you vote this bill favorably out of committee, and I respectfully close.
The committee substitute is withdrawn, and if there's no objection, the bill will be left pending. Representative Jones.
Representative Thierry.
So we've already closed it.
Closed.
Okay.
The committee substitute is withdrawn, and if there's no objection, the bill will be left pending. Is there objection? The chair hears none. HB 852 is left pending. The chair lays out HB 2088 and recognizes Representative Busey to explain the bill.
Thank you, Madam Chair and members, for allowing me the privilege to lay out House Bill 2088. House Bill 2088 is a cleanup bill from the 87 session, a bill that we passed together called Kevin's Law. It was House Bill 1935. This legislation gave pharmacists the authority to dispense a 30-day emergency supply of insulin and insulin-related products. An unintended issue we're encountering is prepackaged dose packs of insulin pens often exceed a 30-day supply. Insurance companies have been pushing back on reimbursement for medication that falls under this category. This bill amends the law to allow the pharmacist to dispense the smallest prepackaged insulin dose so long as it has at least a 30-day supply, even if it provides a few extra days because of how this medicine can be prepackaged. Just slightly could end up 32 days, 33 days of dosage. In reviewing the language as filed, we need to make a non-substantive technical change, and we'll do so by committee sub to address the reimbursement issue. The bill also reconciles discrepancy in two bills passed unrelated to me in the 86th legislative session brought by the agency. First, this bill will clean up the law to provide specific violation authority of the Texas State Board of Pharmacy and strikes the unintentional broader authority. Second, the bill clarifies that the board only has authority over the license when they are practicing as a pharmacy technician or pharmacy technician trainee. That's some agency cleanup, and I'm sure there's someone here from the agency if we need to get more into that. But really what we're doing, good intention, but sometimes the prepackaging of this medicine doesn't fit right within the 30 days. So we're just amending it to be the closest to that as possible, even if it goes slightly over, to make sure they can get this emergency insulin as needed. If there's any questions, otherwise I reserve my right to close.
Questions, members?
I know we have one witness with pharmacies.
Okay. We'll begin our public testimony and
Thank you,
reserve
Madam
your
Chair.
right to close.
I do.
The chair calls Amy Lusson, or Lucen, I'm sorry if I didn't pronounce it.
The first time.
Okay, Amy Lusson, and I show that you are representing the Texas Federation of Drugstores and yourself, and you're for the bill. Is that correct?
Yes, that's correct.
Please begin your testimony.
Yes, thank you. Good morning, Chairman Click and members of the committee. My name is Amy Lesson, and I'm here today speaking in favor of HB 2088 on behalf of the Texas Federation of Drugstores. I'm a director of pharmacy and retail operations with Walgreens. Physicians spend a lot of time with patients with diabetes to establish an insulin dosage and medication that is right for each individual. That decision is based on that patient's specific severity of their disease state, weight, diet, genetics, and that person's lifestyle. So even people with the same diagnosis and weight may have significantly different dosage requirements. For this reason, the number of units a person will require over a 30-day period will vary greatly. The pharmacy industry is very appreciative of Representative Busey's legislation from last session, House Bill 1935. However, due to the wording requiring that the emergency insulin or supplies cannot exceed a 30-day supply, the industry is concerned that these come prepackaged, as he explained, and may exceed a 30-day supply for an individual. Prepackaged pens cannot be broken up into smaller doses, and likewise, the vials cannot be adjusted to provide exactly a 30-day supply. For some people, this prepackaged amount may actually exceed 30 days. An example of this would be a patient who injects 25 units of insulin a day. Depending on the type of insulin or the pens that they use, it could last anywhere from 30, 32, 34 days. Because the law requires that it cannot exceed a 30-day supply, this puts the pharmacy at risk of not being reimbursed by the patient's insurance provider because it exceeded the greater than not to exceed amount. To date, pharmacies are providing the closest amount to the 30-day supply to those patients needing an emergency supply, even if this prepackaged amount exceeds the 30 days. This bill helps clarify the language to allow each patient to receive a 30-day supply and the pharmacies to be assured they will be reimbursed accordingly. It allows pharmacies to care for these patients on insulin therapy and ensure they have that continuity of care. I think it's really important, especially considering in 2022, there's been a year-over-year growth of 16.9% of anti-diabetic medications in the United States. So we have more and more patients on these medications every year. I can provide you a couple of pictures of the different types of the packaging if you want to see what it looks like, what the pens look like. The insulin pens are large writing pens. They help prevent under and overdosing. They often don't require refrigeration. They're conveniently pre-filled. They're a lot more durable. They're easier for a patient to carry around with them. There's also a jet injection device, and they're an option for patients that hold several different doses of insulin, and after you place it against your skin, you press a button and it's pushed through. Most of the vials come in 10 ml vials, and they expire 28 days after they're opened. The smallest available package of a vial may actually last a person only 15 days. So to do this 30-day supply, we're giving a patient 2 vials to make sure they have enough to last the full 30 days. I want to thank you so much for your time today, and we encourage you to pass this technical cleanup bill, and I'm happy to answer any questions you guys may have.
Questions, members? Ready, thank you.
Thank you so much.
Is there anyone else wishing to testify on, for, or against House Bill 2088? Chair recognizes Representative Busey to close.
Members, this is just a technical cleanup from a good bill we all passed last session, so if there's no further questions, I will close. All right, thank you, Madam Chair. I close.
If there's no objection, HB 2088 will be left pending. The chair hears no objection. HB 2088 is left pending without objection.
This is 2478. That one. Chair lays out House Bill 2478 and recognizes Representative Click, Chairman Click, to explain her bill.
Thank you, members. Section 33.011 of the Health and Safety Code requires newborn screening tests for core and secondary conditions listed in the recommended uniform screening panel. These screening tests are done on all blood drop cards collected by heel pricks at birth. HB 2478 effectively changes a biennial report from DSHS about newly added screening conditions for newborns to an annual report that includes information about what newborn screenings the recommended uniform screening panel has recommended. I'm open to any questions and reserve the right to close.
Thank you, Chair Click. Members, are there any questions? Chair calls Stephen Holland. Chair shows your name as being Stephen Holland, representing yourself, and you're testifying today for the bill. Is that correct?
That's correct.
Okay, you may begin your testimony.
Good morning. My name is Stephen Holland. I am past chair and current vice chair of the Board of Directors of the National MPS Society, and I'm here today representing over 2,600 families touched by MPS and related diseases. I'm also the father of 3 MPS 1 children, Spencer, Maddie, and Lainey. My son passed away 15 years ago at the age of 18. My daughters, Maddie and Lainey, are 31 and 29 years of age and live with my wife and me in River Oaks, Texas, where I work as a CPA and have served as an elected city council member for my hometown, the city of River Oaks, Texas, for the past 29 years. Lainey is with me here today on the front row. I provided oral testimony before the Secretary's Advisory Council for MPS 1's nomination to the RUSP in 2012 and 2015, and was thrilled when it was finally added in 2016. I am saddened when I stand before you 7 years later as a proud Texan, realizing that 33 states have already added MPS 1 to their newborn screening panels, while the greatest state, and the one with the second largest number of births in the United States, has not. Why should a child born across the state line in Oklahoma have a better life than a child born in Texas because we have not yet started newborn screening for MPS? Once your child receives a diagnosis like MPS 1, a parent feels an overwhelming desire to make things right by that child, to create as equal a playing field in life as possible for that child, who obviously was born with a huge disadvantage of having a terminal genetic syndrome through no fault of their own. One of the most important ways of doing that is providing them with a medical treatment that will help prevent further damage by their condition and help sustain their life, whether that be stem cell transplant or weekly ERT. The problem is that we as parents cannot begin these treatments until we know our children have the disease. It often takes many months and sometimes many years between noticing there's a problem to getting a diagnosis. During this diagnostic odyssey, irreparable harm is being done to our children that future treatment will not be able to reverse. This delay in diagnosis and treatment often creates parental guilt and regret for not following up sooner on these conditions or for not forcing their pediatricians to follow up these earlier, causing great parental concern and complaints of an overbearing parent. Once it is too late, parents realize that they lost that precious time when early treatments could have forever changed their children's long-term clinical outcome. However, with newborn screening, all of this regret, guilt, and conflict with the medical community over delayed diagnosis is eliminated. Treatments can start immediately, which essentially eliminates the long-term clinical life-limiting and life-ending effects of these diseases. Early treatment gives that child the level playing field that we as parents so desperately desire and for which our children so decidedly deserve. Without it, parents wonder what my child would be like if he or she had only received treatment since birth. Another important benefit from newborn screening is reducing the births of affected siblings. In my family, all 3 of our children were affected, though the odds were that with each birth, it would have only been 1 out of 4. Because our kids were born close together, we didn't realize there was a problem while we were having children. If newborn screening had indicated my son had MPS I, we would have used the benefits of genetic counseling to prevent my daughters from also being affected. We know many families with more than one affected child who indicate they would have done the same thing, reducing the overall prevalence of the disease and the resulting demands on society in general and on our family individually. So in a nutshell, it comes down to time and options. We are all blessed to live in the greatest country in the world where we have the ability to prevent most, if not all, of the permanent damage caused by these diseases by providing parents with these treatment options at birth. So let's do just that. I, along with all of the MPS I, MPS II, and POMPA families, support Texas HB 2478 in its annual reporting requirements regarding newborn screening with RUSP-approved conditions in Texas.
Thank you, Mr. Allen, for your testimony. Members, are there any questions of this witness? We appreciate it. Thank you.
For your time.
The chair calls Mercedes Johnson. Ms. Johnson.
Good morning.
Good morning. We show your name is Mercedes Johnson. You're representing yourself this morning testifying for the bill. Is that accurate?
That is correct.
Okay, please begin.
Thank you. My name is Mercedes Ramirez Johnson. I'm a resident of Denton County, Louisville, and I'm very proud to be here representing rare disease families. Particularly newborn screenings is very near and dear to my heart. My 2 youngest sons, Dorian and Wynn Johnson, were born with mucolipidosis type 2, which is under the umbrella of the family of MPS diseases. Unfortunately, ML2 is the most aggressive and fast-acting of those lysosomal storage diseases. The average lifespan for a child with ML2 is anywhere between 3 to 6 years. I was blessed to have my son, Winnie, for 6 years, and my son Dory for 10 years, and they beat the odds for many, many reasons. But their bodies were still ravaged by the aggressive nature of ML2. The importance of early diagnosis through newborn screenings is absolutely vital for Texas families. A family can go months, if not years, with their doctors knowing something is wrong with their child, but not being able to come up with a diagnosis in a timely manner, where all of this could be easily avoided if the newborn screenings were enacted. That could mean the difference between a child who can sit up and feed themselves and walk and talk versus a child who does not have the ability to do any of that. And although ML2 is not currently on the federal RUSP, it's imperative for families like mine to have it added on the state level as soon as possible as it is cleared through the federal level. We don't have the luxury, at least for ML2 parents, we don't have the luxury of many, many months, if not many, many years, for that switch from the federal level for it to begin to be thought of and considered on the state level. And so as a mom of a rare disease child, I did not choose to be thrown into this rare disease community. It's one of the most inclusive yet exclusive clubs that you want to be in. But with all of our parents and all of the families across the state of Texas who have a rare disease warrior in their home, the number one thing that you want to do as a parent is be able to provide your child the best quality of life, the most pain-free existence, and the most happiest existence. And one of the most measurable ways that we can do that is by adding ML2 and MPS diseases onto the newborn screening panel. Does anybody have any questions for me?
Thank you for your testimony. Thanks for sharing it with the committee. Representative Jones has a question.
I'm sorry, did I just hear you testify that you lost 2 children?
I lost 2 children, yes, ma'am.
One was 6 and one was 10?
Yes, ma'am.
I'm so very sorry for your loss, and I'm actually very thankful that you're sharing this with us because I didn't know. And I think children should be screened, so thank you so much.
Thank you. Thank you for your support. That their legacy lives on through the advocacy work that I do, so I appreciate that.
And I'm sorry, what are their names again?
Dorian and Wynn.
Okay, thank you.
Thank you.
Any additional questions, members? Thank you very much for your testimony.
Thank you.
Is there anyone else wishing to testify on for or against House Bill 2478? If not, the chair recognizes Representative Click to close on the bill.
Members, changing this report will allow the legislature to see in more real-time manner what newborn tests need to be added to the newborn screening panel and enable us to respond more quickly to emerging medical needs. Thank you, and I close.
If there's no objection, House Bill 2478 will be left pending. The chair hears no objection. House Bill 2478 is left pending without objection.
The chair lays out HB 3212 and recognizes Representative Toth to explain the bill.
Thank you, Madam Chair and members. HB 3212 is named Mallory's Act after baby Mallory, who sadly died because of an MCAD deficiency. In Texas, we test for MCAD deficiency during the newborn screening. However, by the time the test results came back, Mallory was in the emergency department. The Department of State Health Services called the hospital to relay the newborn screening results, only to be told that Mallory was already coding. MCAD deficiency leads to a baby starving to death. When I heard this, I filed House Bill 3212 to increase the efficiency of newborn screening process. And you can tell by the bill number that this issue came to my attention fairly early in the legislative session. And since that time, I've learned quite a bit about what went down. Hospitals from around the state send their newborn screening specimens to be tested at DSHS here in Austin. Because of this process, Section 3 of the bill needed to be completely rewritten, and we're working on with stakeholders right now to craft a new committee substitute. We discovered during our research that currently DSHS does not process newborn screenings on Sundays. This seems like an obvious place to start. But here are a few changes for the subcommittee. First, DSHS needs to be open 7 days a week, and we're working with them right now to figure out what the fiscal note will be on that. We revised the disclosure to instruct parents of risks involved in declining the newborn screening, as well as the importance of reviewing the results as soon as they're received. We added the information in the disclosure on the importance of newborn screenings to the informational pamphlet currently required by law to be given to parents and newborns. We are removing the penalty from this, and I'm going to walk you through basically what happened and what typically can happen with the failure of not having testing on 7 days. If a baby is born on Friday, they don't take the sample from the baby, the blood sample, until Saturday, at which time it's sent to Austin. Unfortunately, DSHS is closed on Sunday, which means it's not tested until Monday. And in a situation like that, the baby will be in distress by the time the parents and the doctor is notified. And you're going to have the opportunity to hear from Mallory's mom in just a moment. With that, I'll entertain any questions, and if you have any.
Questions, members?
Thank you, and I ask for the opportunity to close.
Super. Chair calls Bailey Burns. Bailey Burns, I show that you are representing yourself and that you're for the bill. Is that correct?
Yes, ma'am.
Already, please begin your testimony.
Okay, well, this is my daughter, Mallory. She was 4 days old when she passed away. Thank you all for having me here today before you. On September 23rd of 2021, I gave birth to a beautiful baby girl. Her name is Mallory. Throughout the entire 9 months of growing her in my womb, I was confident she was healthy and was going to go on to live a very fulfilled, long life. I gave birth to her at Christus Good Shepherd Hospital in Longview, Texas. According to her newborn screen results, it revealed that her newborn screen was drawn September 24th, a little over 24 hours after she was born, which is ideal in the newborn screen time of collection. It was received at the state lab here in Austin, September 27th. All newborn screens, all newborn screens are processed and read at this laboratory. The Department of State of Health Services writes the national recommendation that first newborn screen specimen should arrive at the state lab within 24 hours after collection. In Mallory's case, that did not happen and is very unacceptable. When it comes to the shipment of the newborn screening specimen, a quick delivery of specimens is imperative. It immediately becomes a race against time. For some of these disorders, there's a very fast-moving clock. Every minute counts. It has to be collected appropriately, and it has to be shipped, and Texas is a big state. It's a centralized lab. It cannot sit in a laboratory. It cannot sit in a transit port before it gets here to Austin. Timing of delivery and results are critical, especially for a newborn who is positive for a rare genetic disorder that can cause life-threatening symptoms by the first week of life. The newborn screen tests for 63 rare genetic disorders. That is why a newborn screen exists. I feel that the hospital I delivered her at was not mindful of the time between collection and shipment. I also believe that the hospital I delivered her at is not the only hospital in Texas that delays their transit of newborn screen specimens. MCAD and other rare genetic disorders are treatable and managed if caught in time. They would have given Mallory a feeding tube to ensure she was eating and also a dose of an amino acid called L-carnitine. This was entirely preventable. Babies survive with MCAD every day. I have friends that have babies with MCAD. They are surviving. I know without a doubt that Mallory would still be alive today if her newborn screen specimen results came back within a timely manner. Mallory's Act will ensure that babies can have a true chance of survival if we can get the newborn screen results of the newborn baby back within 48 hours of birth and have the lab open 7 days a week. The importance is the newborn screen identifies conditions that can affect a child's long-term health of survival. Early detection, diagnosis, and intervention can prevent death or disability and enable children to reach their full potential. Many rare diseases result in premature death of infants and young children or are fatal in early adulthood. 20 to 30% of all infant deaths are due to genetic disorders. Just like Mallory, baby with these disorders may look healthy at birth. Many problems cannot be seen. How it works is that a few drops of blood are taken from your baby's heel and put on a blood spot card. The card is sent to the state lab. The test results go to the birth hospital or your doctor. They will call you if any problem is found. However, if a problem is found, it could be entirely too late, just like it was for my child.
Your time has expired. Questions, members? Thank you for being here today and sharing.
I'm sorry.
Representative Jones.
I'm sorry. Did I hear? First of all, let me tell you I'm sorry about your daughter.
Thank you.
Did I hear you? How long did it take for them to send the lab?
Her newborn screen was drawn 24 hours after she was born, and it was according to her medical record, it said that the state lab, it was collected on September 27th.
And she lived for 4 days. Did you have?
And she died the next day, September 28th.
So, and you're saying that had the test been expeditiously sent, they could have done something to help her. So in other words, her death was preventable.
Yes, it was. It was entirely preventable. Yes, ma'am.
Very rarely am I at a loss for words, but I'm so sorry about that.
Thank you. Thank you all for having me here before you today. Thank you.
Chair calls Rich Wheeler, followed by Bonnie Abram. And next on deck will be Steve Woolub. Show your name is Rich Wheeler and you're representing yourself and you're for the bill, is that correct?
Yes, ma'am.
Alrighty, please begin your testimony.
Chairman Click and representatives, thank you for allowing me the chance to talk to you. I am a family member of Bailey's and Mallory by extension. I also happen to have just finished up serving my third term as mayor for the city of Shenandoah, Texas. You may remember the city of Shenandoah, Texas as David Vedder's home, who was the boy in the bubble. David Vedder suffered from what's known as SCID, which is severe combined immunodeficiency, and unfortunately he passed away from that. However, David's legacy is that because he brought light to this condition, no babies die from this anymore. It's now treatable, and almost all babies that are born with SCID live long, healthy lives. Our hope for today and what we are asking for today is to let Mallory's legacy be that no more babies die from this, that these test results are given in a timely manner and a very treatable symptom can save other babies' lives, and this doesn't have to happen again. And I'd be happy to take any questions.
Questions, members? Thank you.
Thank you.
On deck next is Bonnie Abram, Steve Woolub. Bonnie Abram, Steve Woolub. Show your name is Bonnie Abram and you're testifying on behalf of yourself and you're for the bill, is that correct?
That's correct.
Thank you. Please begin.
I'm speaking on behalf of all the grandmothers. I'm the grandmother of Mallory Burns and the mother of Bailey Ann Burns. I was there from the time that Mallory took her first breath to the time that Mallory took her last breath. So I speak on behalf of all the grandmas that they will never have to endure this. Mallory was born on September 23rd at 3:40. I was there when she came into this world, and then her newborn screen was drawn September 24th at 9:30. They came and got her, took her for a newborn screen. We left the hospital Saturday. Everything was good. Mallory was a healthy, happy baby as far as we could tell. Monday, not Monday, but Tuesday morning, Mallory was crying, and Bailey changed her diaper. She had a poopy diaper, and then Mallory started gasping for air. At 7:30, I just talked to my husband, like, everything's great with Mallory. She's doing great. She's good. At 8:15, Mallory quit breathing. Mallory was turning blue. I said, give her to me. Bailey handed Mallory to me, and I started CPR on my grandbaby. Bailey called 911. I did CPR on her, and I got her back. She was back. Her eyes opened up, and here she was. I was so relieved. Oh, we're good. Ambulance came. Fire truck came. They said, do you want to take her to the hospital? Absolutely. We took her to the hospital. I laid her on that stretcher, which no grandmother should ever have to lay their grandbaby on a stretcher. And they coded her for 3 hours. They did great with her. Life flight came, couldn't keep her heart started. So Dr. Healy came, got Bailey, and wanted Bailey to sit and watch in the ER room what they were doing to Mallory. And Bailey's like, why do you want me in here? So you can see I'm doing everything for your little girl. About 30 minutes later, Dr. Healy sat with Bailey on the floor and hugged her and told him to stop CPR. Mallory was pronounced at 11:40 on Tuesday morning. As Bailey was holding Mallory, Dr. Healy came back in the room and said Mallory had a genetic disorder, that she died of MCAD, which more or less, as Steve said, she was starving to death. So Mallory's newborn screen was received at Austin on 9/27, which was a Monday, and Mallory passed away the Tuesday. And we got the results back later on, but it was too late. If we would just had them the day before or 3 hours earlier, she could have survived. So minutes matter. Thank you all for letting me speak.
Questions, members? Thank you for being here and sharing your story. I know it's hard.
Yes, ma'am.
Thank you. Chair calls Steve Woolab. And Mr. Woolab, I show that you are with the Texas Hospital Association and you're neutral on the bill. Is that correct?
That's correct, Madam Chair. Thank you for the opportunity to be here today. I think a lot of what we were going to say today has really already been said. We understand HB 3212 is an attempt to minimize the chances of anything falling through the cracks in this process of newborn screening and testing and getting the results back. We've certainly heard and understand about the devastating and tragic consequences that delays in the processing of the initial screening can have. We had discussed the bill with Representative Toth's office last week. We appreciate the opportunity to do that. The concerns we raised and the reason we were neutral on the bill seem to have been addressed in what Representative Toth was describing as a potential substitute coming. So we're looking forward to reviewing that language. In particular, we were suggesting that the information be included in the pamphlet that is already given to new parents, and it sounds like that might be a possibility in the substitute, as well as the elimination of the penalties. And so we look forward to continuing to work with Representative Toth's office and welcome any opportunity to give input into improvements into this critical process.
Questions, members? Alrighty, thank you.
Thank you.
Is there anyone else wishing to testify on, for, or against House Bill 3212? The chair recognizes Representative Toth to close.
And Madam Chair, I just want to say before whatever the words are you say, to make you not be able to say anything, I had a question for him.
For the hospital? Oh, yes, ma'am.
Okay, Representative Jones, go ahead and ask
Okay.
your question.
So I see here that there's an administrative civil penalty of not less than $500,000.
No, we're working on a committee sub right now. So if you'd like to work with us on it, we'd love your help.
Yes, because I was trying to figure out if it was a strict liability. And I mean, although I don't represent.
So when we first drafted this bill, we were only aware of the issue with dishes being closed on Sundays and not running these tests on Sundays. We've since come to find out, after my meeting with the Texas Hospital Association, that there was a failure on the part of the hospital in this as well, where they took like 3 days to send the sample out to dishes. So dishes is not entirely at fault in this, although we've identified the fact that, yes, there's an issue. If you're a baby born on Friday and you have MCAD, you run a risk, a real risk. But in what we've since found out, though, is the hospital was at fault in this thing.
Okay, so I just like to see the committee substitute.
Yes, ma'am.
Because I was just wondering if I'm presuming serious bodily injury is defined somewhere. And I just wanted to know if a baby died, like you automatically have to pay this civil penalty. Are there any exceptions? I just don't know if there's something out of somebody's control. That's all I was wondering.
Yes, ma'am. Let me just close with this, and if you have any other questions afterwards, kids aren't supposed to die before their parents. They're certainly not supposed to die before their grandparents. And I guess what makes this so just incredibly difficult is that this was preventable. This never should have happened. And I hope you'll work with me, all of you, in crafting a committee substitute that will make sure that this doesn't happen again. And thank you, Madam Chair, for hearing the bill. With that, I close.
If there's no objection, House Bill 3212 will be left pending. The chair hears no objection. House Bill 3212 is left pending without objection. Members, we're going to stand at ease for just briefly, and the committee, just for a minute. Order. The chair lays out House Bill 1686 and recognizes Representative Alverson to explain the bill.
Thank you, Madam Chair, and members of the committee for allowing me to lay out House Bill 1686 for you today. House Bill 1686 prohibits healthcare providers from performing procedures and providing certain medical treatments for the purposes of gender transitioning, gender reassignment, or gender dysphoria for children. Multiple systematic reviews say there is no high-quality scientific evidence that hormone therapies, puberty blockers, or surgery help children overcome gender dysphoria or lower the risk of suicide. Despite that, no evidence exists or that the evidence that is cited is of low quality or very low quality. Multiple American medical organizations have consistently advocated for these treatments as being standard of care. In addition, there is meaningful evidence that children are being physically and emotionally harmed by unintended consequences, side effects, and change of heart that sometimes occurs after the initiation of hormone therapy and puberty blockers. Members, those of you that were on this committee last session remember hearing a similar measure where we were told that the effects of all of these medications are reversible. We knew then that that was not true, and in fact, science has now caught up and has acknowledged that much of what happens to an adolescent who is treated with hormone therapy or puberty blockers, and certainly surgery, is irreversible. Without conclusive, high-quality evidence, doctors engaging in gender transitioning young people are effectively experimenting on children and, unfortunately, oftentimes preying on the fears of confused parents. For many years, professional counseling has been a proven alternative that helps girls and boys overcome dysphoria, depression, anxiety disorders, and in fact, scientifically remains the most effective treatment for adolescent gender dysphoria. I want to be clear, it is my belief that parents are often put in difficult positions when presented with a situation where a doctor and a mental health professional are recommending the prescription of puberty blockers and hormone treatments for the purposes of changing a child's birth gender, or else the child will commit suicide. This is an unenviable and no-win position. It is not, unfortunately, fortunately, it is not supported by scientific fact, but it is a situation which many parents have found themselves in. And so I want to be clear that this is why House Bill 1686 addresses a prohibition on the medical and surgical treatment in children and does not criminalize parents. I would also add that this bill contains a broad list of exemptions for treatments of genetic conditions which are medically verifiable, where there might be a situation where a child has ambiguous genitalia or an intersex condition or some sort of antibody or hormonal imbalance which is inborn and would prevent the normal development of secondary sexual characteristics and gender and sex. And as we hear testimony today, I would ask each of my fellow committee members to consider asking critical questions regarding the quality of scientific evidence being presented, and specifically if folks could cite the author, journal, and year of the publication. I would like to reserve my right to close, but I'm happy to take any questions that you may have.
Question, members. Representative Tinderholt.
Thank you, Madam Chair. Thank you, Representative Alverson, for bringing this bill. You and I have talked, and I'm honored that you have this bill, and I know it's can't be a good situation for anyone that's even considering this, and I think all of us will keep that in mind as we go through this. But I first wanted to say thank you for bringing this bill. And I also told you I had a few questions, so I'm going to ask those questions early. Was there any consideration to making a civil cause of action similar to what we did last session with the heartbeat bill?
That was certainly talked about, Representative, but I think that the appropriate venue for regulating this is through the Medical Board and the Medical Practice Act, as it turns out that the real dysfunction here is the lack of convincing, high-quality scientific evidence and a general unwillingness of the medical community to self-police and self-regulate on this issue. And so that is the reason why we're doing this. And so that's the direction that we elected to take.
Thank you. I have a couple of concerns that parents, and I don't see anything in the bill, correct me if I'm wrong, parents may consult with medical professionals across state lines and have medication, specifically puberty blockers, sent into the state. Does this cover that at all?
Representative, unfortunately, or fortunately, we are the state of Texas, and so this bill contemplates the practice of medicine, the practice of healthcare in the state of Texas. And with respect to sort of Jeffersonian principles that we are founded on, we cannot, nor should we, entertain telling another state what to do, just as we would respectfully ask them not to tell us what to do.
And the other one is very similar. If someone's being counseled to do this with their child and then they bring them across state lines to execute the actual surgery, would this be similar answer?
This bill doesn't contemplate medical care received outside of the state of Texas.
So as I was learning more about this, I learned a lot about detransitioning and a lot of people that wanted to do it after they got older. Does the bill discuss anything about detransitioning and the fact that they were abused as minors, now they're adults attempting to detransition and heal from the harm done? Does this even touch detransitioning at all, or is this just for the surgery itself, the initial surgeries and puberty blockers?
So, Representative, I would look at this bill as being a preventive measure to preventing people from having to experience detransitioning. I think you're going to hear abundant testimony today from detransitioners who feel as though they were pushed into or forced into or coerced into or just basically given a bill of goods that ended up being inaccurate. That this would solve their problems, that their suicidal, tendencies would resolve, and that they would be perfectly happy. And then, unfortunately, they have woken up, in their late teens, early 20s, some of them earlier, and realized that this wasn't at all what it was said it would be. They are no better than they were, and in fact, they're much worse. And now they just want to get back to a place to where they could potentially reclaim some of what they were originally given when they were born, but medically and surgically they are scarred permanently. So I would say, number one, this is a preventive measure to prevent folks from having to go through that again, because we recognize that a lot of these folks that are detransitioners are folks that began this treatment as adolescents, not people who began this treatment when they were adults. And in addition to that, I would say that there is other legislation out there looking at sort of the coverage of or the requiring the system to provide health care benefits to detransitioners. I think it's a travesty that every state or whatever, every insurance company, there are even states where the Medicaid system will pay for transitioning. But as I think you'll hear from witnesses today, once they cross to the other side, not only will their doctors and therapists disown them and refuse to acknowledge that they exist, but they're left with no coverage, and everything that they have to do to try to get back to where they started is out of their own pocket. And I think that's horrible.
That leads to my next couple of questions. I was going to ask if the bill requires insurance companies that paid for this to assist with detransitioning, and I think you answered the question that it's no. That's correct?
It's Representative. There is another bill on that, but it's beyond the scope of this bill.
What about statute of limitations? If someone had a surgery and say 15 or 20, I believe it's 2 years right now, but if it's 15, 20, 30 years later, does this cover that? Because sometimes it takes people a long time to realize that they really wanted to go back. This doesn't cover that either, correct?
That's right.
Okay.
And I'm certainly sensitive to what you're saying with regards, and I know there are other states and places where, you know, they have a different statute of limitations, and it may be less challenging to bring a suit against somebody that you believe, you know, scarred you for life.
And when it comes to that, and I just have two more questions. I don't want to monopolize, but one of the things was the economic cap. If there was something done that it's only $250,000, I'd like to work with you after this bill's done and see if there's any of these things we've talked about. But the last thing I want to ask is that I think we agree that counseling, professional psychological counseling with individuals, that there's a lot of value in it. But I have concern about therapists that try to psychologically transition these children to be the opposite sex. And what I mean by that is they might not be able to go do the surgery, but I fear that we may not be covering the medical professionals that are doing the psychiatric work and transitioning them without doing the surgery. Does this cover that at all?
So this bill leaves open the idea that since mental health services and treatments have been shown repeatedly to be highly effective, there are multiple good studies out there that show that if a child is expressing gender dysphoria and they're provided with supportive counseling and therapy, that a vast majority of them will either resolve by the time they complete the second decade of life, or it will mature into same-sex attraction. Neither of which is a good situation to have transition to the opposite gender.
Well, you and I,
yeah,
you and I have talked, and I want to reiterate. I know this is sensitive. I thank you for bringing this bill. I can't thank you enough. This is one of the most important topics to me, and I think to a lot of members. And I know it's important on both sides to the people out there. So I know that we're going to be respectful to everybody today, and I can't thank you enough for bringing this bill forward, sir.
I appreciate you, Representative. Thank you.
Other questions? Representative Johnson.
Thank you, Chairwoman. Representative Oliverson, or Dr. Oliverson, is gender dysphoria a true medical diagnosis and term?
I think that the concept is certainly something, but it unfortunately has become I would say it's become so expansive, so sort of pulled in many directions that I believe it to be an imprecise medical term.
Do you believe that there are physicians in Texas that are practicing gender-affirming care or treating gender dysphoria in a true and accurate way?
No.
You don't think there's one physician in Texas?
I think that the ones that are prescribing hormones and puberty blockers and referring patients for surgery as adolescents are failing to follow the science entirely.
And so referring for surgery as adolescents, you're aware that that's not a standard of care and that there are not surgeries performed in adolescents?
That's actually incorrect, Representative.
Could you give us the citation as you asked for?
I can tell you that when we heard this bill last session in 2021, we received public testimony from a physician, not in this very room, but in where we normally meet, who testified under public testimony that in fact we do mastectomies on girls under the age of 16. But then she added, but that's completely reversible.
Okay.
Of course, we all know that's not reversible. That's foolish to say that that's reversible.
And under your bill, mastectomies or cosmetic procedures would still be allowed for individuals as long as they're not claiming gender dysphoria?
Well, I think you have to distinguish whether or not we're removing normal, healthy anatomy or we're removing abnormal anatomy. And I think the example that gets thrown into the mix, which unfortunately is a mischaracterization, is a male adolescent with gynecomastia, which is an abnormal proliferation of breast tissue in an otherwise healthy boy. That is not a normal developmental condition.
Is cosmetic surgery considered to be removing abnormal tissue?
I'm sorry.
When you said that it's not happening unless it's abnormal, I'm trying to clarify. If somebody is getting
I'm not
breast-
aware of a mastectomy being performed or any breast reduction surgery being performed on anyone under the age of 18 for anything other than abnormal anatomy, other than what's happening here.
In this circumstance, though, under your bill, it does not contemplate if somebody under the age of 18 with parental consent wishes to have cosmetic surgery.
Such as?
So let's say you have a young girl that has one breast that is larger than the other, and that is causing her discomfort or emotional concern, or she's getting ridiculed in school and says, these do not match, and I want them to match. Under your bill, would they still be able to perform that surgery to correct the distinction between the two cup sizes in the two breasts?
Yes, that would be my understanding.
And so in that respect, surgery for that anatomy would still be allowed for a child that is claiming to have mental distress or concerns, as long as they're not expressing gender dysphoria.
I think that I think those are light years apart, honestly. I mean,
And the parents in those circumstances are participating in making those decisions. And one would be permitted under this bill, but the other would not, correct?
right. That's right.
Also, hormone therapy. The hormone treatment that is done can also be done for precocious puberty.
Actually, it's typically not done for precocious puberty. For precocious puberty, usually we prescribe puberty blocking drugs because it is an inappropriate expression of puberty. When you have a child that enters puberty before the appropriate age for puberty, there can be negative consequences to that, just as there would be for suppressing puberty at an appropriate stage where, you know, a child should be undergoing puberty and developing bone mass and continuing to have growth in the brain and the heart and other, you know, bodily systems.
And so in this circumstance, the same puberty blockers that you are indicating could still be prescribed by physicians in Texas.
Those
conditions like you just expressed.
There's a section in the bill, Representative, that specifically outlines a series of exemptions for the treatment of conditions that are medically verifiable genetic disorders, where there's an abnormal development. You know, puberty is not proceeding normally, or because of a chromosomal abnormality, a child may not ever have a normal expression of their sex assigned at birth.
And again, in those circumstances, so it's not a complaint over the surgical procedure, and it's not a complaint over the hormone because it's prescribed in other circumstances. The ban here is in circumstances where physicians, in working with the families, have determined that it's appropriate for gender dysphoria. That's the ban.
The ban is basically because, you know, has to do with conditions where the science is essentially inconclusive, poor quality at best. We have a growing list of harms that are being done. We have a growing list of people who have gone down this pathway because they were told it was going to solve all their problems, and now they are ruined.
And in that respect of science, in your term, being inconclusive at best, as a governing body, would it be more appropriate for us to maybe put together a combination of scientists, doctors, folks that we agree are experts within the field, and have them begin to do a study on the differing testimonies that we may hear today as to whether or not the efficacy is good for Texas public policy or not?
So, Representative, I contemplated that, but the reality is that that's already been done 5 times. By countries around the world that have far better ability at gathering record keeping because of their national health services, have much better data to be able to analyze this, and also have had more experience farther along this pathway than we have. So I don't know what value we could possibly add by basically, you know, if 5 out of 5 systematic reviews agree that the evidence for this is lacking and that this is a poor standard of care that is leading to harm and that it doesn't confer any benefits in terms of reducing the risk of suicide or improving gender dysphoria, then I'm not sure what we could possibly add at this point.
If today we had a number of Texas physicians or even Texas medical associations and groups that were to come up to say that they have differing studies or opinions, would that maybe raise the question of whether or not it would be more appropriate for this body to do something like create a study?
Again, I would say that this issue has been looked at exhaustively by the greater scientific community. And so I don't anticipate that doctors in Texas are a microcosm that is completely insulated from the rest of the world.
But it would
this issue is a worldwide issue, right? And so I think that what's really disturbing to me is that a number of groups in America and a number of physicians in America have failed to pay attention to the multiple systematic reviews that have already been done and essentially either do their very best to silence or squelch out any dissenting scientific opinion, which is in and of itself non-scientific, or have completely just ignored the risks and the changing and evolving knowledge that we have on this subject.
And I guess my question from a policy perspective is, there are steps within our process and system by which we could do a study. If it is a slam dunk, as you say, then we may be back here in 2 years with the documentation to say this is the right thing for us to do. But doing a study is possible. I know that's not what you want to do, but I'm just asking, is it a step that this state could take?
I think it is certainly always a step that could be taken, but I don't think that it's a step. I think it's a waste of resources at this point. Again, I would ask you, what could we possibly add to the 5 comprehensive systematic reviews which have already been undertaken? I mean, this is sort of like, yes, you can continue to do a study on gravity over and over again to prove that gravity still exists. You can always do that. But the question is, when 5 out of 5 comprehensive systematic reviews conclude the same thing, what value is there in doing a 6th?
We could also put together part of the medical board, put together a review. I know that's hard, maybe because you said there's not one good practicing doctor in Texas on this issue, but presumably we could find medical personnel that are qualified and have them participate in coming up with a plan or a schedule by which would be, if you don't agree with today's current standard of care, an additional element or safeguards to not have what you claimed is experimenting and preying on fears of parents.
Yeah, and again, Representative, we can do all of those things, right? We could do nothing.
We could do those things.
We could just ignore the systematic reviews that are already out there. But again, my point is this has been done. Okay. This has not been done once. This has been done fairly exhaustively. There's nothing for us to add.
Let me also ask about the uniqueness of intersex. This bill does not ban parents from making a decision early after birth and picking the gender of the child that is intersex.
Those would be medically verifiable genetic conditions associated, with an abnormality of normal development.
And in that circumstance, the parents often choose the gender, maybe because they were hoping for a girl or they had their grandfather's name picked out. But the parents get to choose the sex of the baby before the baby begins to identify maybe their leanings. Correct?
I think you'd have to talk to somebody that does that for a living. I know that
under your bill,
I know that there are certain conditions where it is easier for a child to be raised as one gender versus another. Let me give you an example. There's a condition called testicular feminization, where a child is born XY, 46XY, a boy. But because of an abnormality, the body is unable to receive the effects of testosterone being produced by the testicles. And so the body's external characteristics in the womb develop very much as a female. Now, you could make an argument that that child was born a boy and should be raised as a boy, but the reality is that child has genitalia, which is somewhat ambiguous, but probably leans a little bit more female. And Their testes, although they're present, have undescended. There is no scrotum. And so it becomes, I think, in the judgment of most medical professionals, or maybe all of them, I don't know, that it is easier for that child to be identified as a girl simply because of the anatomical abnormalities that occurred in the womb and up until leading to birth. So I guess my point to you is that I think it's pretty rare to have a circumstance where it's literally 50-50 on either side, totally ambiguous. Can it happen? Yes. But what I think you'll find is a lot more common is a situation where the patient leans one way or the other. And so then that's an easy conversation.
In the sense that it's...
So in other words, what I'm saying is let's sort of not get, I don't want to get into the weeds of the 1 in a million circumstances here.
Sure.
We have a much bigger population to deal with here.
We do. And in that circumstance where there's intersex and the doctors or the parents pick, it may not correspond with as that individual grows and the gender in which they identify. So you may pick that they should be a girl based on medical science, but they may feel as if they were male. Those children don't get to participate in that process, correct?
I think the more important question to ask here is how do they feel when they're 20, 21, 24?
Okay.
And I'm going to say to you that I think a major problem that we have in this country with the science and the direction that medical organizations have gone in this country, which is not supported elsewhere in the world, by the way, is the fact that there's an overwhelming reliance on the child's internal perception of themselves at a young age when their mind has not fully matured. Yeah. And as you know, as a lawyer, we don't let kids sign consents for medical and surgical treatment. We don't let them vote. We don't let them drive. They can't even get tattoos. And so the thing is that is...
They're not supposed to.
Well,
that happens quite a bit.
It's not lawful for them
You're right.
to do, right? So the thing is, what concerns me is the fact that this conversation seems to completely neglect the fact that an adolescent's perception of self is probably not the best reflection of who they'll be when they're 25. And I think that's what this bill attempts to address. That's why this bill sort of, it says what it says, but it's very silent about what a person can do once they reach the age of majority.
I, too, appreciate this medical discussion. And I also think you and I both appreciate each other's commitment to faith. And I hope that we can continue an honest discussion about what may be medically appropriate or not appropriate. But I can also say you may not remember the moment you found out you were straight. But I remember the moment I knew I was gay. And it's because society told me there was something wrong about me. If you haven't been a child in an adolescent state that knew, consider from some of us on the dais. Kids know. It's hard. And I hope that this state will find a way to make decisions that is compassionate and is protecting of all Texas children. And I look forward to continuing the dialogue.
Thank you, Representative.
Representative Price.
Thank you, Madam Chair. Chairman Oliverson, thanks for bringing the bill. I wanted to ask you a quick question about some references to medical studies and how that's handled both domestically and in other countries, because I think we'll hear a lot of testimony today. I anticipate there'll be a lot of references to that throughout the day. We did last session, when this bill or similar bill was heard before the committee. Can you kind of set the stage, if you don't mind, to the extent you are familiar with maybe the differences between the studies conducted here and the way the issues you and Representative Johnson were just discussing are handled in the United States versus what that may look like in other countries who have studied these issues as well, and just kind of set the stage so that we can filter what we hear coming forward throughout the day?
Sure, I think that's a great question, and there's a lot of direction we can go with that. But I would say a couple of observations. I would say that By and large, at this point, European countries who have been down this pathway for longer than we have, in a more cohesive medical practice setting because of their single-payer health system, have one by one done a right-about face and called for a moratorium on these treatments for adolescents. Not to say that they don't still provide care for folks who are transgender, but to say that we're no longer providing medicines and surgeries to change a child's gender. And this is born out of concern that that the science supporting that this is a good thing is at best of very poor quality. B, there is a growing list of harms that are being recognized that weren't appreciated initially when the Dutch study came out. But now it is well known that there are things other than the development of secondary sexual characteristics that are occurring during puberty. And when you don't allow puberty to proceed normally, many of these it become issues later in life. And I think you're going to hear that from some people today who that is their life story, unfortunately. But generally speaking, from a scientific standpoint, I would say that, you know, one of the problems that I have, and I think others have, many others have, with the literature in this area is that there are few, if any, randomized controlled trials. There's a lot of data that's being bandied about as if it's authoritative, but the reality is you go back and you look at the methods and you find that it was a self-reporting survey, where essentially you self-selected a population that took the time to fill out the survey. And then you make all kinds of conclusions based on that. And friends, I got to tell you, that's literally the worst science of all. I mean, even as lawmakers, we would look at an internet poll and say, okay, is that a scientifically based thing? So, you know, we're looking at very significant quality issues. And I would point out that even organizations in America like WPATH, have pointed out that many of their, quote, strong recommendations are based on studies that they self-identify as being of low or very low quality. So this is kind of, you know, I don't want to say it's make it up as you go along. I don't think they're making it up as they go along. But it has evolved into somewhat of an echo chamber where there's a conscientious desire not to listen to dissenting scientific viewpoints and contrary information, and instead to just reinforce the narrative. And that's really problematic. And by the way, that is a compelling reason why this is good legislation, is you have a community of professionals that absolutely are unwilling to self-regulate. Thank you.
Representative Tinderholt.
Thank you again, Madam Chair. I'd like to kind of get clarity on two things that I kind of glossed over quickly. And it's because it's things that I'd like to see, and I know we're going to work together. I think we agree that therapy for these children is very good versus the surgery. Would you agree with me that trying to psychologically transition these children is harmful to them, along with what the bill already covers?
Representative, there are studies out there that indicate that social transitioning is not a neutral act, and that children who are socially transitioned at a young age have a very, very low percentage of coming to terms with their biologic sex. So I think that, you know, respectfully, I think there's obviously debate about that. I think the effects are a little less well understood than the effects of the medicines. I would tell you as a doc, it's always easier to track the outcomes of side effects that you can observe medically than things that you can observe from a mental health standpoint.
Would you
Those are
say
always
that
harder.
it's harmful to do that, though, to try to psychologically transition a child?
Well, as I said, I would say that these are not neutral acts.
Okay. And then I believe this, and I believe that transitioning a child at the ages that they're being done should be considered child abuse. Would you agree with that?
Well, Representative, I think part of the problem here is that, and I feel very passionately about this, and I want to let everybody know who's listening to this and everybody in the room that I know for a fact because I've visited with them. I know there are many families where this was a decision that was sort of dumped in their lap, and they were given a false dichotomy choice between it's either this or suicide. And I don't think that's fair. The science doesn't support that. It is unconscionable to me that a licensed healthcare provider would put a parent in that position. But I think unless you can figure out how to unwind all of the harm that's already been done to parents by the medical community with regards to moving their children down this pathway, then I don't think that's a reasonable thing to propose.
So what about for the medical professional? Because I'm hearing the same things when I talk to people that were transitioned, that they were literally, and I think we'll hear about it today, that they were literally told, do you want to have a dead child or do you want to have a child of the opposite sex? Would you think that it should be child abuse for the medical professionals that are doing it?
Well, I don't know about child abuse, but I would just say, Representative, that it would fall below the standard of care for medical practice, and it would cost them their license forever and all time when this becomes law.
Thank you for answering my question, sir.
Representative Collier? Oh, no. Representative Jones?
Thank you so much, Madam Chairwoman, and thank you, Dr. Oliverson. I just have a couple of questions, not only as a lawmaker, but as someone who represents and has worked in the LGBTQ community for the totality of my adult career. And I have just a couple of questions. Speaking of reinforcing a narrative, I have heard about several of the randomized trials that you've been speaking about. Could you specifically, where are those trials, from? Because Rep. Johnson mentioned a couple of the need for a study, especially as you mentioned the need, there are quality issues, particularly as it relates to Texans. And what I've heard a lot of is the narratives of things that are happening in other countries, the use of witnesses from other states. And I'd really like to hear about how are we having this conversation for Texans and utilizing what Texans are recommending, because we have several of the medical associations that have spoke against what this bill is trying to do, and still it is being framed as those professionals do not know what they're talking about, that parents are having this decision dumped into their laps. And I'd really like to clear that up and really see where the science is going for Texans, not for people from other states or research from other countries.
Well, Representative, you said a lot, but let me just say in response, so I think it's important so what I was talking about are systematic reviews, not randomized controlled trials. And I'm not trying to be to quibble, but it's an important difference that I want to clarify. So a randomized controlled trial is a prospective study where you establish a control group and a treatment group, and you basically blind the observer and the treaters to which group is which. So essentially, some will get the treatment, some will get a placebo, right? Mm-hmm. And you will observe an effect, and you will see if there's a statistically significant difference between the two groups that could be accounted for by the treatment. The trick in doing that is that you have to design the study in a way, and you have to have an adequate control group, and you have to actually account for any and all potentially confounding variables that could come in. Anything from background, demographics, mental health status, it's everything else has to be completely equal for the study to be valid. Mm-hmm. A systematic review, which is what I'm talking about, is more where we actually look at the entirety of medical evidence across the board, all studies on a subject. That's right. And we analyze that, and we analyze that in several different ways. We analyze the quality of the study. It's important to know that all studies are not created equal. If I gave everybody in this room a magic pill, and half the people in this room said that they felt better, and half the people said that they didn't feel better, that does not a study make. That's right. So, there needs to be a proper method. So part of a systematic review is that, particularly when there's confusion in science, a systematic review helps sort out what different conclusions from different studies say, and it helps weight the results of those studies based on the reliability, based on their methods, the sample size. How good is the data?
That's right.
I know you got data that says that this is beneficial or it's not beneficial, but how good is that data really?
Right.
So that's what a systematic review is. So to your question, so there have been, the ones that I'm aware of are most recently Florida has done a systematic review. But before that, I think the one that everybody probably can easily remember comes from the Cass report, which was the UK, where they basically shut down their child gender modification clinic after that report was published because the systematic review essentially says what I told you, basically, right? But in addition to that, I think the other ones are Sweden, Finland, and Norway. So these are all countries where, you talked about social issues and biases and things like that, and I want to be sensitive to that. So in these Scandinavian countries, this is something that's been looked at for a lot longer than in the United States. And so that to me is important when they can say, well, we're farther down this pathway than you guys, and we have now looked at this in a comprehensive, dispassionate way, and we have concluded that this is not good practice of medicine, so we're saying no more.
Okay, and thank you for that. I really appreciate that. And so as a follow-up to that, are you saying, particularly those who have mentioned favorable outcomes to services and healthcare for transgender youth, that there's not enough data to back up those outcomes that are being reported, or if they exist at all?
I think there's data out there, Representative. The problem is that the data is is very conflicted, and the quality of the studies that everybody's sort of holding up as the gold standard is of very low quality. They're not good randomized controlled trials.
Okay.
Thank you.
Other questions, members? Representative Jones.
So are you saying there's no such thing as gender dysphoria?
No, I'm not saying that, Representative. I want to be clear. I think that that's a real condition. I'm just arguing that medical and surgical treatments of adolescents is an inappropriate treatment, and it's an inappropriate time frame for this.
So I'm just thinking about how, like in family court, and when parents are fighting over their kids, I mean, at a certain age when they're minor, the courts let the kids decide which parent they want to be with, or they heavily consider it. So I do know that in legal settings, they do allow children to make very important decisions about their lives. Along those same lines, I heard you say that and if I'm wrong, correct me, please, that if a trans kid is suicidal, basically that some grown-up convinced them that they were, like, suicidal. Did I hear that right, or I did not hear that right?
I don't think that's what I said.
Okay, because I can think back to this case where I represented a trans woman in criminal court. And when I talked to her mom to try to find mitigating testimony, her mom said when she was in pre-K, when they lined the kids up, and this was before social media, so this trans woman didn't have the internet telling her that she could be something that she wasn't born as. But when she was in pre-K and the teachers lined up the kids to go to the restroom, they put the boys in this line and they put the girls in this line. She always got in the girl line. And so the teacher said something to mom about, well, can you tell him he needs to get in the boy line? And it didn't matter how much mom said, you need to get in the boy line. She always got in the girl line. And of course, she grew up to be a trans woman. And one of the things that she suffered from when she got older, and I don't know that they knew about gender affirming care back then, is that there were all these things that ended up happening to her body because there wasn't gender affirming care, and everybody kept trying to tell her she was a boy. And I know she had attempted suicide because I talked to her mom. She had been hospitalized for that. So I guess my question is there ever, under your bill, is there ever a legitimate diagnosis of gender dysphoria that would allow surgery or gender affirming care of a minor? Because in her instance, she knew as a pre-K kid that she was a girl. And then along those lines, if your answer is no to that, then why are we putting the kids who may not know, or like who maybe didn't want to, they were wrong when they were younger, why are we putting them above the kids who are right when they're younger? And if I need to explain that, I'll try to do better.
I'm going to do the best I can to answer your question. I would say, let's see. You actually said a lot, so I'm trying to think out how to package this.
So did you.
So I think part of the issue here with regards to the diagnosis of pediatric gender dysphoria is that we do know there are studies that are, seem to indicate that given supportive therapy, that a large percentage of these children either come to terms with their biologic sex or they become gay. And so the reality is that I think what I have not seen and what I don't think that the science is very good about right now is figuring out who's who. And I think you're going to, I don't want to take from their testimony, but I would just ask you to, there's people on all sides of this issue, right? But we have a number of folks here who the science got it wrong for them. And I think the most important thing that we have to contemplate as we hear this is that none of this is reversible. And if you guess wrong, and a child goes through several years of puberty blockers and cross-sex hormones, they're not going to get back to square one ever. And so were that the case, were it completely reversible, this might be a slightly different conversation, but it isn't. And the more we learn about this, the more we realize that the secondary effects and consequences of cross-sex hormones and puberty blockers go far beyond just secondary sexual characteristics of the opposite gender.
So if we err on the side of what you say, your argument makes sense. But if you err on the side of they were right? The kids were right. They knew exactly who they were. And they end up growing up, and they're not given gender-affirming care, and they're not given hormones. And now all of a sudden, you have a woman who has secondary, I believe your words were secondary effects where she can't even, she doesn't look like a woman, she doesn't feel like a woman because you denied her access to stuff when she could have blocked it. And so I guess my question is, why is the one subset of people more important than the other subset of people?
Well, I think the first rule of healthcare is first do no harm, right? And I'm going to throw one more little piece of data out there for you to contemplate, because I think it relates to what you just said, and that is that the former president of WPATH, who's one of the world's leading surgeons as far as this, transition surgery, recently said that this epidemic of childhood puberty blockers and cross-sex hormones is actually making it harder to do gender-conforming surgeries. So I know people would think that, well, if I start these treatments when I'm young, then I'm going to conform better to the gender that I want to be. So the impetus is get it started as young as possible. But what I'm saying to you is that the surgical community is coming back now and saying that it's actually the opposite, that it's actually much more likely to be successful if you do end up doing gender-conforming surgery on somebody who's actually transitioning as an adult than if they had never gone through puberty normally. There's just not the, I don't want to get into kind of the, gross anatomics, but basically what she's saying is that there's just not enough to work with.
Well, so I'm going to respectfully disagree with you because you could have dueling experts up here all day. And I'm just trying to figure out why your experts are better than my experts, or the people that you're seeking to represent are more important than the people that I and others like me are seeking to represent. That's because innately that means that we're treating a certain class of citizens like second-class citizens. And I don't think we should be doing that in the state of Texas. But I won't go back and forth with you. I just wanted to have that discussion. Thanks.
And I appreciate your viewpoint. And I do hope that everybody here listens to whatever, all the different perspectives that are presented today, because I think that part of the issue that we've had in this debate has been an unwillingness to hear the whole conversation. So I just want to make sure that I want to make sure everyone's voice is heard too.
I agree, because I believe some people are having unwillingness to listen to my side of the argument. But so that's can go the same. Thanks.
Any other questions, members? All righty. Dr. Alverson will reserve your right to close and begin hearing public testimony. Chair calls Quentin Van Meter, followed by Jessica Zwiener, and then Alan Hopewell. Good afternoon, Dr. Van Meter. I show that you are with the American College of Pediatricians, and you're representing them and yourself. Is that correct?
That's correct.
And you are for the bill?
I'm for the bill, yes.
All righty. Thank you. Please begin your testimony.
First, I want to apologize for my telephone ringing in the midst of this august event, because I had assumed I turned it off carefully, and it somehow escaped that. So my apologies to everyone in the committee and to you, Madam Chairman. I'm here in support of the bill as a pediatric endocrinologist, as the immediate past president of the American College of Pediatricians, which is a professional organization of board-certified pediatricians who feel very strongly about the need for following what has now become the best set of guidelines internationally and including in the United States. The whole premise of gender identity comes from a history with Professor John Money back in the 1970s, and I happen to have been a student of his and was at that time dismayed at his lack of scientific process and in consultation with the parents and obtaining consent. So he experimented on children, and because he did that and things came out badly, Johns Hopkins basically closed his programs in the late 80s. I said, no more. This has been bad for these children. It's bad for our reputation to have done things that are outside the realm of good and ethical science. In 1993, I came across my very first transgender patient, who was then referred to as transsexual. And it was a young man who was born a biologic male. And he decided that he had been born in the wrong body, and he felt very strongly about that. His family was a military family who'd moved frequently. And they came to Georgia, where I practice, and sought out my opinion of what we should do to help this young man transition. And this was just 30 years ago. There wasn't a single pediatric endocrinologist in this country who had ever had a case like that, or who could give me any advice. I went to all of my senior mentors from north to south and east to west, and they scratched their heads and said, we've never seen this before. It's something very unusual. We could possibly advise you on what to put together in the way of a treatment protocol. That was just 30 years ago. If we have these kids that have been living these lives all these years, as the affirmation advocates would say, where were they living and why did they not appear? They didn't kill themselves. We didn't have suicide rates of 3% of our population of children taking their lives all the way through those years. So this is something that's new. It's more of a social contagion that has happened, and the internet has been quite responsible for that. Gender dysphoria is real. It's real suffering. The patients that come to me with gender dysphoria are in pain. They're in a severe emotional pain. But if you look at the big picture, if you look at the Tavistock Clinic in England, when they looked at the kids that were in waiting for treatment, and they had long waiting lists, 0.3% of those children killed themselves. But 0.3% of the children who transitioned killed themselves. This is real hard data that you cannot refute. So the touted suicide rate of 41% that's used to scare parents and scare the kids themselves is artificial and profoundly dishonest, and is causing the parents who want their child to live. There's nothing more that you would do as a parent. I'm a parent of 4 adult children, and I now have 5, almost 6 grandchildren. And if something was, I was told they would kill themselves, I would do everything I could possibly do. The thing to do, the thing that works, the thing that is the standard, should be the standard, is to counsel them through all of the things that they've been suffering with that brought them to that point. Why would they want to take their lives? And as Walt Heyer, a very well-known detransitioner, when he sees these kids, he says to them, "Why do you not want to be the sex you were born? What is wrong? What scares you about that?" And he gets an answer just by being very direct. There is a reason these kids want to be somebody else than who they were born biologically. And we need to address where that came from and help heal the wounds which are there beneath the surface. And in doing so, really do the best for these children.
Questions, members?
I do.
Representative Tinderholt.
Thank you, Madam Chair. Thank you, sir, for being here today. We appreciate you. So it sounds like you agree that mental health assistance is probably one of the most important things that we can do for these children and potentially the parents. Is that kind of what I'm hearing?
Yes, and allowing them to go through puberty. Puberty is a curative process. It's painful. Everyone in this room has probably gone through puberty, I would guess, and remembers acne and teeth that were too big and hair that was curly when you wanted it to be straight, and not being accepted by your peers because of some physical appearance or sense of who you were. And that teaches you lessons of life, and with the family support helping through that and the psychological support, if necessary, to work in the underlying anxiety and depression, you power through this period of time and you end up as a reproductive adult.
So what do you think about medical professionals that are mental health professionals that are transitioning the individual without doing the surgery piece, the ones that are affirming and saying that it's okay and it's okay that you feel that way, and trying to help them transition just short of doing the surgery?
There's a danger in allowing yourself to give the impression that there is no problem beneath the surface. And, giving the child pronouns and letting them dress and act in the manner of the opposite sex gives that child the sense that they are something different than they really are. They're not accepting who they are.
Do you think it's harmful?
It is harmful because it tears apart the fabric of the family. It tears apart the friendships, that when a child comes out and comes to school the next day as the opposite sex and is treated as such, that can't be put back together. It's a Pandora's box. And Dr. Kenneth Zucker, who is really the world's expert in this, has written extensively on the harms of doing a social transition. It is not reversible. You cannot put the lid back on that. Once the child does that, if they come through therapy and they realize that they realign with their biologic sex, they have friends who will never talk to them again. That circle of friends is gone. It causes the child to seek friends, and the place they seek those friends is on the internet. And it's a dangerous, unregulated place, which is very shiny and exciting and draws them further into the pathway of medical and surgical transition.
In your experience, and I know you do the medical side, but in your experience, do you think that someone should be held accountable for actual abusing the child? Because I look at that it's child abuse. Do you look at it that way at all?
I look at it as doing harm to the child. And from a physician standpoint, the thing that drives my ethical and moral compass is doing no harm. You weigh the harms and you weigh the benefits, and you see what's going on. So chemotherapy in patients with cancer, who you know it will take their life, and you have a way to allow them to live, perhaps infertile because of the nature of the drugs, perhaps other disabilities that come along, but thriving in other ways. That's a different circumstance. There are statistics to show that there is more mortality that comes from that. The mortality in the transgender community is hyperinflated and used as a weapon.
So I'm going to ask you a simple question I think you're going to be able to answer very easily. What's a woman?
A woman is a reproductive person who produces ova and from the ovaries, and that is the biologic job of that person to procreate.
And so if someone wants to do what people are calling transition, can someone that's a male transition and become a female, or can a female transition and become a male, or is it more that they try to look like that?
It is the appearance and the social role. You cannot take a biologic male and transfer that person to a biologic female. It's an impossibility, and vice versa for males.
And so what I'm hearing from you over this, I don't want to put words in your mouth, is that what's happening right now is unhealthy.
Yes, I would say so.
Thank you, sir.
Yeah.
Other questions, members? Representative Alverson.
Thank you, Madam Chair. Dr. Van Meter, we appreciate you being here. And I just want to talk a little bit about some of the medications and treatments. You are a pediatric endocrinologist, is that right?
That's correct.
Okay, which I think is important because I know we'll probably have other pediatric endocrinologists that may testify differently. And so I want to make sure that we have this opportunity to get your perspective as a fellow pediatric endocrinologist on some of these things. So with respect to the puberty blockers, let's talk about those first. Obviously, there are certain medical conditions where giving a drug that would essentially for the block puberty, that there are medical conditions where that would be appropriate. That we've treated for a long time, like precocious puberty, right?
That's correct.
Can you tell us a little bit about, so that I know there are a lot of non-medical people in here, but from your perspective as a pediatric endocrinologist, how is precocious puberty different than normal puberty? And why is it appropriate medically to give a puberty blocking drug to a child who has precocious puberty as opposed to somebody who's just experiencing natal puberty at the normal age?
Well, it primarily has to do with preservation of height potential. And you might say, well, wow, is that really that important to the child? But there are cases where when puberty starts early enough, the female patient, and it's a ratio of almost 3 to 1, precocious puberty in females versus males. It ends up shortening their height below ability to reach countertops and drive in a car without being in a car seat. So you're trying to preserve their height potential that's there, that you know from the midparental target height. Also, it's very difficult socially for a second grade female to be menstruating regularly. There's nobody in the classroom, really, essentially no other individuals. And it's something that they can't handle the hygiene. They don't understand it necessarily. It becomes something where they feel like a pariah because they have to excuse themselves from the room. They have to do things that they're distinctly different, and they suffer emotionally because of that.
So when we give a child a puberty blocking drug who has precocious puberty, I know folks want to say, well, we give these drugs to kids with precocious puberty all the time and the effects are totally reversible. And so it's reasonable to conclude that if we just block normal puberty for a period of time, that's totally reversible too. Is that your expert opinion?
No, because it has to do with the timing and the length of time and what happens on the pathway. If you start puberty blockers for in the precocious puberty, there is a limited time frame where you cease the treatment and let the child's system kind of wake back up. At a time when their peers are basically getting into that stage of puberty. So you bring them in socially into an environment where they have no sense that they're different than their peers, which is important for them to do that. But it also allows the body not to have any circumstances that those things that they're not reversible.
Mm-hmm.
Now, the timing of normal puberty, that is to say, after the age of 8 in females and after the age of 9 in boys, early puberty creates some challenges, but nowhere near the challenges that happen to children with true precocious puberty. But if you start blocking puberty in boys at a normal time, the average age for boys is 11 years and 6 months. The average age for girls is 10 years and 6 months, with some variations with very ethnic populations, but very close to that range. If you start blocking puberty, you are stopping the physiologic process of maturation from an infertile individual to a fertile individual. And along the way, all the body systems are preparing to be able to be a fertile adult, to create the gonads, to create the gametes, and then fertilization process occurs. The brain is very dependent on puberty it's expecting the hormones of the natal sex to be able to develop, and if that doesn't happen, there's a period of blockage that development we don't know. We have no idea if that can be recouped. There's no evaluation of that anywhere, okay?
Mm-hmm.
So you talk about doing some studies and maybe doing studies here in Texas. You would have to really do that over a period of about 20, 25, or 30 years before you brought that in as a standard healthcare procedure and knew it was safe and effective. You really can't jump in and do all the treatments in advance and like you're anticipating that you're going to get the result you wanted, because we don't know what happens to the brain if that can be recouped. We do know in precocious puberty that the original study group now has been followed for about 25 years. And fertility is okay. There aren't any birth defects. There aren't any increases in cancers. So those things that we didn't want to have happen at a very young age have been able to happen in those kids. The thing that has been there under the surface is the emotional ability and worsening of anxiety and depression, which we've seen in our kids with blocking puberty, even in the precocious puberty kids. So there are various types of these puberty blockers that are short-term, that last just a month, some that last 3 months, some that last 6 months, and some that last a year or two. And so if you have a child that you're treating, many times we'll start with a shorter acting one, a 3-month product, because if the child suddenly has incredible anxiety and depression, we have an opportunity to cease that treatment and let that resolve. If you use a much longer acting, 1 and 2 year, like the implants of puberty blockers, you're stuck unless you pull that implant out, which is not easy to do.
So, well, let me ask you this. So, I was reading, and it's been a while since I did my endocrinology rotation in medical school, but I remember reading that there are certain medications that you can give that actually suppress the hypothalamic pituitary gonadal axis, where the body is now incapable of manufacturing its own sex hormones. Do we see that when we give the puberty-blocking drugs for long enough, or if we start administering cross-sex hormones? Does that actually, you talked about infertility, but can you actually destroy the body's ability to manufacture its own hormones if you do this for long enough?
It takes a while to wake up. There are, again, no studies to know that we have not looked at that. We really look very closely at that population of adolescent females who have significant delay of puberty. Those girls who don't menstruate by the age of 15, 16, and 17. We are very concerned about their bone mineral density, accretion of calcium into the skeleton, which occurs up to age 25. There is a window where that can happen. And when you take out the years in the adolescent and take away estrogen from a female, you are irreparably damaging the skeleton. And that's pretty, even the affirmation advocates will agree, well, yeah, there is some diminished bone density. It's real, We do not know. We're not following those kids out to menopause to find out if they have severe osteoporosis and fractures as a result of that.
I remember reading somewhere, it was one of the studies I looked at that said that it's also the case that male to female adolescents, those that are transitioning from boy to girl who are on cross-sex hormones, also develop osteoporosis at a pretty young age. Is that true?
That is also true.
So they'll continue to have problems maybe later in life with premature fracturing of bones and even their spine.
We don't know. It's just like theorizing on the side that says I think it's going to be safe and okay.
Yeah.
It's theorizing really to say that you can prove that will be an issue because no one has looked at that.
Okay. And in your opinion, as a pediatric endocrinologist, you've looked over the literature, I take it, as far as this whole area of the gender medicine and sort of what's going on and stuff like that. Is that you have looked? Yeah. I'm assuming you know it quite well. So would it be your contention that American medical organizations in the promulgation of gender-affirming care, are they following the best science in terms of that practice?
They're not following the science. If you go back and look at the root place where this body of information comes from, it starts with the Dutch protocol, which began in about 2000 in the Netherlands, where they took children specifically, not adults, but children, and put them through a longitudinal pathway. Again, it was open-ended. They based it on what they thought would be a benefit. Okay, that's the blocking of puberty comes from the concept of an adult psychologist who said, all of my adult patients complained that they wished they had not gone through puberty so that their body would not have changed. Much like the Representative Jones mentioned, you said that's their wish. That's the adult people said, gosh, if I had just not had my shoulders broad, or I hadn't had a lot of facial hair, or whatever it happened to be that makes it difficult for them to have the persona of the opposite sex in appearance. That was the nidus of, well, let's try it. I mean, that's as deep science as it was. That's a theory. Let's try this. This is back to what John Money did back in the days in the 70s. So that protocol now has been opened up by people getting information about every bit of data, and it turns out that it's a sham. The whole basis, the Dutch protocol, did not improve mental health at all. Did not improve it in any way, shape, or form. Patients were excluded from their patient population because they didn't do well. You cannot do a study, and when you drop out the losers and the ones that were harmed, and you don't count those in your data bank.
It was like everyone that was lost to follow-up essentially
lost to follow-up,
carved out. So,
right. So
they stopped coming for their puberty blockers, and so then we just carved them out. So
right. If you can't really do a controlled trial on this because if you did a controlled trial with an institutional review board, which is a group of independent folks who have nothing to do with financially or socially or with the people that are doing the study, they are truly independent. They would not allow a study to be done, a controlled study where there is any potential for sterilization. It just wouldn't happen because these children, when they go through the whole process, are sterilized. And so they wouldn't even allow a study to be done because it would be not ethical. They would know that the kids couldn't consent. The parents could not really consent to on behalf of their child to say that they want no sexual function whatsoever. They will never have intercourse. They will never have orgasms. They will never have the secretions that their natural body organs would do because they can't create that surgically. They can't replace that or make that happen. They have costume pieces of body parts that are created very, very beautifully with plastic surgery that leave scars behind on other parts of the body where they take tissue to create the new organ systems. But it doesn't work. The artificial vagina doesn't secrete lubrication naturally. It doesn't have the sensation that the vaginal structures and the clitoris has. The artificial penis has no erectile function unless it's pumped up artificially, and it has no sensitivity to achieve an orgasm in a standard fashion. So it basically makes them sexually dysfunctional And that's the thing that is where the harm comes from, is that you're creating a dysfunctional, asexual individual who doesn't understand the pleasures of an intimate sexual relationship with whomever, same sex or not.
And I guess, I think one of the things that troubles me as I've, really done a deep dive into this and looked at it kind of with what you said is that if it were the case that 99% of people who express gender dysphoria as adolescents persisted in that gender dysphoria, whether we treated them or not, that they would essentially be adults with gender dysphoria until such time as they get the conforming, whatever it is, therapy that they need, they're going to be unhappy. But isn't it the case that a majority of these folks that are given supportive therapy and no medicalization end up either coming to terms with their birth sex or expressing same-sex attraction? And what you described is a situation where we create an individual who is dysfunctional in terms of intimate relationships and the ability to have those meaningful, intimate relationships with another person. And like I said, if it were the case that, the vast majority of them, that was essentially their best life, but it doesn't seem like that's the case. Am I just reading that wrong, or is that your contention?
I agree with what you're saying. So I actually think it harms the gay community because it takes away sexual function. If that person is going to resolve their gender dysphoria and identify as same-sex attracted, that person will not have a sex life. It is forever damaged, and that is something that I don't think a 6 or 7-year-old or a 12 or 13-year-old or a 15-year-old can wrap their head around.
Okay. Just a couple more quick questions. I'm sure we're going to hear about some of these medical organizations that are all for the gender affirming model or whatever we're calling it. I guess my question to you is that with respect to what we know about the science that's out there and what we've seen with the systematic reviews that have been done, does the positions put forth by the various medical organizations in this country comport with the rest of the world and the medical knowledge that's known and what's going, or are they kind of out on an island by themselves?
Well, they're working on an island, and it's a very closed community. You mentioned doing a study in Texas, Representative Johnson, and I would say that if you could get the transgender clinics here in the state of Texas to open their books to a wide review of a panel of people from the whole spectrum of gender therapies, from pure counseling to pure medical and surgical intervention, and open up so that there's transparency of every child that comes in, where they're accounted for, what happened to them, if they dropped out, why they dropped out, if they are having psychological problems along the way. We have seen the fabric tear open in St. Louis at the Washington University.
Yeah, we have.
And that has shown what's going on behind the veneer of wonderful happiness on the outside. I cannot get information from gender clinics for patients that come to me for a second opinion. I am not welcome to the data. I'm not allowed to know what's gone on. It is very secretive, and I don't know why there would be secret stuff that my colleagues wouldn't share with me unless they were hiding something specifically. And so it's very hard. There is no dialogue. We ask over and over and over again in the professional societies to which I belong, the Endocrine Society, the Pediatric Endocrine Society, will you open a dialogue with people on all sides of this issue in front of the membership and let them listen to dialogue back and forth? You present your side, I present my side, you bring up a study. If I have concerns about that, I would like to express the concerns about the validity of the study and why. You have the same right to question opinions that other people might have that are opposite of yours, but there is no opportunity for that to happen. None whatsoever.
Are you telling me that a rigorous scientific organization that holds itself up, which I'm sure we'll hear about in the course of this conversation today, as being authoritative and scientific, refuses to have an honest intellectual debate on a topic because they don't want to have that conversation?
It's very true. I have attended webinars for the Pediatric Endocrine Society, to which I belong for almost all my professional endocrine life. And I pose questions in a chat room where you can raise our hand and ask questions. All of my questions are uniformly ignored, as if they never happened.
I think that's probably the most deeply disturbing thing I've heard. I mean, science, by definition, is supposed to be able to withstand scrutiny and challenge, right? I mean,
That's correct.
That is the whole fundamental basis of the scientific method, is the knowledge that whatever it is that we claim and assert to be true and valid, factual, is provable through repeated observation by multiple different reviewers approaching the issue the same way. And what you're telling me is that there are these same organizations which are going to tell us what we should do in Texas that claim to be authoritative have literally silenced debate on this issue and refuse to debate the issue in a scientific manner. Is that what you're saying?
That's what I'm saying. I have applied and registered for the Pediatric Endocrine Society annual meeting in San Diego in May. In the application process, for the very first time, there is a disclaimer that I have to check and sign and agree that if I show any disrespect, whatever that means, to any individual who is presenting, I will be expelled from the society and immediately removed by security from the premises. That is, I had to check it's never been there before, and this year it is.
So if you just disagree, and you say, I think those conclusions are not valid, somebody might say that you're disrespecting them and you have to be removed from the meeting?
I assume that's what that's about.
That's crazy.
It's never been there before, and it's there now.
That jeopardizes the entirety of the scientific method, in my opinion.
I would agree with you 100%.
Well, Dr. Van Meter, I know you had to travel a ways to get here, and we're truly grateful to you for being here and for being courageous and standing up and telling us your side of the story. We certainly want to hear all sides, and so we're grateful for your expertise, and I just thank you for being here today.
Thank you for having me.
Representative Jones? Representative Johnson.
Thank you, Chairwoman. You were just highlighted for your expertise, and you are the same Dr. Quentin Van Meter who around 2020 was actually rejected by Texas court under a Dober standard of not having expertise in gender-affirming care. Is that correct?
No, it was specifically not having any expertise in puberty blockers.
So you were rejected by a Texas court under the legal standard of Dober of whether or not you were an expert in puberty blockers, correct?
I was rejected, but there was a very complex circumstance with a lot of problems with the plaintiff's attorney, who basically, the judge was made so angry at so many points that I had references with me in the courtroom, and the judge looked at me and said, if you don't know those references by heart, you may not present them and go to your briefcase to get them. So it was a very uncomfortable circumstance. But I have subsequently, in the state of Missouri, been held as an expert witness and other court cases since then.
But you have been rejected as an expert in Texas.
In that particular courtroom.
Thank you very much. You were also part of the American College of Pediatrics, correct?
College of Pediatricians.
And the American College of Pediatricians is different from the American Academy of Pediatricians, correct?
That's correct.
The American College of Pediatricians, of which you're a part of, has about less than 1,000 pediatricians as part of your membership?
That's correct.
And the American Academy of Pediatricians has 67,000 members, correct?
That's correct.
Is it you or your organization that have pushed for conversion therapy in the past?
No conversion therapy has ever been suggested.
You have not been one who has advocated for conversion therapy in the past?
Conversion therapy is a very pejorative, invented term that says anything that is done that would allow the patient to resolve their emotional issues and go a direction of mental health. That's banned as conversion therapy. And the American College stands firmly that there should be an ability for somebody who wishes to resolve their emotional issues about either their same-sex attraction or their gender identity, that it should be allowed, the counseling, and counseling should not be banned, as it has been banned in 20 states and the District of Columbia.
Okay. Let's see. In your deposition, you stated that your recognition as an expert in part is your presentation for Teens for Truth Conference, Countering the LGBT Agenda, as part of the Southwestern Baptist Theological Seminary in Texas.
I was invited to speak.
Okay. And in addition, your organization has also said that you've called homosexual relationships promiscuous a danger to children, unstable, and you've claimed that the LGBTQ people's experience results in shortened lifespans.
And the statistics are there. That is the life expectancy of transgender is 50% of the general population.
It's not just transgender, but you've also called out homosexual lifestyle as being a danger to children.
We have recognized some of the risks that are associated with it, that are not associated with heterosexual relationships.
All right. Thank you so much.
Representative Jones.
Thank you so much, Madam Chairwoman. Based on what was just raised, I do have a couple of questions concerning your work with transgender youth. One, have you ever treated transgender youth or would consider yourself an expert on adolescent medicine for trans youth?
I'm not an adolescent specialist specifically. Okay. I'm not a board-certified adolescent, but I am a pediatric endocrinologist and a pediatrician, and those issues are part of the purview of the folks that I treat. I have a very large stable of diabetic patients who are adolescents.
Very helpful. And so my next question, you've mentioned about the hyperinflated suicide rates for transgender individuals. Where did that data come from, particularly if that's not your practice?
The Tavistock data.
Okay.
I mean, that's profoundly, 0.3% is way different than 41%.
Okay.
Now, the Williams Institute, which is a very strong advocate from UCLA organization, has clearly shown that suicide ideation, not completion, is about 20% of the population of autistic children, children with anxiety, children with depression, and children with gender dysphoria. That's their data, and that's not completed suicides. That is suicidal ideation. So that organization already brings the suicide myth down considerably to equal with people who are struggling with mental health issues abroad.
Gotcha. Thank you for that clarification. I appreciate it.
Yeah.
Representative Jones.
Going back to Delbert, so I'm going to tell non-lawyers what Delbert is, because people might not understand why that's significant. With Delbert, if somebody comes in, somebody says, I call this expert, the courts have to determine whether somebody is really an expert. And so Delbert puts you through rigorous standards to find out if you're actually an expert. So if the courts in Texas say you're not an expert, you're not an expert. It doesn't matter what you say. And that's in all areas of expertise. So one thing I want to explain to people who are not lawyers. So I'm gay. I'm lesbian. So, in fact, I'm the first black openly lesbian person in the Texas State House, the Texas Legislature. So should I be able to adopt kids? Because I've heard you don't believe that people like me should be able to adopt kids.
We took issue with the idea that kids that were adopted by same-sex parents were better off, not statistically significant, but better off than children raised in an intact parent, heterosexual family, functional family with both biologic parents.
So I'm a single mom.
Right.
So I guess if I'm a single mom, I can't be a parent either. But I want to get back to my question. Should I be able to adopt kids as a gay person?
I have no issue with that.
Oh, okay. All right.
The point is that to claim science, this is what the American Academy of Pediatrics did, is they claimed science showed a better outcome for children who are raised in same-sex families.
Thanks for sharing.
That was an issue that the American College of Pediatricians said, why is the American Academy of Pediatrics choosing to say that when their data is not based on any science, it's based on anecdotal reports? I take care of kids in my endocrine practice.
Yeah, but I don't want to know that. That's not what I asked. I just asked if I could adopt or not. So just hold on for a second, because I want to hurry up and get through.
Sure.
Right. So I'm asking some very direct questions. So you also don't think I want to be curious, because I think that bias matters when listening to what somebody says. So do you think I should be able to marry as a gay person? Because I hear you don't believe I should be able to marry. I just want to know if that's accurate.
The issue is not whether you should be able to marry, but is that proven to be of any harm in any way to the children that would be in that family. It's a preservation of the family unit. And this is not against single moms. This is why the American Academy of Pediatrics will not touch single moms, because they do not want to offend or harm or hurt anybody who is in circumstances that they could not control.
But my question isn't about whether if I'm gay and I'm married, if it's affecting kids. I don't have no kids. For purposes of this question, should I be able to marry?
It is your choice.
You know what, and I've also heard, because again, I just want perspective in considering your testimony, should I be able to have an abortion? Because I hear you don't think I should be able to have an abortion.
My personal conviction is to do no harm, and the developing conceptus from the moment of conception is a human being.
So that means that I shouldn't be able to have an abortion?
Doesn't mean that at all. It's my personal opinion about whether or not we should do harm to individuals. That's all it's based on. And decisions, these are things that are done in states. The states decide what they are going to do, and God bless them. If that's the law of the state, that's the law of the state, and you're allowed to do the things that are within the purview of the state in which you live. So, I mean, I'm just saying, what's my personal opinion on the sanctity of life is that life is absolutely precious from the moment of conception till the last natural breath.
I believe the sanctity of my life matters as well, but thank you.
Yeah.
Representative Alverson.
Thank you, Madam Chair, and I apologize for double dipping, but I felt like I kind of need to refocus us here a little bit. So, Dr. Van Meter, I understand you're not you're a member of the American College of Pediatricians, and the AAP is. Are you a member of the AAP, by the way, as well?
No, I left.
Did you leave the AAP?
I did.
That's interesting, because I will tell you that less than a quarter of physicians licensed in the state of Texas are members of the American Medical Association, and their membership year over year is dropping by about 10% per year. So it's not unheard of, and I certainly wouldn't want someone to try to say that you're not qualified to be here on the basis of the fact that you left a professional society with which you had irreconcilable differences and moved to another. So that's one thing. Number two thing is, do any of these organizations establish your board certification? In other words, does the American Academy of Pediatrics, are they essentially the board certification organization for pediatricians?
Currently, they are not.
Okay, because that's the same for anesthesiologists, too. We have the American Society of Anesthesiologists, which is an advocacy group and a professional organization for anesthesiologists to come together and discuss issues of anesthesiology. They are not, however, the arbiters of whether somebody has attained the medical knowledge as a qualified expert in a particular subspecialty of medicine. That would be up to the board. And so I guess are you board certified? I think you said you are, right?
I'm board certified in pediatrics and pediatric endocrinology.
So is pediatric endocrinology a separate board certification from pediatrics?
It's a sub-board. It's completely separate.
So you had to go to residency for pediatrics, then you had to do a fellowship in. Do you have to do pediatric endocrinology, or is it endocrinology and then pediatric endocrinology?
It's pediatrics first and then pediatric endocrinology. That doesn't have to be that way, but that's the most standard.
Okay. All right. So, and obviously, so I think what I was hoping we would spend most of our time talking about today is, science and data driven. So I guess my statement to you is, it seems to me as though from the standpoint of organizations in healthcare that are responsible for determining whether or not you have achieved an appropriate level of medical knowledge, you have passed your boards. You are board certified. And I'm not sure that a court really has any role in determining whether a doctor has passed their boards or is qualified or certified.
In addition,
I'm not a lawyer, but that doesn't make sense.
The company that makes one of the puberty blockers has used me as a principal investigator in their clinical studies of puberty blockers.
Yeah.
And they have their own standards of what they would accept in terms of professional expertise. And I was accepted by, the
Yeah, and I mean, look, I'm just going to be honest, and maybe I'm just speaking for myself, but I would trust the American Board of Pediatrics and the American Board of Pediatric Endocrinology light years more so than I would trust a judge in Texas to determine whether somebody's a medical expert. I mean, these are the medical experts, right, that are basically, did your board certification, mine was basically I had to pass a written exam, and then I actually had to have an oral examination where experts in the field literally could ask me any question under the sun related to the practice of anesthesia, and I had to be able to answer it. You know, here's a case, doctor, what would you do? Well, here's what I would do, right? I mean, it's not like it's just you sort of, you know, cut out something on the back of the cereal box and fill it out and turn it in, right?
That's correct.
Okay. And for the record, your position that life begins at conception and ends at natural death is, I'm a physician, and I share that exact same position. So there's at least two of us in the room. Thank you.
Thank you, Madam Chair.
Representative Jones.
In case there was a mishearing or misunderstanding about what I said, courts do not determine whether you've passed your boards. What judges do determine when people call in experts so that people can figure out the ultimate issue in a case, if someone holds himself out to be an expert, there are certain standards that they have to prove in court to determine whether they're an expert or not. So if you show the court and the defense and the plaintiffs get to put on experts to get to put on evidence to show whether they think the person is an expert or not. And so courts determine that. So to the extent somebody thought I said they determine whether you pass the boards, that is not what I said. In court, it is very important to make sure that evidence that is given from experts is reliable and is based on sound science. And that is what the Daubert standard is, and that is what judges do, and they do it all of the time. Thank you.
Other questions, members? Okay. Thank you very much for your testimony. The chair calls Jessica Zwiener. Good afternoon. I show that your name is Jessica Zwiener, and you're here representing yourself. Is that correct?
Yes, ma'am.
And you're against the measure?
Yes.
Okay, thank you very much. Please proceed.
My name is Jessica Zwiener. I'm a board-certified endocrinologist in private practice in Houston. I specialize in initiating and managing hormone therapy for transgender adolescents and adults. I'm speaking today in opposition of this bill. Medical care for transgender youth is life-saving. Transgender youth are at increased risk of a host of mental issues, such as depression, anxiety, or suicidal ideation. The treatment of gender dysphoria is transition. This has been established over years. There are very few interventions for youth that are as effective at reducing depression, anxiety, and suicidality as transition.
Dr. Zwiener, could you get a little closer to the microphone, please? Thank you.
I'd like to start by explaining the process of how we diagnose gender dysphoria and the stages of medical transition. The diagnosis of dysphoria is a very slow, methodical process. Many children do experiment with cross-gender behavior. This is a normal part of child development. For most of these kids, cross-gender behavior is transient. It's a behavior, not an identity. For example, a little boy who wears his sister's hair bows on and off for a couple of weeks, but never has any desire to be a girl. This is not dysphoria. This is not what we're treating. These children generally grow up to be adults who are not transgender. Other children, however, exhibit cross-gender behavior that is insistent, consistent, and persistent. For example, a boy who refuses to wear any clothing other than dresses, who insists repeatedly that he is a girl, and who refuses to cut his hair. If this behavior persists, the child is more likely to be transgender. But this diagnosis cannot be made until the child has been consistent in this behavior for 6 months at minimum. The families of these children generally seek out psychological evaluation at this point. Most parents are not familiar with gender dysphoria, and they need professional guidance to make sure they're doing the best thing for their kids. At this stage, a psychologist's job is to evaluate the child's overall mental health, to determine if they have any other mental health conditions, and to determine whether the child has gender dysphoria. Before puberty, there are no medical interventions to treat gender dysphoria. None. There are no medications, no surgeries. Nothing medical is ever done until the onset of puberty at the absolute earliest. Before puberty, a child is supported as they explore their gender identity. They are not pressured to be one gender or the other. We're not trying to push kids to be transgender. We just want them to figure out who they are. Some children decide to transition socially. Social transition involves choosing a new name and changing their outward appearance to match their desired gender. This is completely reversible. Some children choose to socially transition at school. Some only transition at home. The process is different for every family. It proceeds at the child's pace. Children generally remain under the care of a psychologist for ongoing support and evaluation. Once puberty starts, medical treatment may be considered in consultation with an interdisciplinary treatment team consisting of physicians and mental health professionals. Reversible puberty suppression, or puberty blockers, are an option for some transgender youth. These medications are safe and reversible. They've been used for 40 years in cisgender kids with precocious puberty. They've been used for about 20 years in transgender children. These medications temporarily stop puberty, putting the child back into a prepubertal state. Once the blockers are stopped, puberty resumes. Puberty suppression is used to buy time for the child, the family, and the treatment team to be absolutely sure of the diagnosis prior to starting hormones, while avoiding irreversible and undesired physical changes associated with going through the wrong puberty. Puberty blockers have been shown to significantly improve the mental health of the transgender children who are lucky enough to have access to them. Some children do experience some adverse effects from blockers. These are generally minimal. They are outweighed by the massive improvement in mental health that we see. Once the adolescent is older, hormone therapy with estrogen or testosterone may be started after discussion with the child, the parents, the physician, and the psychologist. The goal of hormone therapy is to develop the secondary sex characteristics of the chosen sex. For example, for a transgender adolescent girl to develop breasts, or for a transgender adolescent boy to grow facial hair. This rarely happens before age 16. Hormone therapy is safe. Initial doses are low. They're increased slowly over a period of time until the blood levels of testosterone or estrogen arrive at the normal range for their desired gender. Surgery for minors is not the standard of care. Medical interventions are the most effective treatment we have to alleviate gender dysphoria. We have plenty of studies about that, which we can get into later. But these treatment decisions are complex, and they're made by parents, they're made by the adolescent in a methodical, thoughtful manner in consultation with an interdisciplinary treatment team of doctors and psychologists. Treatment is slow and steady. At no point in the process is treatment rushed. Patients are never pressured to start hormones or have surgeries. Multiple specialists are always involved. Just as with every other treatment in medicine, it's important to weigh the risks and benefits of treatment against the risks and benefits of not providing treatment for this medical condition. I work with transgender youth and adults every day in my clinical practice. I see firsthand the enormous impact that these treatments make in the lives of individual patients. After exhaustive reviews of the medical literature, every major medical society in this country has endorsed this care. For these reasons, I urge you to all oppose this bill.
Questions, members? Representative Jones.
Thank you so much, Dr. Zwingler. One thing I want to ask, if you could please speak into the mic. Thank you.
Will do.
Could you talk about your experiences providing health care to youth, including youth who will be impacted by this legislation?
Yes, I take care of a number of adolescents as well as adults in my practice. One thing that I think is missing from this debate that we're not seeing a lot of, we focus a lot on the possible harms, on is bone density going to be a little bit affected or something like that. We're not hearing much from the kid. We're not hearing as much from the kids themselves or their families about the enormous impact to kids' mental health. And that is something that I really do want to focus on. I see a lot of children who come in with depression, with anxiety, who their parents are concerned about them. They have withdrawn socially. They're not doing well in school. They're spiraling. They're kind of falling apart. Once they start hormones, many of these kids come back to themselves. Their parents talk about how happy they are to have their kids back. I take a lot of children off of antidepressants because they don't need them any longer. The kids, once they have been able to access these treatments, they're able to just be normal kids without having to think about gender all the time. And it's very gratifying to see.
Thank you. Next question is, how do you feel this legislation will harm the patients that you serve?
I think I'm going to see a lot of mental health issues. Since the legislature's been in session, I've seen a lot of mental health issues already. Patients are scared. They know that these treatments have been very important in maintaining their health and their mental health. I spend a lot of time listening to people try to figure out if they need to leave the state or not. And I'm really concerned how I'm going to face these patients and tell them, we've seen how important and how impactful this therapy's been for you, but now you can't have it anymore.
Gotcha. And my last question, what is a common misconception of the clearly false information that is surrounding the conversations around the need for this legislation?
There's a lot. I think that the proponents of this bill are worried about, genital mutilation of children. I hear that all the time. No one is touching these kids' genitals. There's not surgery done on minors. I'm sure we can find occasional exceptions in extreme cases of dysphoria if children are self-mutilating or something like that. But in general, it's not something that's done. Medical interventions are never done before puberty. And there's no need to protect the 4 and 5 and 6-year-olds who are not affected by any of these treatments.
Thank you so much.
Thank you.
Representative Tinderholt.
Thank you, Madam Chair. Thank you for being here today. What kind of doctor did you say you are?
I'm an endocrinologist.
Okay. And do you teach at all?
I have residents and med students who rotate through my clinic, but I don't teach.
Where is that at?
UT Houston.
So it's a state-funded school?
Yes.
Okay.
I'm not representing them today.
Okay. When you first started, you said when someone has gender dysphoria, you very casually, and I don't know if it was that I could barely hear you, but you kind of casually said, and the answer is transition. Do you really believe the answer is just always transition?
I believe that in many cases, the answer is transition. I don't believe that that's always the case, but I believe it's important to listen to the child or the adolescent, help them work through any mental health issues they have, help them figure out the risks and benefits of social transition and medical transition. But in my experience, it's almost always the answer.
So I'm going to read you a couple of definitions. One is a state of unease or dissatisfaction. The other is holding false beliefs about reality despite evidence to the contrary. Which of those do you think is dysphoria?
Can you say the first one again?
State of unease or dissatisfaction, or holding false beliefs about reality despite evidence to the contrary.
I don't think either one of those appropriately characterizes dysphoria.
So when you look up dysphoria, which the word is used everywhere all the time, and you look it up several places, the generic definition is unease or dissatisfaction. When you look up delusional, it's holding false beliefs about reality. I think that the medical profession is using the wrong term, because when someone has delusional issues, it's okay, we get them medical assistance. You just said that you talked to the child. So if the child thinks there's something that they're not, make it up, whatever you want it to be. I would think that as a medical professional, I could be wrong, that you would say we need to go get that individual mental health assistance because they're in their mind, they have an altered reality. It's what we do. It is what we do in America. We go help people if they need mental health assistance. So in what world has it become okay to block puberty for children, and then as they get older to permanently disfigure? We're going to hear from people that were permanently disfigured as children. So you would say that this is not child abuse, am I correct?
I would absolutely say that this is not child abuse. Gender dysphoria is a recognized medical condition. If a kid comes in and says that they're, I don't know, a horse or something, that's not something that happens commonly enough that we...
Would you do surgery?
If a kid said they were a horse, I would not do surgery.
Like I don't know, because...
May I finish?
Absolutely.
Gender dysphoria is a recognized medical condition. Transgender people have existed in all societies all throughout time. This is not anything new. This is not brand new. We have a treatment that helps these kids have normal mental health outcomes. Kids who are supported by their families and communities and have access to appropriate medical care, they have the same mental health outcomes as their cisgender peers. The goal of treatment for me is not to have a kid who says they're cisgender. It's to have a kid who is happy and functional and able to be a human, a functioning adult without having to think about gender all the time.
I'd like to ask you the same thing I asked the other doctor. What's a woman?
It sounds like an easy question, but it's a complicated question.
Explain it. Tell me the complicated answer.
Okay, so when we look at biological sex, most people fall into male or female. There's multiple different ways to determine what sex you are. We look at chromosomes, we look at internal sexual organs, we look at external genitalia, we look at hormone levels, we look at various different genetic abnormalities, we look at gender identity, lots of different things. For most of us, those things line up. We call that cisgender. Some folks, they don't line up.
No. I asked you about sex. What's a woman? That's a sex, not a gender.
Well,
There's a difference.
Our last expert said that a woman was somebody who produces ova. That definition is very limited.
But you're combining gender and sex in your medical.
Now I'm talking about sex. A woman is not just somebody who produces ova. What about the woman with androgen insensitivity who is genetically XY and doesn't have ovaries, but feels like she's a woman, looks like she's a woman, doesn't
What
realize?
What percentage of the population is that?
It's not common. I don't know what the percentage
So let's just use the regular, everyday, run-of-the-mill, what's a woman? You say it's complex. Let me tell you, I'm retired from the Army. I'm not going to claim to be the smartest guy in the room. But I can tell you what a woman is all day long, and I can tell you what a man is. My 4-year-old son can tell you what a man and a woman is, and so can my 6-year-old daughter. Yet you're a medical professional telling me it's complicated. And then you're the one that is doing these surgeries to children.
I'm not doing any surgeries.
Well, then you're using puberty blockers. Am I wrong?
I use hormones.
Okay. But you can't define a man or a woman, but my 4- and 6-year-old can all day long. They don't even have to talk about XY chromosomes and double 2X chromosomes. They don't have to talk about that. But I have a medical professional that's gone to school for probably at least 12 years and done residency for 4 is my guess. And you can't define it, and that concerns the heck out of me. Can a man have a baby?
Yes.
Please explain that one to me.
There are plenty of transgender men out there.
I said, can a man have a baby? A man.
Yes, a transgender man who feels like a man in his brain, who has taken testosterone, who looks like a man externally, who occupies a male role in society, who is treated as a man, whose driver's license says that he is male. These people sometimes have babies.
So it's not child abuse in your mind. I gave you what delusional versus dysphoria is, and you say it's dysphoria, and so does your medical profession. You've gone to school for a long time. You tell me that, way longer than me, at least 12 years with your residency, probably 16. And you tell me that it's a complex answer what a man and a woman is. I think that says everything that it needs to say. I appreciate you coming today. Fundamentally, we disagree. The science is simple. Gender and sex are different. Medical stuff should be easy when we're defining what a man and a woman is. I'm just
clearly more complex if we're here having a hearing about it.
How is it complex? My 4- and 6-year-old can tell you what a man and a woman is, ma'am. All day long. They can define it easily in the most simple terms. And you tell me it's complex.
Because my patients come to me and tell me what their gender is. They say that I'm a woman.
Scientifically. If a child or a patient came and told you something that was totally off the wall, you would say, hey, that's way off the wall. But when it comes to sex, you're listening to them.
We look at patterns. Lots of people talk about this. Lots of people have this issue.
I'm going to be very respectful, but tell you this is part of the problem. The people that are doing these things to the children and telling the parents that this is acceptable and this is the way it happens, and you can't even define to me. You tell me that it's complex what a woman is. That is part of the problem. It's a serious issue. I respect the fact that you came here today. We fundamentally disagree, and I thank you for answering my questions.
Thank you.
Representative Alverson.
Thank you, Madam Chair. Dr. Zwiener, I appreciate you being here again. I know you were at the Senate, and I appreciate you coming back to testify today.
Thank you.
Okay, so I'm just trying to understand the process here. So you're a pediatric endocrinologist, is that right?
Board certified in internal medicine and adult endocrinology. Adult endocrinology generally treats kids with reproductive issues down to about 14 or so.
Okay, so you're not a pediatrician.
No, I'm not a pediatrician.
Okay, so you're an adult, and just, I mean, to be clear, so internal medicine, I did an internship in internal medicine that focused on medical conditions for adults. It doesn't cover children at all.
Correct.
Okay, just to be clear about that. Okay, but what I'm trying to understand is, so, we've talked a little bit about, studies, and you said if we want to get into that, we can, and I'd like to. Honestly, because I think part of the problem we have here is that everybody's pointing to the same data and asserting it means something different. So what I'd like to know is, you had said in your testimony that these treatments, the puberty blockers and the cross-sex hormones, resolve the gender dysphoria. And I don't know if you said this or not, so you may not have, but just to be clear, do these treatments actually reduce the risk of suicide in these adolescents?
Yes.
And can you quote for me the study that says that?
I can. And one thing to know with studies, you know this, you're a physician, but the way that we come to find out the truth in science is complex. Again, I know we don't like that word. Every study is different. We look at the accumulation of evidence. There are small studies that show that there is no effect on the suicide rate. But when you look at the studies in aggregate, and then you compare that with clinical experience.
Okay, but not clinical experience. I don't want to talk about clinical experience because that's anecdotal. And you know as well as I know that that's poor science because there's no control group when we're talking about anecdotal stuff. So what I want to know is what study I need to know. I want to know author, journal, publication date. What are we talking about here, just so we can be all on the same page?
So there's one by a group at Harvard done by Dr. Turbin, had 20,000, was published, where was this one, PLOS One.
Okay, so Turbin.
He had two, 2020 and 2022.
2020, 2022.
And those are some of our best studies because they are big, 20,000 adults. Most of these studies we look at have 30 children or 50 children, something like that.
Now, I appreciate you because I do think, and I thought I said this in my layout, but I hope everybody kind of hears it. I'm not trying to pick on you or anything, but I really feel like that's something we should be doing as we're going through this conversation because everybody's pointing at the science and saying the science agrees with me. And I want it to be clear as we're talking today about, which authors are we talking about, which study, so that we can all look, because one of the beautiful things about science is it isn't science unless you publish it, right? Which means the world can see, the world can look at your methods, the world can look at your results, and the world can look at whether your conclusions line up with your study design, your materials and methods, and your results, and sometimes they don't, right? So I appreciate that. So I'm going to come back to that, and we may end up having to come back to that afterwards here because I have a couple other questions. But when a young person is referred to you, are they seeing a behavioral health specialist before they come to see you, or are you the one that makes the initial diagnosis of gender dysphoria?
All patients who come to me have seen a mental health professional. Most of them have done that on their own. Some of them, when they call to make an appointment, we say, you have to be in treatment with a mental health professional.
And for how long do you require them to be undergoing mental health treatment before you're willing to have a conversation with them about puberty blockers or hormones?
I don't have a hard and fast rule about the length of time. What's important to me is that I feel comfortable making that diagnosis and that they do have a mental health professional that they have been in a relationship with. I'm the last step in the process. So most of these kids have been socially transitioned for years. They've been in therapy for years. Yeah.
Okay.
I don't have a.
Okay, that's fair. I guess Are we talking a year? Are we talking 6 months? Are we talking 1 month? What are we talking about here between the time in which they sought out mental health and the time in which you begin treating them medically?
Usually it's at minimum a year, but it just.
Usually.
It generally.
What's the shortest period of time?
Honestly, probably about a year. Most of these kids, I'm trying to think. I can't think of anybody that I've seen for less.
Okay, that's
had
fair.
mental health for less
That's
than a
fair.
year.
That's actually encouraging to me because, like the Dutch protocol says it's a minimum of 6 months,
Mm-hmm.
right? And so I get nervous when I hear people say 1 month, 2 months, whatever.
Oh, no.
You would agree that's completely medically inappropriate.
Yes, and I mean, we should also recognize our common ground here. Everybody wants what's best for the kids. I have no incentive to get as many kids to be on hormones as possible. That's
Okay. I get that. Now, to that end, have you seen patients that you've talked to them and you've kind of gotten to know them and you've said, you know what, I don't think you have gender dysphoria and I don't think you belong in this clinic?
Yes.
So you have turned patients away?
Yes, not many, again, because I'm the last step. They have to have gone through a therapist who has diagnosed them with gender dysphoria, but I've had a few when I've told them, this seems a little bit sudden, let's wait a little bit.
Well, let's talk about that because sudden is kind of the thing that I know is being discussed a lot in this issue right now because if I'm not mistaken, we've seen a dramatic reversal in the data recently in the last, 5 to 10 years in terms of the presentation, the sex at birth, and sort of the way this is rolling out. It used to be, as I understand it, was mostly adolescent boys expressing gender dysphoria. Now we have a ratio, I think, if I remember correctly, of like 4 to 1 adolescent girls to boys. Is that right?
Depends on where you're looking at.
Okay, and so I keep hearing about this concept of rapid onset gender dysphoria, and you just kind of rolled your eyes at me, so I'm going to guess that you think that's the fake thing. But I'm aware there are studies out there looking at trying to figure out why is it that we've seen this rapid reversal between girls and boys, because whenever you have a change in a population, that doesn't typically just happen on its own, right?
Correct.
And so I wanted to ask you about that and get your perspective. What is the explanation for why is it now that it's mostly girls and not boys that are coming for this treatment?
So first I want to address rapid onset gender dysphoria. There was one paper published where the author came up with this new diagnosis of rapid onset gender dysphoria. Her study was on parents, never talked to the kids. The parents were recruited from online support groups where they went because their kids were trans and they didn't understand it. They didn't really support it. It was a very biased sample. They never talked to the kids. And if transgender or you think you might have some questions about gender and you know your parents are not supportive, I mean, any good teenager would hide that from their parents.
Sure.
And that's why a lot of the time when you talk to the adolescents, they'll say, no, I've known this for a long time, but of course I didn't tell my mom.
This is also exactly what we saw, or at least what's alleged, with the clinic at Washington University in St. Louis, right? Where this person that was working there, who herself self-identified as an advocate, said that I started to see clusters of young women from the same schools, sometimes the same classes, who knew each other, one after another, identifying as trans. Now, we know, I think, from the Cass review that I think the statement was made that social transition is not a neutral act, right? In other words, that it has an effect on a child's development, right? Just like any other thing, children are impressionable, right? And I think we would be fooling ourselves if we said that there's no such thing as peer pressure.
Right.
Right. And so I also know, well, I tell you what, I know we got to get to that. We'll come back and finish this conversation. I am enjoying talking with you, and I hope you don't feel threatened. I'm enjoying having this conversation.
Thank you.
We'll pick it up after.
Members, we'll be convening on the floor at 2 in just a few minutes. It's my intention to recess. The chair moves that the committee stand in recess until final adjournment or recess of the House or during bill referral if permission is granted. Is there objection? Hearing none, the motion prevails.